Thank you, ma'am. So good morning everyone present here. So today I am going to present a case on an unusual presentation of cystic fibrosis. So a 4-month-old male child presented with loose stool and vomiting for 4 days along with poor feeding, irritability, lethargy and reduced urine output. There was no history of fever, cough or breathing difficulty. On examination, the child was lethargic, tachycardia was present and maintaining saturation at room air. On assessment, the child had severe dehydration. On VVG, it was found that the child was having hyponatremic, hypokalemic, hypochloremic metabolic alkalosis. On doing initial blood investigation, it was revealed that sodium and potassium was decreased along with increase in urea and creatinine that was suggestive of pre-renal AKI. pH was within normal limit but was on the higher side and bicarbonate was increased. And after giving RL correction for dehydration, the sodium and potassium increased mildly along with decrease in urea and creatinine. pH was increased and bicarb was also further increased. On day 3, electrolytes were almost normalized along with decrease in urea creatinine and the child was discharged. On the first day of admission, when we examined for urine chloride, it was 10 along with low fractional excretion of sodium and high fractional excretion of potassium. On day 7, repeating the lab values, we found that sodium and potassium was again in the lowering trend along with increase in bicarbonate. That raises the suspicion for pseudo-Bartter syndrome. On taking further family history, we found that there was previous 2 history of sibling death and one of the sibling who died had CFTR variant and both the parents were carrier for CFTR and elder surviving and affected sibling also had the same variant. And then we have done the whole exome sequencing of the child which revealed likely pathogenic compound heterozygous CFTR gene positive. So Bartter syndrome is actually inherited tubular defect in sodium potassium to Cl- co-transporter in thick ascending limb of loop of Henle and distal convoluted tubule where there is increased urinary sodium and chloride excretion that leads to extracellular fluid volume contraction and impaired sensing of macula densa. That leads to PGE2 overproduction and RAS activation. RAS activation leads to increased urinary potassium and acid excretion and hypokalemic metabolic alkalosis. And PGE2 overproduction leads to increased medullary perfusion and that leads to polyuria. Whereas in case of cystic fibrosis, there is CFTR gene mutation. So chloride reabsorption is impaired and sweat contains high amount of NaCl. In triggers like hot weather, fever, illness, GI fluid loss with diarrhea and vomiting, that leads to NaCl rich fluid loss, that leads to extracellular fluid volume contraction, ultimately leads release of antidiuretic hormone and dilutional hyponatremia. And for RAS activation, there is potassium and hydrogen loss in urine that leads to hypokalemia and metabolic alkalosis. On another side, the chloride depletion leads to hypochloremia and renal, that leads to renal bicarb generation and that also leads to metabolic alkalosis. So true Bartter syndrome and cystic fibrosis related pseudo Bartter syndrome we can differentiate by in true Bartter syndrome there is mutation in sodium potassium to Cl- co-transporter, whereas in cystic fibrosis there is mutation in CFTR chloride channel. Site of salt loss is renal for true Bartter, whereas it is extrarenal for cystic fibrosis. Biochemical picture is same for both, that is hypokalemic, hypochloremic, metabolic alkalosis, but we can easily differentiate between these two with the urine chloride level, where the urine chloride level is normal or high for true Bartter and low urine chloride for cystic fibrosis related pseudo Bartter for RAS activation, and urinary PGE2 will be elevated for true Bartter and normal for cystic fibrosis. Genetic testing is diagnostic for Bartter mutation and positive sweat chloride test, and CFTR genetic analysis is confirmatory for cystic fibrosis. So paired chloride test can easily differentiate true Bartter from pseudo Bartter syndrome in cystic fibrosis. So, if the patient present with hypokalemic, hypochloremic metabolic alkalosis, at that time we have to measure the urinary chloride before hydration, and after giving isotonic saline and after correcting the dehydration, if the chloride still high more than 20 millimole per liter, that indicates for true Bartter syndrome, that is persistent renal loss. And if after hydration chloride falls less than 15, that indicates pseudo Bartter, that is extrarenal loss. So, management of pseudo Bartter syndrome is actually rehydration with half normal saline along with correction of dyselectrolytemia, and salt supplementation has to be given. Fractional excretion of sodium target has to be kept between 0.5 to 1.5%. We have to start the supplementation at 1 to 2 millimole per kg per day, and we can maximum give up to 4 millimole per kg per day along with other supportive therapy. So, take home messages from this is healthy infant with pseudo Bartter syndrome. First, we should think of cystic fibrosis. In pseudo Bartter syndrome due to cystic fibrosis, salt supplementation is crucial, and paired chloride test is the most convenient way by which we can differentiate true Bartter from pseudo Bartter in the easiest possible way. Thank you.
So I would like to request our judges for questions and discussion.
Sagota, I am a little bit surprised about your initial fluid resuscitation. When you actually telling us a child presenting with a hypochloremic, hypokalemic alkalosis, why is your resuscitation fluid ringers lactate? Can you justify?
So, the child mainly presented with severe dehydration, and
Okay.
Now you've shown us the family pedigree, okay?
Yes, sir.
And there were 5 siblings, of which 2 had expired,
Two had
and one of
expired.
them had CF. Another one possibly had CF. You mentioned as a red dot. So, what genetic counseling for future children and subsequent generations did you give to the parents?
For antenatal diagnosis, in next pregnancy, antenatal diagnosis should be done previously, and if the child is positive for cystic fibrosis, then preliminary measures should be taken to
Discontinue. That's what you mean?
no, sir, not to discontinue. We should take measures to reduce his pulmonary infection and other things
Postnatally.
postnatally.
Just last question I will say, in a patient like this, what is going to be your most important treatment? You have mentioned about treatment of pseudobarters, but in a child with CF and pseudobarters, obviously the management actually encompasses something different. What will be your holistic management plan for this child?
Salt supplementation is to be given, and hydration, we should stop exposing the child to hot and humid weather, and should maintain hydration adequately, and salt supplementation has to be checked.
Okay, thank you.
Thank you, sir.
So we have got Susmita Di also, and we have got some time. Susmita Di, Sumantra, if they have any questions, or anyone else in the audience, because we have got. And in the meanwhile, I would request the judges to go up on the podium. Judgeদেরকে podium এ থাকতে হয়, ওটা নিয়ম আছে. So Sumantra just wanted to know, where is it? Yeah, it was depleted. Was the urine chloride low or high? Was it repeated again?
So next I would like to call up on stage Dr. Ujan. She is a second year resident from Apollo Multispecialty Hospital. Please come.
ওটা চলছে না না তাহলে তাহলে জাজদেরকে আবার নিচে নামিয়ে দিচ্ছি।
Hello. Good morning everyone and happy Independence Day. I am Dr. Ujan Basu and today I will be discussing a case where we are navigating refractory steroid resistant nephrotic syndrome, integrating immunomodulation, CRRT and SLED on the way. As we know, refractory steroid resistant nephrotic syndrome in children remains an enigmatic therapeutic challenge with no proven therapy as of yet that succeeds to manage it completely. So, several immunomodulatory therapies and new modalities are used to combat the disease, often resulting in significant compromise in immunity and leading to severe complications. We present a child with refractory SRNS showing poor response to rituximab and having an extraordinary clinical course on the way, battling the primary disease and its secondary complications. Our child presented for the first time with first episode nephrotic syndrome in April of 2022. He was managed with steroids. On August, he had his first relapse, which was also managed with steroids. On October, he had his second relapse. However, this time he was resistant to steroids and deemed as steroid resistant. In November, a biopsy was done, which detected minimal change disease. However, FSGS could not be ruled out. Tacrolimus was started and remission was attained. In 2023 January, he had his third relapse, which was again managed with tacrolimus. In September, again, there was another relapse and this time rituximab was given. He continued with remission till March 2024. Then he had high serum creatinine and hyperkalemia, which was thought to be because of the side effects of tacrolimus. So tacrolimus was stopped and steroids were continued. He had immediately another relapse with hypertension and AKI requiring admission, and he was started on antihypertensive from then on. From May to June 2024, he received 4 doses of rituximab and had gradual remission. He continued to have proteinuria. In October 2024 to January 2025, he received another cycle consisting of 4 more doses of rituximab. In January 2025, he attained partial remission this time with continued 1+ to 2+ proteinuria and was on alternate day steroids. And the proteinuria continued till June. So the first admission that we will delve into is June 2025 when he presented with severe abdominal pain, fever and anasarca. Suspecting spontaneous bacterial peritonitis, empirical antibiotics were started and close management of hypertensive crisis was done. Intermittent albumin and Lasix infusion was given. However, child continued to have gradual rise in urea, oliguria and cola colored urine. A new onset AKI had set in. Hemodialysis had to be started in view of the worsening oliguria, and he received a total 12 cycles of hemodialysis. Ultimately, he had improved urine output and hemodynamic stability. He was discharged home on alternate day oral prednisolone, antihypertensives and furosemide. A repeat biopsy was done and this time it showed focal segmental glomerulosclerosis. In view of the repeat biopsy, persistent proteinuria, recent sepsis, other possible modalities of therapy were extensively discussed with the parents. And trial of LDL apheresis was decided to be the next modality. This decision was backed by several studies, especially by those by Eri Musso et al., where there was beneficial effect of LDL apheresis on refractory nephrotic syndrome due to focal glomerulosclerosis. However, it remains to be a newer modality as there is no extensive long-term data. The trial of LDL apheresis continued from June to July, where he received 6 sessions, each session around duration of 2.5 hours. Average volume was 3.3 liters, circuit was primed with normal saline. Low dose tacrolimus was started and initially it was increased. The second admission was after the 6th cycle of LDL apheresis when the child suddenly complained of diffuse severe abdominal pain, redness of the skin and fever spikes. Tacrolimus was immediately stopped, stress dose hydrocortisone was started and child developed this time hypotension, tachycardia and features of septic shock. He was shifted to the PICU. Inotropes were started, oliguria was there which did not significantly improve on Lasix infusion. Empirical antibiotics were given, and investigations revealed anemia, for which the child received PRBC transfusion, raised acute phase reactants, raised urea creatinine, low albumin, for which albumin infusions were given, coagulopathy, and even an HLH panel was sent, which was not positive. IgG levels was low, so IVIG infusion was given, and IL-6 levels were more than 50,000, and blood culture showed non-typhoidal salmonella. CRRT, in view of the site high IL-6 levels, was decided to be the treatment of choice here for CRRT with oxyris, and for cytokine removal, fluid removal, and to manage the AKI. After 48 hours, repeat IL-6 levels were reduced. Post the first CRRT, the child suddenly had a cardiac arrest, and he was resuscitated with 2 cycles of CPR. He was started on HHFNC, antibiotics were upgraded, and CRRT was restarted, this time with M100 at a low dose and gradually increased, and then it was transferred into SLED, and he received 5 cycles of it. In the next few days, child had increased respiratory distress. X-ray was suggestive of ARDS. Nasopharyngeal swab RT-PCR showed SARS-CoV-2. He required non-invasive ventilations, and gradually it was tapered to high-flow nasal cannula. Over the next 2 weeks, child showed gradual clinical recovery. He was off dialysis for a week by the end of July. He had good urine output this time, but he had to be restarted on antihypertensives in view of raised blood pressure. He was discharged again on alternative prednisolone, antihypertensives, and he is on regular follow-up, requiring intermittent albumin infusion and Lasix with 2+ proteinuria still. This case highlights the complex management of refractory SRNS, and LDL apheresis was used as an adjunct to immunomodulation as a trial to improve the CNI sensitivity. However, the role of LDL apheresis remains debatable, as we could not optimize the CNI dose. And the immunosuppression required for the primary disease predisposed the child to infections, COVID-19 ARDS, also limiting the trial of LDL apheresis. CRRT and SLED were vital in managing the cytokine storm and for the management of the child. Thank you.
Thanks, Sujan. That was a very nice presentation. Just a quick question here. Was the child actually on any prophylactic antibiotics with cotrimoxazole, or you checked the immune dysfunction even before actually, these things happened? Because the child was actually having regular doses of rituximab prior to all these episodes.
So even prior to this admission, before these doses, cycles of rituximab, we did check the IgG levels, and IVIG were given prior also when the levels were low, and that we did not give cotrimoxazole.
Okay.
Your culture had grown up non-typhoidal salmonella.
Yes, sir.
Now, what were the sensitivity patterns?
It was pan-sensitive, sir. Only it was pan-sensitive. It was resistant to fluoroquinolones.
So, did you consider stepping down the antibiotics at that point of time?
Sir, actually, this was the one that came on the blood culture, but since the child was so immunosuppressed, we did think that there might be other pathologies, especially because he was having invasive lines. There was a perm cath, there was a dialysis line, so we did not...
You did not consider
we
stepping
did not
down.
taper down, no, sir.
And later on you had to step up further?
Yes, sir. After the cardiac arrest, we did step up further.
And how frequently were you monitoring your electrolytes?
We were monitoring the electrolytes every day, sir. Every day, sometimes when the child was critical, even 12 hourly, few days.
Sampling so frequently may not be an easy job.
Yes, sir. In this case, since a child was of a nephrotic syndrome, which is a hypercoagulable state, so it was quite difficult to manage a line. So there was a pick line that was in situ, and one of them was mainly there for the sampling as well.
Thank you.
Yeah.
This question not to you, question to all stalwart of nephrology. So why is a tech talk? So in a tech talk, why cyclosporin was not used? It's a very well tolerated drug.
Actually, sir, since it was a 6-minute session, I did not involve everything because it would be very difficult for me to explain these. But cyclosporin was used prior to the admissions, when he was on outpatient department, cyclosporin was used.
I encountered similar case, and patient still admitted in our hospital 4 months over, and the doctor who handles it knows how difficult the situation is. how difficult the situation is. Today your 20% albumin, tomorrow again albumin 0.9. So it's very difficult, it's 4 months still on, and we encountered similar tech talk, and we got a very good result with cyclosporine, well tolerated.
I
So
think,
this,
let
just
Rajiv
for,
actually answer that, but
so-
I think when it comes to choosing between CNI, there is not much difference. Often it's actually, depending on the choice of depending on the patient's age, family's
No, I
preference,
mean,
and the nephrologist's choice, I will say.
So I would request you to again go back on the stage. এটা কাজ করছে আর ওরা বললো কি যে ফটো তুলতে নাকি সুবিধা হয় ওতে। আর so this child was initially treated on
Thank you, Ujan.
cyclosporine. The child was initially treated with cyclosporine. As Ujan said, it's a long story. Initially responded to CNI, then relapsed, then became CNI resistant. We gave rituximab. First time responded very well. Again relapsed. Second time again rituximab, responded very well with ongoing CNI. Third time became completely refractory and did not respond.
Thank you, sir. So the next case presentation will be by Dr. Shreya, who is a first-year resident from Institute of Child Health,
Samyukta,
Kolkata.
already your time is over, so you should have to cut it short.
Yes, sir.
The success of the program depends upon in time.
Okay,
So
sir.
make it short, already
So-
6 minutes extra we are giving, it's not possible, we'll call up the second session.
Okay, sir. So next session, from the next session presentation, kindly stick to your time and try to finish it within 5 minutes.
Good morning, everyone. Myself, Dr. Shreya Misro, first year resident from ICH. My case is when traditional blind faith turns into curse. There is ample evidence of alternative medicine being widely practiced as traditional health remedies in our country, but this can be potentially life-threatening in various circumstances. One such evidence is conventional ichthyotherapy, an ancient heritage-based tribal practice in India where use of fish remedies by tribal communities is being followed via verbal knowledge across generations. Irrational consumption of fish bile extracted from fish gallbladder to apparently improve vision and correct rheumatism has led to documental fatalities by causing dose-dependent toxicity. So fish bile can lead to hepatotoxicity, nephrotoxicity, toxic myocarditis, and multi-organ dysfunction syndrome. Now, a 7-year-old male child who was fed raw fish bile by his grandmother, and that was being traditionally practiced in their country, but nobody in their family developed such symptoms. Child complained of nausea and pain abdomen within hours, which was followed by 4 to 5 bouts of non-bilious, non-projectile vomiting with excruciating pain. Urine output was progressively decreasing, vomiting and pain abdomen persisted, so the child was referred to ICH. Vitals on admission, he was encephalopathic, maintaining saturation in room air, no evidence of any shock, but he was icteric on per-abdominal examination, no organomegaly, but urine output was decreased less than 0.3 ml per kg per hour. So on admission, we went on to do the relevant investigations which revealed hyperkalemia, increased urea, raised creatinine, elevated liver enzymes, suggestive of transaminitis, metabolic acidosis, but CRP was less than 1, which is suggestive of a non-infective etiology. Phenaphyuria was, phena was 3%, phyuria 35%. Urine RE, we saw 20 to 30 RBCs and 2 to 3 pus cells. USG KUB was normal other than mildly raised renal cortical echogenicity. We went on to do a POCUS, where we saw IVC was not collapsed and there was no evidence of any volume depletion, no B lines in lung, chest X-ray was normal. So management, we started with initial hemodynamic stabilization and supportive care was given. Immediate catheterization was done for strict monitoring of urine output. We went on to do an ECG to rule out any cardiac arrhythmias. Fluid was started according to the AKI regimen. Correction of dyselectrolytemia, hyperkalemia was corrected, and after cardiac stabilization, sodium bicarb was added for the correction of metabolic acidosis. Antihypertensives and broad spectrum antibiotics added,
As hyperkalemia persisted with uremic features and gradually the child developed signs of fluid overload which were initially absent, urgent hemodialysis was started. The child required 4 cycles of intermittent hemodialysis. Serial monitoring of serum creatinine and liver enzymes were done, which showed gradual reduction and clinical improvement of the patient. So this is the outcome analysis where we can see the monitoring of hepatic and renal functions were done and complete resolution of AKI by day 10 of admission, and the child was discharged with normal kidney and liver function by day 12 of hospital stay and is now well on follow-up. So these are some of the case reports with similar presentation as our case. Now, the main toxin causing this kind of fatal AKI is heat stable C27 bile alcohol sulfate ester toxin cyprenol sulfate, and we can see this the table showing that how traditionally in generally the tribal communities and the folks in the rural areas, they consume different parts of rohu fish and carp fish as a remedy to improve their health and vision, which can be potentially life-threatening. So the pathophysiology of the fish bile toxin mediated damage is that the cyprenol sulfate, it blocks the cytochrome oxidase and causes direct damage to lysosome, leading to proximal tubular necrosis and hepatocyte necrosis with interstitial edema. So the discussion and learning points from our case, the incidence of acute renal failure in fish bile poisoning is 55 to 100%, with 70% of the patients requiring hemodialysis, and mortality has been reported in 18% cases. Though uncommon, but fish bile toxicity can lead to multi-organ dysfunction syndrome. So the key learning point is that early intervention via clinical suspicion and history is extremely crucial, and health education to raise the public awareness to discourage such folk practices is essential. Thank you.
Thank you. It's a very novel case, I will say, because it's normally we don't come across poisoning like this in this part of India. Now, what made you actually suspicious about this particular thing? Because there is no toxin or any blood test that you have managed to do in this patient. And is there any specific antidote? This is the second part. And how much of the fish bile is actually thinking of lethal or can give rise to this kind of renal damage?
Sir, from the history we came to know, because the history was given by his mother, she told that it was being traditionally consumed in their family, and the grandmother gave it to the child, and she has also given it to her children.
The amount?
Sir, amount, there is no, in the animal studies it has been seen that 2.6 milligram per 20 gram in mice, but no documented lethal dose is available. No studies have been done to document the lethal dose in humans, but in animal studies have shown the lethal dose to be 2.6 milligram per 20 gram. And there is no, we manage the patient symptomatically with hemodialysis and other supportive care, but there is no specific antidote.
Okay, no question. I think we will go to the next. Yes.
So next case presentation will be by Dr. Shahiti. Next, Dr. Ritodip. Sorry, next presentation is by Dr. Ritodip. He is a second year resident from Institute of Child Health, Kolkata.
Good morning, I am Dr. Ritodip Nandi and I am going to present a case report on steroid resistant nephrotic syndrome in a dizygotic twin with multicentric carpotarsal osteolysis syndrome due to a sporadic MAFB gene mutation. Now, MCTO or multicentric carpotarsal osteolysis syndrome, it is an autosomal dominant disorder which is characterized by progressive osteolysis of bones, especially carpal and tarsal bones, which result in deformity of the limbs. Associated other anomalies are facial dysmorphism, corneal opacity and craniofacial anomalies. Now, Kidney involvement is common, which may range from mild to moderate proteinuria and may progress to kidney failure also. Till date, only about 60 cases have been reported in literature. Our case report was 5 years 6 months old female dizygotic twins with global developmental delay presented with nephrotic syndrome with the onset at the age of 2 years and which was later steroid and cyanide resistant. On examination, both the children had triangular faces, chubby cheeks, low set ears, micronathia and protruded tongue and eyes. These were the images of the two twins. Now, the upper limbs were short with ulnar deviation of wrists and flexed flexion deformity of the elbows, and lower limbs also had flexion deformity at ankle joints. These were the image of the hand. Now, upper limb X-ray revealed absence of carpal bones, focal osseous destruction of left distal first metacarpal and bilateral destruction of distal humeral epiphysis along with posterior dislocation of ulna, and there was similar destruction of tarsal bones in the lower limb X-rays. We can see that there are no carpal bones in the X-ray. Now, serum creatinine was 1.5 with an eGFR of 27 and 0.5 with an eGFR of 81 of the two twins respectively. The renal biopsy of the first twin was done, which showed focal segmental glomerulosclerosis, and the twins gradually went into CKD after 6 months and 1 year of presentation to us respectively. Now, whole exome sequencing of the first twin was done, which showed significant variant in MAFB gene, which confirmed the diagnosis of MCTO. The parents were asymptomatic, both the parents, and we did a genetic screening with Sanger sequencing, which came as negative. So, it was a sporadic mutation. Both twins were started on ACE inhibitors and the first twin on cyclosporine also. As they went into CKD, immunosuppressants were stopped, CKD management was optimized, and now they are on regular peritoneal dialysis. This was the report which showed MAFB gene mutation. Now, MCTO is a very rare genetic disorder which primarily involves musculoskeletal system along with other organ systems. Both of our patients had musculoskeletal and renal at presentation only. Renal involvement was worst in the first twin. MCTO follows an autosomal dominant inheritance, but sporadic mutation is also reported. Bisphosphonate and denosumab have been used to slow down bone resorption, and antiproteinuric agents such as ACE inhibitors and ARBs can also be used. A single case report has showed benefit of cyclosporine. Now, why does MCTO affect kidney? MAFB is a basic leucine zipper transcription factor which is expressed in both developing and mature podocytes. It is essential for podocyte differentiation and food process formation. Thus, MAFB may have a protective role against podocyte injury. So, in MCTO, MAFB mutation occurs, so it may present with nephropathy in 55% of cases, ranging from proteinuria to CKD. Now, what are the learning points from this case? Any clinical clues like limb abnormalities with or without facial dysmorphism in a child with SRNS should prompt radiography of the limbs. If there is reduced or absence of carpal and tarsal bones, it is characteristic of this disease and it can be confirmed by genetic analysis. Genetic counseling and multidisciplinary approach is beneficial for management. Thank you.
Thank you, Ritodip, for presenting this case. Tell me something, because what I remember seeing these children in ICH before, as well as from your presentation, was there any difference between the nephrotic syndrome in these two children? Because one of them you started on cyclosporine, the other one you straight away went into ACI. So obviously there was some difference in the clinical presentation between these dizygotic twin. The second question is, let me finish. Second question is, you mentioned about genetic counseling and multidisciplinary approach, and you also mentioned that parent Sanger sequencing didn't show any specific thing and only a variant of uncertain significance. So how you go about genetic counseling for the hapless parents? So two questions here.
So the First twin at presentation had high creatinine, low GFR. So and the second twin did not have that much of lowering of GFR. It was 80 at presentation. So we went for renal biopsy of the first twin, and which showed FSGS, and so we started AC inhibitor and cyclosporine. And CKD also, the first twin went into CKD within 6 months. The second twin took 1 year from presentation to ICH to 1 year to go to CKD.
So one child already had CKD as well as proteinuria at presentation, that's why you didn't go.
Both
of them had CKD.
Both the child had SRNS when they came to us.
But one child also had CKD.
The first child went into CKD after 6 months.
Okay.
And the second child after 1 year.
Okay. And regarding genetic counseling?
Genetic counseling, sir, it was a sporadic mutation, so we can't go for genetic counseling here. We can do chorionically.
So what you are going to advise to the parents? Because this is a very hapless set of parents, I remember.
So in next pregnancy, we can go for amniocentesis or chorionically sampling or free fetal DNA, because the parents did not have mutation, so we can't go for genetic testing of the parents.
Okay.
What do you think is the long-term outcome?
Long-term outcome is they are on daily peritoneal dialysis.
And another simple question: since they were twins, okay, and they presented probably at same points of time.
Same point they presented.
Okay, and they had those congenital defects in the limbs. So at what point of time during the chronology you suspected that this could be the etiology behind the nephrotic syndrome, MCTU?
Sir, we had facial dysmorphism, limb abnormalities. So, to be honest, we didn't suspect MCTO because it is only very rare.
One of the very
so,
rare
we sent the whole exome sequencing and it came as MCTO of the first twin.
Then
we
finally
did Sanger of the second twin.
Sorry, I think we should move on.
Thank you, sir.
Thank you, sir.
So next I would like to call upon stage Dr. Shahiti. She is a DNB resident from CMRI hospital.
Good morning, judges, mentors and colleagues. I am Dr. Sahiti Adhikari, a second year DNB PGT from CMRI hospital. Today I have the privilege to share an extraordinary journey of a 17-year-old girl who was diagnosed with a renal tubular disorder in early childhood. We will focus not only on her medical aspect of her condition, but also on her journey to living a fulfilling life. Her story started at just 3 years of life with refusal to walk, displaying progressive lower limb deformity with habitual dislocation of the patella. There was disproportionately short stature with widening of the wrist and bilateral knock knees. The skeletal features were strikingly abnormal, like the genu valgum, metaphyseal cupping and fraying, and there was persistently low phosphate level and markedly elevated ALP. So this nudged us to the diagnosis of the rickets. There was low serum calcium with a low 25-hydroxy D, and the serum parathyroid was raised. So all these features are consistent with the nutritional rickets. We started her on calcium and vitamin D supplementation, which normalized the calcium 25-hydroxy vitamin D and parathyroid level. But the radiological features were unyielding due to these supplementation, and there was a persistently low phosphate with a high ALP. So further workup was done and urine analysis unmasked the persistent phosphate wasting with a low TRP and TMP GFR. So we have a child with rickets, and we were able to exclude metabolic acidosis and chronic kidney disease. With supplementation, the serum calcium, 25-hydroxy vitamin D and parathyroid hormone normalized, but there was persistently low serum phosphate level. On further workup, the urine, there was persistently leakage of phosphate in the urine. We were unable to do the serum FGF23, but we were able to rule out hereditary phosphatemic ricket with hypercalciuria and Fanconi syndrome. So here we are left with hereditary phosphatemic ricket and acquired form of hypophosphatemic ricket, which is likely low at this age of life. So our genetic journey began. Hypophosphatemic rickets is the most commonest cause, X-linked dominant, but both the parents were clinically unaffected. So what was this? Is it an autosomal recessive or a de novo mutation? Early whole exome sequencing was negative for specific phenotype, but our clinical suspicion was so strong. So on further discussion with the geneticist and detailed evaluation including CNV pipeline analysis, the result was that there was a heterozygous exonic deletion from 16 to 20 of the FEX gene, and the report was likely pathogenic. But confirmation would upgrade to pathogenic if parental test confirmed de novo variant. So treatment was not easy at all. There was careful calibration of the phosphate and calcitriol supplementation with balancing out the risk of hyperparathyroidism, GI side effects and increased calciuria. We were able to improve the symptoms, and it's a success that we were able to correct the ALP to upper normal level and phosphate to the lower normal range. She required regular blood and urine testing, and dose of the calcium and 25 hydroxyvitamin D was adjusted accordingly. She required dental follow-up, hearing and orthopedic assessment from time to time. Burosumab, it is an anti-FGF agent which is associated with high cost factor, around 20 to 50 lakhs per year, but it's still unavailable in India, and the effect of growth hormone on final height of these children is not yet known. So other teams involved were endocrinologists, dental, ENT, orthopedic and genetics. Orthopedic intervention was done on completion of the skeletal maturity. She is now under a very big pill burden, that is 5 tablets of phosphate and 6 capsules of calcitriol per day. But we are happy that we are able to normalize the other blood parameters, but the serum phosphate was still low and she continues to grow on the 3rd percentile. She is having a good school attendance with good academic performance, independent mobility. She cycles to school daily with no musculoskeletal pain, improved limb posture and self-image. She is actively participating in every physical activity. So our stepwise approach to is very important for initial diagnostic dilemma, and X-linked hypophosphatemic ricket requires careful monitoring and multidisciplinary teams. And symptoms may worsen in pregnancy, so there is a 50% risk to progeny. So I would like to say that all chronic pediatric disorders, quality of life should not be viewed as an afterthought. It must be the central goal of the treatment. Thank you.
I'm sorry, did I miss? Can you tell me how does burosumab work? What's the mode of action of burosumab?
So burosumab is an anti-FGF agent. So it will block, decrease the serum level of anti-FGF because the main culprit is increased in level of this.
Increase in level of?
FGF 23.
So what is the result? What happens to the phosphate?
So phosphate will increase because the renal leakage will decrease, and serum level mein phosphate will increase and bone mineralization will improve.
And any action on 125 OH2?
Sir, actually FGF 23 blocks the blocks 1-alpha hydroxylase. So the active vitamin D will increase. So ultimately bone mineralization.
But you have not used burosumab in this
No, sir,
patient.
it is not
It
available
was
in
only
India.
supportive treatment and holistic approach. Yeah.
Yes, sir. Yes, sir.
Yeah.
With conservative
Thank you.
management.
Thank you.
Thank you, sir.
So,
Thank you, sir, for the session, and thank you the residents for their case presentation. So the result of this case presentations series will be announced pre-lunch, and I would like to request our judge and chairperson to kindly collect their memento from the memento corner.
yes, please.
Thank you very much. The organizers for giving us this opportunity.
Amitavo, Pahari and Arun, please go there and collect your mementos.
Thank you very much,
Take the
Professor
mementos.
Kundu. Thank you,
Dr.
organizers, for giving us
Aruprai?
this opportunity.
Aruprai is there. So next I call upon the next The transforming clinical practice, the era of genetics and genomics. This will be done by Dr. Ratna Puri from Gangaram Hospital. May I request Dr. Dipanjana Datta to kindly come to the stage and introduce her and start the proceeding. You have 20 minutes at your disposal.
Thank you, sir. Thank you, everyone, and wishing everyone a very happy Independence Day. It gives me great pleasure to introduce ma'am. She has been an inspiration for all of us who are in genetics. So, Dr. Ratna Duapuri ma'am is Professor of Genetics and Chairperson and Institute of Medical Genetics and Genomics, Sir Gangaram Hospitals, New Delhi. Has over 2 decades of experience in genetics and genomics. She holds a MD in pediatrics and a DM in medical genetics and has received multiple prestigious awards, including the Dr. I.C. Verma Outstanding Researcher Award in 2019 and Dharma Veera Award for Excellence in 2010. She has spearheaded the Indian Undiagnosed Disease Program, introducing whole genome sequencing pipelines for structural variants and repeat disorders, leading to identification of novel genes. She is actively engaged in rare diseases and has been leading the Undiagnosed Disease Network International from India, the Rare Disease International Lancet Commission, the WHO Rare Disease Group, and she has contributed to the national policies through the DBT and ICMR committees, helped to initiate the NB Medical Genetics Program, and coordinated various national webinars. As a clinician and researcher, she has more than 200 publications and has been instrumental in establishing rare disease patient support group and advancing standard of care. I welcome ma'am.
Thank you so much, Dipanjana, for a very warm introduction. And at the outset, I'd like to thank the Institute of Child Health for inviting me here for this very prestigious meeting. And I've been asked to speak on transforming clinical practice, what is the era of genetics and genomics, and I thought we'd start with this. When I was doing pediatrics, that's what genetics was all about. It was the then. But now we have it in every core. You've seen the presentations in the first half of the meeting. They were predominantly a genetic etiology. So we just need it all. And to start with, genetics and genomics, they are two slightly different things. Genetics is the branch of science that deals with the study of inheritance. That's where it started, the genes underlying it and their functions, whereas genomics is studying our genome and the huge amount of data that's generated. And when we talk about medical genetics, which is what we all do, it is incorporating all this into the care of the patient who comes into the clinic, as we've seen in the first half of today. And bringing everything within a concept of the volumes of books. Those are our 23 chromosomes. And within the books, each alphabet is the DNA. You know, the 4 alphabets which we all are made of, the ATGC, and there are 3 billion of those. And when they come together to form a sentence, that is what the DNA is, and the genes reside within that DNA. And so as it is complex reading the volumes of books, even when we read our volumes of Nelson, every time you pick up something new, it is so packed. And so the genomic architecture is something similar. But over the years, there's been a paradigm shift in technology. Whilst initially we saw things just one at a time in 4 different colors of ATGC, with the completion of the Human Genome Project nearly 2 decades ago, we have a huge amount of data that is generated in gigabases. And that's what it looks like, the dots. They are still 4 colors, but it is extremely dense. And so with the exponential power of computers and analyzing the data, it's actually transformed our care inside the clinic with inclusion of genetics and genomics. You heard that we didn't suspect it. The report told us, and we go back and look at those features in the patient, and that's how we get our answers as to why our patient has that particular phenotype. And so is it very exclusive? Not at all. Genetics is very, very inclusive. It spans all specialities in the clinic, and it spans across all times of a lifetime. And so right from the preconception to the newborn period, to a pre-symptomatic testing, pharmacogenomics, and then a post-symptomatic testing either in childhood or in the adults. And so the menu of genetic tests is ever expanding, and you can see that we started years ago. When I started genetics, we probably had the first two, just the karyotype and the fluorescent in situ hybridization. And the rest has come over in the last 2 decades. PCR tests were there, but applications of that PCR have evolved immensely. We have MSMLPA, we have microarray, which looks at the chromosomes in detailing. We have the various metabolic tests. It's not only the DNA-based test. The DNA-based test confirms, but we have to put together everything to decide what is that DNA test that we have to use, and I'll tell that over the next few slides in my talk. And finally, what has revolutionized care is the next generation sequencing, which is the clinical exome, looking at a little bit of our full hand, which is the genome. The finger is the whole exome, and that's all we understand about our body, because that's the coding part of our genome. And then if we want to look at just some part of it within that, which are the identified genes, which of 20,000 genes that we have in our human body is just about 6,000, that's the clinical exome. And so we went about to do some work in patients who had intellectual disability but had normal chromosomes. And here we identified a yield of 53.7%. And so what? It impacted the long-term management in about 14% of these patients, and it also went on to look at the reproductive outcomes for the next pregnancy in about 21.4% of the patients. And I'm really privileged to say that this work is published in the Indian Journal of Pediatrics, which started right here in ICH under the supervision and leadership of Dr. K.C. Chaudhary, and Dr. Ghosh just informed me, I didn't know that this is where it had started. Now when we talk about hypoxic ischemic encephalopathy, 90% of things that happen after birth is HIE. But we know that there are masqueraders in genetics. I've just listed some. It's important to have the thought process, because on the right hand side you see that these are the tests that can identify these disorders. But we have a large number that is identified by next generation sequencing. But let me tell you, the ones on top would not be picked up by next generation sequencing. They will need those specific tests. And so in this work, which we published in the European Journal of Human Genetics, I had a student who looked into 70 cases from intensive care, PICU and NICU, of which we achieved a diagnosis in around 45-46%. They were across all phenotypes. And so what? What was the impact on diagnosis? It altered the medication in 35%. Some of them would just improve by special diets. It avoided major procedures. It transitioned some onto palliative care because the intensive care costs would not be justified for the outcomes. And the largest chunk, it offered reproductive options to prevent the birth of another child with a genetic disorder. And just one example, which is not common in the NICU, is difficult to control seizures. And if you find a genetic cause, you know exactly what drug to give. And here, instead of the plethora of drugs that the patient was on, it was just one carbamazepine, which led to a dramatic control of seizures because there was a variant in the channelopathy, KCNQ2. And the child then does well. Similarly, a family with 2 children with HIE, we all know that that's not something which is the norm. And how do we blame everything to the obstetrician and the neonatologist on call? It's because we fail to identify these phenotypes. Firstly, with recurrence, always think. And then look at the child. The child looks different from the parents. And then go on to see the retrocollis, the abnormality of the tone, and then the MRI, which is a giveaway. Because this sort of an MRI has only 1-in-1 diagnosis. and this is a molybdenum or a sulfite oxidase group of disorders. They don't have good treatment, but at least now we understand what happened and can prevent this family for having another child like this. And you need those other supportive tests in the urine and in the blood to confirm the diagnosis. It's not only the molecular test that's enough. And this is another child with global developmental delay, but a facial profile and the spectrum of changes that we see with the streaky pigmentary abnormalities, which gives away the diagnosis of a mosaic disorder, because where we have streaks of pigmentations along the lines of Blaschko, we know that we are dealing with a mosaic disorder. You need to test that part of the skin to confirm that this child has a chromosomal abnormality because of an extra chromosome 12 in the body. This boy was snoring outside the OPD in the middle of the afternoon. And the parents said that's a normal profile because he sits with his mobile half the night and therefore he sleeps the whole day. But the culprit was not the mobile. The culprit was the basic disorder that he has, which is the Smith-Lemli opids. So these are some clues that you get, and then look at the face, look at the midfacial hyperplasia, combine it together with the behavior abnormalities to make a differential diagnosis, which in this case was a Smith-Magnus syndrome, which then requires a different genetic test to confirm, and this is the MLPA, or you can even do a microarray that will confirm the reason for that Smith-Magnus syndrome, which is a deletion in this gene. There are some times where the tests don't give you a diagnosis, but your clinical suspicion is so strong, which is what we saw for the hypophosphatemic rickets patient. There was another one which was very similar to that. A lot of facial dysmorphism, digital abnormalities, an MRI which looked like a ciliopathy, a Jobe syndrome, and cortical migration abnormalities. And when you put together these things, and especially these giveaway, if you do a good examination, you know that this is the one and only orofaciodigital syndrome, because you search in a free tool, which is the online Mendelian inheritance in man. And when the test does not give you an answer, you go back and check. And so when we did this, we went back and checked the data, and we identified what we were looking for, a variant in the gene. It was not previously reported for specific reasons of analysis, but we know that we found another family in Pakistan who are similar to our genetic background, and we were very sure with the clinical phenotype that this is what we were dealing with. So armed with this sort of experience in the clinic, we looked at a lot of data, in this case 88 patients whom we thought were, yes, they had a genetic basis, but their initial report was negative, the genetic report. And we went back and looked at the same data. We did not order another test, but we looked at the raw data, and we got a diagnosis in 27% of these patients. And so this is the power of the clinic and applying the phenotype to the genotype. So when these tests came in, we all thought we would be out of a job, but I now realize we have a greater job and a greater reanalysis because of these experiences that we have, and understanding these sort of diagnostic odysseys these patients goes through. And this just shows you that from the black part to the end, which is the reanalysis and reporting, they've been through a lot in their lives. There are some reasons why these are two babies born in my hospital, evaluated by us, and we didn't have an answer the first time or the second time. Because we didn't look at the key thing. And then you put it down all together and you see which is the odd thing here. Both of them had hyperphosphatasia in the presence of a normal vitamin D. Go down and look at that pathway, and when we looked at that pathway, we identified a new gene, which was the PIGB gene, which was within that pathway of the GPI synthetic pathway, which gave us the diagnosis for this family. So it's persistence and perseverance which enhances the diagnostic yield, and you need it because they are actionable aspects. It's a multidisciplinary team that worked together. And in this era of so much depth in every subspecialty of pediatrics and adult medicine, we all have to work together and incorporate genetics in the clinic. If something is clear, you do that specific test. If it's not clear, you have to follow a sequence. And that sequence involves a good phenotype, including basic investigations. Not to forget thyroid, because we don't have newborn screening. Look at the nutritional abnormalities, and then go on to do the other tests, and finally make a conclusive diagnosis for our patients. And it's all this work over the years we realized that even though we thought we understood the technology we were using, 60% of patients remained without a diagnosis. And that's what propelled this work throughout the world and also in our country, which was coming together with phenotypes and patients who were undiagnosed. The Undiagnosed Diseases Network International, the Wilhelm Foundation, who lost 3 children without a diagnosis, and propel this work. It's a parent organization. And this fashion photographer who was actually just filming for the various fashion names in, on the New York Times, who brought the beauty of these children who actually had been stigmatized for life because they had a genetic disorder, but nobody knew what it was. And it is through this that was born the Indian Undiagnosed Diseases Program. And we've been able to understand technologies, make new diagnoses, and more than make new diagnoses, bring a community of undiagnosed together to support themselves and support each other and propel the work we do in the kind of environment we work where the load is huge for each of us. And yet I believe that each of us have to put that little aside for the extra work that we have to do to make their lives comfortable, which actually brings about a very, very humbling experience. And so with that, I finish my little perspective on how we use genetics in the clinic. Thank you so much. Yeah, sure.
Thank you. I'm Dr. Vaman Khadilkar. I have a question for you. We have opened this Pandora's box now with the genetic analysis, and many a times we get this variant of uncertain significance. But the gene is exactly as you said in the pathway, and clinically it fits. So if we report that case and it gets into the global database, then when next time a person finds that specific deletion, does it still come as variant of uncertain significance or gets addressed as reported with her disorder?
Yeah, thank you so much. So the gene, so when you look at the data, you will always look at genes that are associated with the phenotype, and therefore the variant of uncertain significance will always be related to the phenotype. Now, there are various attributes based on which, there are 32 attributes based on which we say it's pathogenic, likely pathogenic, or a VUS. By just another person finding the same gene variant, it cannot become a likely pathogenic. Initially, the criteria were quite loose, but now with more and more sequencing, the criteria have become very stringent, and only if some form of real functional analysis has been done does it become a likely pathogenic variant or a pathogenic variant. Otherwise, you get multiple entries within the databases, the commonest being ClinVar, where these variants, there would be 5 different reports of the same variant, but it may remain as VUS unless someone has done work on that variant.
So then the geneticist needs to go back to the case and do the functional analysis.
Yes.
So
it's very difficult to do a functional analysis for every VUS variant.
Yes.
And also to say that 90% of VUS variants become benign over a period of time. And so now, because for our population we have a very small database, but still something of those 10,000 genomes have come up, various people are working on that, and if we build that into our analysis, the wooses will decrease, should decrease.
With the permission of the chair, can I ask one more question?
Yes, yes. We have 2 minutes.
So, I deal with pediatric endocrine disorders, and I do end up seeing a lot of congenital adrenal hyperplasias. Not every time you get a homozygous deletion. You get compound heterozygous within the same. And often, if you have consanguinity, then you get 6 or 7 variants within the abnormal gene, but they are compound heterozygous. Now, unlike thalassemias, where you have a known fact that these may cause a disease, in congenital adrenal hyperplasia, there is a clinical disease, but you get compound heterozygotes. Now, should we call these compound heterozygotes as pathogenic?
Okay. So firstly, the genetics of CAH is very complex because there is a pseudogene.
Yes.
Okay. And when we do next generation sequencing, the pseudogene also gets sequenced and multiple variants come up in that. So that's not a good technology to use. It's good to use a combination of Sanger sequencing and MLPA because that will address everything. Now, when you do that, the number of WOOS variants will decrease, or the number of variants you find will decrease, but yet we know that in CA, so whether it's homozygous or compound heterozygous doesn't matter as long as there are 2 variants which are segregated in the parents. But we know that in CAH you can have a point change and a deletion that come hand in hand, like the IG2. And there are some duplications, like a duplication of the CYP21A2 gene, which is benign because it's found in many people.
Yes.
And so that is really, really complex.
Yeah.
And to put it all together, I just want to tell you that we are putting together this in memory of Dr. I.C. Verma, who always would tell me that, Ratna, we don't put our data together, and we know that's the lacunae in genetics in India. And so we are trying to bring out a special supplement of the IJP in his memory with data from India.
Oh, that is
and
wonderful.
I will definitely send it to you because it's got...
That's wonderful. Because we studied 341 patients. And there are a variety of those. Thank you. Thank you.
So, thank you, Dr. Puri. May I call upon Dipanjana and Dr. Arun Mangoli to kindly hand over the memento to Dr. Puri. Madam, please, there at the back, we will hand over the memento. Our next neonatology update, which will be moderated by Dr. Rishikesh Thackeray. May I call upon the panelists? Please kindly take your chair. Dr. Bijan Saha, Dr. Khya Ghosh Uttam, Dr. Amrita Puri and Dr. Devdeep Mukherjee. Amrita Roy, sorry.
So, very good morning to you
45 minutes, Dr. Thackeray, you have.
It's indeed a pleasure and privilege to be here today for these scientific deliberations. And the objective of our panel discussion today would be to apprise you of what are changes which have happened in the recent past on common neonatal conditions. And we are fortunate to have with us Dr. Bijan, Dr. Khya, Dr. Devdeep and Amrita to share their rich experience and expertise on neonatology. So the story of the newborn begins in the delivery room. As you enter the delivery room, our entire endeavor is to anticipate and identify a high-risk newborn, and this is feasible by asking 4 focused questions. What is the gestation? How is the amniotic fluid? What are the medical risk factors? And the key question today is, what is the umbilical cord plan? International Liaison Committee on Resuscitation every 5 years comes out with updates on newborn life support, which came this year, and the new edition is likely to come next month. So my question is, as we await the arrival of this newborn, Dr. Bijan, what would be the umbilical cord plan, A, based on the clinical status of the newborn, and B, based on the gestation of this newborn? So this is about the consensus of science and treatment recommendations which came through ILCOR.
Thank you.
Let's see what are these updates.
Thank you very much. Before I start, let me tell you what are the different umbilical cord management plan in clinical practice. I think all of our placental transmission means there will be residual blood which is in the placenta that should be transferred to the baby during the first few minutes after birth. And what are the different options? Options are, one is delayed cord clamping. That means you keep the cord intact for 30 to 60 seconds and let the blood go and before clamping and cutting of the cord. Then another is umbilical cord milking, keeping the cord intact and stitching the cord, and when the cord is still with the placenta. And third is that intact cord resuscitation. You are resuscitating the baby when the cord is still in the placenta. And fourth, finally, some is that cut umbilical cord milking. Now, my question was that what are the plan and what are the recommendations? First of all, let us start with the gestational age of 34 weeks and above. So, if any baby is born more than 34 weeks or above and not requiring resuscitation, the guideline says that delayed umbilical cord clamping more than or equal to 60 seconds is beneficial. The second option is that if the baby is more than 34 weeks of gestation, not requiring resuscitation, what about umbilical cord milking? Umbilical cord milking is not found to be beneficial as compared to delayed cord clamping. So third option is that if the baby is born 35 to 42 weeks of gestation, not requiring resuscitation and non-vigorous, that case umbilical cord milking may be reasonable. So this is about the babies who are born more than 34 weeks. So what about those babies who are born less than 34 weeks of gestation? If a baby born less than 34 weeks of gestation and not requiring resuscitation, DCC may be beneficial compared to early cord clamping. Second option is that if the baby is born 34 weeks of, more than 34 weeks of gestation, not requiring resuscitation, but delayed cord clamping is not possible. In that case, umbilical cord milking may be a reasonable option. The last gestational age is less than 28 weeks baby. Less than 28 weeks, studies have shown that umbilical cord milking is not beneficial. It may cause some harm in the form of intraventricular hemorrhage. Having said all these things, there are some studies and we have done some work on cut umbilical cord milking. So if the baby is non-vigorous, where you cannot go for DCC or umbilical cord milking, there is another option. We had 2 studies. So what is done in singleton pregnancy, our study was showing that 30 to 35 weeks of gestation, if a baby is born and non-vigorous, you cut the umbilical cord around 30 centimeter and you compress and stripping the cord 3 times. It has been shown in our study that it increases the hemoglobin level at birth and also at 6 weeks and also it improves the hemodynamic. That is for singleton pregnancy. Another study was conducted in our institute that is from 30 to 37 weeks of gestation in twin and those who are non-vigorous. And they also found a similar finding. It increases the hematocrit level and hemodynamic stability in the infants who are done at umbilical cord milking. So if the baby is non-vigorous, you do not have any option. And I think cutting a cord 30 centimeter from the baby is not a difficult task. Any obstetrician will be happy to do it and you can practice. Thank you.
Thanks, Bijan. So if the baby is vigorous, whether it's term or preterm, practice delayed cord clamping. What is the change? Previously it was 30 seconds, 30 to 60 seconds, but now it is at least 60 seconds. So that's a change which has happened and this would be based whether it's a preterm or term, practice delayed cord clamping for at least 60 seconds. If it's a baby who is non-vigorous, instead of cutting the cord immediately, practice intact cord milking and then move over the baby to resuscitation. There is no evidence of intact cord resuscitation as far as current science is concerned. And rightly mentioned, there is one subset of babies less than 28 weeks where umbilical cord milking is definitely harmful and should not be practiced. So to put this into real world, what we need to do is ensure that the science gets implemented by looking at adequacy in terms of personnel, adequacy in terms of the place and equipment to ensure that all babies would be benefited by this simple cord strategy. Remember, 90% of our newborns would establish spontaneous breathing, but they would be denied this simple low cost, effective, evidence-based intervention unless and until we put this into practice. Okay. The second is that having that plan and a resuscitation algorithm which is there, what we are aware of, which is unique to newborn in the form that instead of ABCD, it is TABCD. So Dr. Khea, could you just tell us what are the key changes as far as temperature, airway and breathing is concerned for this baby who is depressed at birth? What are the updates?
So as we know that in contrast to pediatric resuscitation, in neonatal resuscitation, T, that is the temperature, has the major role. And the systemic review has shown that there is a dose-responsive association between hypothermia and neonatal mortality and other comorbidities in neonates. And many studies have shown that even if there is delivery in the temperate climate and even in hospital, the babies may develop hypothermia. So the new guideline has said that throughout, at the birth point and throughout the time of resuscitation, the temperature, room temperature should be 23 degrees centigrade, irrespective of whatever gestational age is there. So in babies who are born above 34 weeks, near term or preterm and near preterm and term babies, we can get this by skin to skin contact. So we can just take the baby and put it to mother's skin contact, and that will achieve the things. But whereas if the baby is less than 34 weeks, we need to have plastic bags, we should cover the head, and in special situations we can use things like thermal mattress. Of course we use heated humidified air for resuscitation, requiring resuscitation. So the thing is, less than 34 weeks skin to skin care will do, and more than 34 weeks skin to skin care will do. Less than 34 weeks, better to put in plastic bag, head cover, because there is insufficient evidence that only skin to skin care will take care of less than 34 weeks. There is neither for nor against it. And of course you can have other things like as I mentioned.
What about taking care of the airway and breathing?
Yeah, so regarding airway breathing, there is no major changes, but only some recommendations have come. So initial steps like suctioning, clearing, there is no major changes. So if a baby is requiring positive pressure ventilation, so there is a sufficient evidence to see if there is a facilities are available. T-piece resuscitation is better than self-inflating bag plus minus P valve. So if there is training personnel available and facilities available, it is better to use T-piece resuscitator because the effectiveness is better in contrast to SIB, that is self-inflating bag. And whether to use self-inflating bag with PIP valve or not, there is insufficient evidence to or against it. So both can be used. And in a CPAP, of course, in a baby who is a preterm baby with spontaneous breathing, having respiratory distress, CPAP, labor room CPAP is the recommendation. But with late preterm and term baby, whether to use CPAP or not, there is insufficient evidence. Now, so in the LMA is the laryngeal mask airway. So if you want to use supraglottic airway devices, because we often use this when we need to have positive pressure ventilation and also chest compression. In that, in older child, that is older babies, that is more than 34 weeks and term, yes, there is an evidence to use LMA, but not so in the preterms. And regarding oxygenation, of course, in more than 35 weeks, you should start neonatal resuscitation with oxygen only, in room air, 21% oxygen. In the age group less than 32 weeks, we should start with oxygen, starting from 30% or more. In between, that is in between 32 and 34, there is, you have to use your own decision, so it is plus minus oxygen. And there are certain upcoming things like XL CO2 monitoring, respiratory monitoring, and this NIFR, what we said as near infrared saturation detection, that where we detect the cerebral regional saturation to see the effectiveness of the ventilations. There is no sufficient evidence to go for or against all these things.
So, as rightly said by Khea, 9 out of 10 babies would get better with just looking after temperature and airway. In our urge to keep babies warm, avoid hypothermia but be vigilant about hyperthermia. And today, T-piece resuscitator takes edge over self-inflating bag. Remember, oxygen now is a drug, and like a drug, it has its dose. That dose threshold has dropped from 35 weeks in the previous guidelines to 32 weeks, where now instead of giving a range of 21 to 30%, we are at 30% at least of oxygen that is required. So
was also previously there is that we have to intubate the child before we start chest compressions. We have to give 100% oxygen, that is FiO2 of 1, while conducting the chest compressions. Now in terms of intubation, newer recommendation has come up about the use of video laryngoscopy rather than direct laryngoscopy. And there are multiple evidence which has shown that if it is done by unskilled doctors, then video laryngoscopy might be slightly better than direct laryngoscopy in terms of assistance. Also for chest compression, we know that previously there were two methods of delivering the chest compression, the 2-finger technique and the 2-thumb encircling the chest technique. Now the 2-thumb encircling the chest technique generates a better cardiac output as observed in various studies. This is a weak recommendation with low certainty evidence that 2-thumb encircling chest technique is preferred over the 2-finger technique. Chest compressions are to be delivered at the lower third of the body of the sternum, avoiding the xiphoid process in order to avoid injury to the internal organs. That is the same recommendation as previous. The compression depth has to be 1/3 of the anteroposterior diameter of the chest. That is also same recommendation as previous. And 3:1 ratio of chest compression with positive pressure ventilation has to be maintained. Now another thing which we generally forget is that after the return of spontaneous circulation, we generally try to keep the FiO2 at 1 or we forget to decrease it. So please we should try to decrease the FiO2 as the baby's saturation targets are met while we have achieved the ROSC. Now in terms of end-tidal carbon dioxide and pulse oximetry, to check whether ROSC is present or not, it is not recommended. It goes against the recommendations. We should try to see ECG and see if there is return of cardiac activity present or not. And if ECG is not available, then we can go for auscultation or pulse oximetry, whichever is available in that resource environment.
And what about medications and other things like family presence, duration of
Yes, so
resuscitation?
in terms of medications, we know that the only one drug which is recommended during NRP protocol, it is epinephrine. So epinephrine, the route preferred is definitely intravenous. If we are not getting intravenous access and if we have intubated the child, we can give the first dose as endotracheal one. But as soon as we get an intravenous access like the umbilical venous catheter, we should give the first dose of epinephrine immediately. The preferred intravenous access is the umbilical venous catheter. Epinephrine is given at the recommended dose of 0.01 to 0.03 milligram per kilogram, followed by a normal saline flash if it is an IV dose, and higher doses if it is an endotracheal dose. We should keep on repeating the epinephrine every 3 to 5 minutes depending upon the clinical scenario. And another thing which is new, which has come up, is to check the blood sugar early in the course of resuscitation, which was not there in the previous guidelines, because these children, especially the preterms, the children having perinatal asphyxia, having chest compression or epinephrine might have hypo or hyperglycemia. So that should be identified immediately and corrected accordingly. There is no routine supplementation of routine bicarbonate sodium bicarbonate recommendation in terms of drugs. Now in terms of normal saline bolus or crystalloids, if we find that there is obvious blood loss and if red blood cell or PRBC is not available, we can try for a normal saline bolus. If also there is another scenario when we have run the entire course of resuscitation and the child is still not responding, then we can give a trial bolus of normal saline. But there is no routine bolus is not recommended, it is based on the clinical scenario. Okay. In terms of environmental presence and exposure, so when should we call off resuscitation? If after 20 minutes, of absent heart rate, if we have done the full course resuscitation, then we can call it off. However, there is no duration of CPR which can actually predict the mortality or the neurodevelopmental outcome of the child. In case there is inadvertent hypothermia which is occurring during the course of resuscitation, which is inadvertent, rewarming has to be done. As Dr. Khea has mentioned, temperature is of utmost importance. Whether slow rewarming, which is less than 0.5 degrees per hour, or fast rewarming, more than 0.5 degrees per hour, there is not enough evidence to suggest which one is better, but rewarming should be done following local institutional protocol or a standardized protocol. We have already known from the Helix trial that therapeutic hypothermia in low and middle income countries, if they don't follow a standardized protocol, then there is increased mortality. So if we are practicing therapeutic hypothermia in a low and middle income country, we should have a standardized protocol which we should stick to. In terms of family presence, I think it depends upon the culture and the local working environment and the ethics of the scenario. So abroad, family present including parents, mothers, family caregivers are encouraged to stay while they are at the bedside. However, it is to be modified as per the local situation.
So just to reinforce, previous guidelines talked about therapeutic hypothermia as an option for babies beyond 35 weeks of gestation. That cutoff has been raised further based on the recent data, and therefore today we would restrict therapeutic hypothermia as an option only for babies beyond 37 weeks of gestation. But a good snapshot of how resuscitation science has changed and will continue to change as far as the practices are concerned. So moving out from resuscitation, time and again we have burnt our fingers where a newborn has been declared to be otherwise well, only to lose this baby 48, 72 hours down the line, or the baby undergoes unexplained deterioration. My question is, Dr. Devdeep, can we predict a heart disease based on our first assessment that there is a significant heart disease sitting there, a volcano waiting to erupt?
Thank you, sir. So it's extremely imperative that every neonate gets a proper head-to-toe examination before that neonate gets discharged from the institution. And ideally, even though we should examine at the time of delivery, but there should be another examination close to 24 hours, so that to account for the transitional changes that happen during that time. So a baby who seems to be unusually tachypneic without any lung pathology, if there is an audible murmur, or if there is a very single, very definite S2 without a click, these are red flags actually. So again, we should closely look at the femorals. So an absent femorals or very weak femorals should also make us think about possible congenital heart disease. The blood pressure, the upper limb and the lower limbs have to be checked. We have to look for any organomegaly, although that may not be there to begin with very early on. And then there are the definite signs like pallor or a cyanosis. So it can be a central cyanosis or a differential cyanosis, which should start make us think whether we should get a proper cardiology evaluation for this child. And definitely pulse oximetry is something which is extremely important. So look at the pre and the post ductals are extremely important.
So the point here is that during your first assessment, we have enough opportunities to predict a heart disease. One which we should ensure in our day-to-day practice is to look at the split of the second heart sound. This suggests a successful transition from fetal to neonatal. A split, therefore, if is absent, is suggestive of an underlying heart disease unless proved otherwise. So beware of the second heart sound split, especially at the time of hospital discharge or your first contact in the OPD. And as rightly said, we have today critical congenital heart disease screen by means of pulse oximeter. So all newborns should be offered this screen. So how would we perform this screen?
So we need to check the pre and the postductals. So the postductals are usually in the foot and the preductals in the right hand. So so again, this is done closer to 24 hours. We will not rule out every possible cardiac heart issues over here, but yes, it helps in ruling out quite a lot of them. So if the saturations at discharge is more than 95% with a less than 3% difference in the pre and postductal, so that's a pass. So if it's between 90 and 94% and with a differential of more than 3%, then we need to review once or maybe twice. And if the baby fails both of these, then the baby needs a proper cardiac evaluation with the echo and the ECG. And it's a fail if the saturation is less than 90%.
True. So what has changed here is that if you are having a borderline saturations, previously we used to wait for 1 hour and then another 1 hour. So 2 sequential 1 hour assessments were recommended. The recent update tells us it is only once that you would re-evaluate the baby. But mind you, of the 4 babies who would fail the test, only 1 will be diagnosed to have a congenital heart disease. That means non-cardiac conditions are far more likely to be picked up with hypoxia, and these are babies with pulmonary hypertension, with sepsis, with thermal instability, those with an underlying lung disease or delayed transition are the ones who are likely to be picked up. A past screen does not mean that you have ruled out a critical congenital heart defect. So though it is assuring, it is not 100% proof. So from here we move now to, I think, the hot topic, and that hot topic is about how do we pick up sepsis. And we have these 4 time tested labs that we have been asking for. So Dr. Khea, what is the current update as far as using CBC and CRP for diagnosis of sepsis? And then we will have Dr. Devdeep, who will share about Procal, Cytonine and sepsis screen. So over to you, Khea.
So the total leukocyte counts, the blood counts, not only total leukocyte count, platelet count, actually they varies. You have to understand in neonates they vary according to the gestational age, they vary according to the condition of the year, not only infectious but non-infectious causes, and also depending upon the gestation. So we have to be very careful if we taking into account blood counts, total leukocyte count. So a low total leukocyte count, so if it is low, it is very significant. So it is quite suggestive of sepsis, may not be the only reasons, because that indicates the bone marrow is already depleted. So usually it is sepsis. Whereas a high count does not always means, okay, this is sepsis, because there may be so many things. Even a vitamin K administration, even if a baby is crying for a long hours, even after the birth. So all these things can raise the total leukocyte count. So we should not take leukocyte count, total leukocyte count as a sole indicator, oh, this is sepsis. And again, it comes up to the platelet count. Often we think low platelet count is always sepsis. It's not so. We have to understand if you are doing a central line, if the baby is on mechanical ventilation, if the baby is on drugs which can reduce thrombocyte counts, all these things, even asphyxia, all these things can cause a low platelet count. And so low platelet count means always fungal sepsis. This yes, should be not taken. So always standard is stain the blood culture. And regarding this absolute neutrophil count also, you have to understand sometimes in very low birth weight babies and extremely low birth weight babies, we get low ANC. So we have to use the charts, always use the chart to find out the absolute ANC. IT ratio always does not indicate, if you have a more immature cells, does not always means a sepsis, because sometimes even if the immature cells are low, it can be severe sepsis, because in severe sepsis, if the bone marrow is exhausted, you may not get immature cells. So these are the things which we have to take into. Regarding CRP, I would say, and regarding blood count, one important thing, never do it very early. So it takes time. The same thing is for CRP. So for CRP to raise, the bacteria has to go to liver, it has to trigger interleukin 6, and then only the CRP will rise. So it will not start to rise before 12 hours, around 10 to 12 hours. So it gets peak at 24 to 48 hours. So no point doing it very early. But obviously, because if you get a negative CRP, it is, the negative predictive value is very good. So you might think that this is sepsis, but if you have a strong suspicion of sepsis, it is better to repeat it after 24 hours. So it is often said that 2 consecutive CRP done at a 24 hours apart, if it is negative, it virtually rules out sepsis. So, but positive CRP, again, like the total count, high total count, may be affected by many things, like fetal distress, maternal fever, birth asphyxia, even resuscitation, requiring resuscitation, may all raise the CRP. So it's an acute inflammatory marker, so it may be raised in so many things. So we have to keep in mind all those things, and the timing is important. Don't do CRP very early. It might come negative even if it is a septic baby.
Okay, Dr. Devdeep, your take on Procal and sepsis screen.
So for neonatal sepsis, it's all about risk assessment, looking at the clinical signs and then assessing all these lab values as a whole and then looking into it. So the sepsis screen actually involves interpreting all of these into it together along with the blood culture, the blood count, CRP, the micro ESR, and then interpreting it as a whole. So any 2 or more being positive actually increases the sensitivity of the result and helps in considering sepsis if in a background of risk factors being there and the clinical symptoms being there. The Procal as an individual factor is again an acute phase reactant and always may not rise just because of sepsis per se, can also be elevated if there is evidence of any asphyxia, any bleeds. So all of this can contribute to it. And along with it, the costs are still prohibitive on the general population compared to CRP or the other counts, etc. And the blood culture still remains the gold standard in a background of clinical symptoms and signs of sepsis. So Procal still not a routinely propagated value to be seen for any child. So there are few evidences where in late onset sepsis in preterms there has been some benefit in prognosticating sepsis by looking at Procal. But again, a serial marker of Procal or interpreting it along with the CRP improves the diagnostic sensitivity and rules out and also improves the negative predictive value. But the sepsis screen as a whole helps in interpreting sepsis better.
So what would you do if you have a newborn with risk factors at risk for sepsis? CBC is the least reliable. CRP is C unreliable protein. CRP and Procal would vary with postnatal age, gestational age, mode of delivery and number of intrapartum and postnatal factors, and are not recommended by either the AAP nor the NNF clinical practice guidelines for diagnosis of sepsis. And the utility of sepsis screen remains in ruling out sepsis rather than for diagnosis of sepsis. So for all practical matters, we go back to say none of these markers in isolation are good in predicting development of sepsis. So what you and me should be doing? The answer comes from the AAP current guidelines, which would say that serial clinical observation of the newborn in a structured and objective manner, looking at the CBC, and to me CBC is consciousness, breathing and circulation. A. B. Monitor TOPS sequentially hourly. What is TOPS? Temperature, oxygen, perfusion, sugars and sensorium. If you clinically monitor these and show a derangement in one or more of these parameters, don't wait for doing any of the tests, get on to an antibiotic. Before you start an antibiotic, do a blood culture. So in today's era, don't harp on a test to guide you. Be clinically vigilant, and if the baby starts showing you symptoms, monitor these symptoms, look at the trend rather than trying to look for any of these tests to give you an answer. Neither of these tests are recommended to stop or start antibiotics in isolation. They need to be correlated always with the clinical status. Having said that, if we have a symptomatic newborn, or for that matter an asymptomatic newborn, should I start antibiotics or not based on risk factors? So we have this list of risk factors, and how would we proceed with any of these?
So when a baby presents with us, the baby may be symptomatic or asymptomatic. So some of the preterm babies will be born with no symptoms, but there may be some risk factor. Whatever the risk factor, it has been shown here. One is chorioamnionitis, foul smelling liquor. prolonged rupture of membrane more than 18 hours, and PPROM, preterm premature rupture of membrane, interpartum fever, and unclean handling, surface cord, etc. Having said these things, just one point I want to highlight. If you want to know all this information, we should have a very good relationship with obstetrics. But many a times this information is not there, we just start antibiotics. So if there is chorioamnionitis, and chorioamnionitis in our country, I think it is underdiagnosed. So if there is chorio and foul smelling liquor in babies less than 32 weeks, there is high probability of sepsis. You start antibiotic, but you have to take a blood culture. So as my previous speaker has already told, the sepsis skin neither rules, it does not rule in, rule out disease. So in this case, if you want to start antibiotic, there is no point of doing sepsis screen, thus you are wasting time. So you take a blood culture, start antibiotic. If there is only that red sign is there and only one yellow sign or blue sign here, if they're less than 32 weeks, that means you have to see the probability of sepsis in this particular infant. So if the baby is born less than 32 weeks or BLVW, and with these symptoms, there is a high probability there is a risk of infection. So what you do, you take a blood culture, start antibiotic. If the one risk factor is there, like chorioamnionitis or foul smelling liquor, or two or one other risk factor. And second important thing, you just follow up the baby. Take a blood count after 6 to 12 hours. If within next 24 or 48 hours you see that baby is doing well, blood culture is negative, you can stop antibiotics. But if the baby is not doing well, blood culture is positive, then you go for the CSA. If a baby is born more than 32 weeks gestation, that means our probability of sepsis is little bit low. In that case, you can take one red flag sign and two yellow flag sign to start antibiotic. The same thing, you take a blood culture, no point of wasting time with doing a sepsis screen, and start antibiotic and follow up the baby and can do a blood count after 6 to 12 hours. But one important point to note, in early onset sepsis, always see the baby at least 48 to 72 hours, every 4 to 6 hourly. So the clinical assessment is more important than the just lab parameters. See, in next 72 hours, if they see the baby is absolutely fine, that means that baby is doing well not because of antibiotic. Actually, baby did not have an infection. So if your blood culture is negative, baby is doing well, and you are convinced, then by 36 to 48 hours, you can stop antibiotic. Now, why I am saying 36 to 48 hours? If I am not wrong, many a times in our clinical practice, most of the babies are getting empirical antibiotic rather than babies getting antibiotic on culture. So we should show some kind of courage. If a baby does not have any infection signs and symptoms, to stop antibiotic 36 to 48 hours, so that misuse or empirical use of antibiotic can be stopped earlier to prevent other many complications, as you already know.
So what Dr. Bijan is trying to tell us is that the recent NNF clinical practice guidelines, based on the risk factors, based on the gestation, clearly came out with current evidence of when to start antibiotics based on the gestation. The major risk factors are in red, the rest 4 are minor risk factors. If you have a baby with gestation less than 32 weeks, one major or one minor risk factor, please start antibiotics. If it's a older baby in terms of gestation, 2 minor risk factors would be justifying treatment. But if you have a baby who is symptomatic, irrespective of the risk factors, don't waste time doing any blood tests.
So
don't waste the resources, as rightly said, start antibiotics, but draw a blood culture, but more importantly, have an exit criteria for antibiotics. So that's key factor which has to be kept in mind. Okay, now the other thing that we have is that jaundice is very common. Again, we have recent update in jaundice. 9 out of 10 times you will be seeing physiological jaundice. Physiological jaundice is a diagnosis of exclusion. So in my first contact with the newborn, how am I going to pick up a pathological jaundice? That means that jaundice which would require either investigations or immediate intervention. So Dr. Devdeep, tell us clinical clues which will predict that this is a pathological jaundice in my first assessment.
So if we are looking at this baby on the first day of life and the baby appears extremely icteric within the first 24 hours, and if we are also aware of the mother's blood group, so the baby's blood group may take a few hours to come back, so we might have to start suspicion of a hemolytic disease that's happening in this neonate. So, and then we can follow up with the bilirubin trends as well. So if it is a sharp rise of more than 5 within the first 24 hours, again that also makes us think of a pathological jaundice. Mild icterus over here is not very significant, but then we have to see the trends over the initial 24 and follow it up with the next further 24 hours up till the next 48 hours. And any neonate who has a persistent jaundice beyond 2 weeks of life, and if that's conjugated, so that's for a term neonate or for a 3 weeks for a preterm neonate, then again we'll have to start thinking whether there is any pathological jaundice over here. So along with that, we will also keep on assessing the clinical signs. So baby appears unusually irritable, or if there are any history of seizures, baby appears very drowsy, then these are again red flags to make us think and start evaluating for pathological causes of jaundice. So we also have to take a history of the urine and the stool color. So the urine appears very dark yellow or brown, again will increase the suspicion, and then the stool being whitish or clay colored also increases the suspicion of pathological jaundice in a neonate. So along with that, the clinical examination, the signs, looking for organomegaly, looking for petechiae, so all of these increases suspicion of pathological causes of jaundice in a neonate.
Which baby you are likely to miss? The most under-recognized sign is postnatal weight loss. These are well babies otherwise with little icterus, but they have significant weight loss. And what do we mean? Every baby with jaundice must have its correlation of the present weight with the birth weight. If you lose more than 10%, that's a lactational inadequacy, and that's the commonest cause for your pathological jaundice. Your tests come negative, but this baby ends up with receiving intensive phototherapy. So every time you see a baby with jaundice, assess its weight, compare it with its birth weight. Secondly, that all these signs in isolation per se are predictive of development of significant jaundice. And what has changed also is that we have today new phototherapy and exchange charts. Previously, to predict development of significant jaundice, we used to use what are called as R-specific bilirubin nomograms, also called as Bhutanese charts, which are today no longer recommended for identifying babies at risk for jaundice. So if we have Dr. Amruta, a 35-weeker with 2.2 kg weight, seen at 30 hours of age with an ABO setting with a bilirubin of 12, how would we plot it and interpret it based on our current understanding of the AAP charts?
So the newer AAP charts which have come up in 2022, they have divided the phototherapy and the exchange transfusion thresholds based on the gestational age as well as based on the hours at which we are collecting the sample. There are some neurotoxicity risk factors which have come up. It includes hemolysis, like in this child there is a ABO setting suggestive of isoimmune hemolytic anemia. Also, if there is sepsis, if there are any instability in the last 24 hours like acidosis, and if the albumin is less than 3 gram per deciliter, which is suggestive of a increased fraction of unbound bilirubin, increasing the risk of bind or bilirubin-induced neurologic dysfunction. So these are the neurotoxic risk factors which you have to keep in mind, along with the gestational age and the weight and the age at which the sample is taken. So taking this into account, we can plot the gestational age in the second chart, the A chart, and it shows that if the gestational age is 35 weeks and at 30 hours the sample is taken, then the serum bilirubin in this child is at 10, which is plotted against that. It shows that the child is, and there is also one risk factor, one neurotoxic risk factor, which shows that this child is in the phototherapy zone. There is another app which is launched by the AAP, which is known as the Billy Tool app, and that app also incorporates the date of birth, the time of birth, the date of sample taken, the time of sample taken, and neurologic risk factors, if neurotoxic risk factors if present or not. And that app also actually gives us the recommendation as to whether phototherapy is needed, exchange transfusion is needed, or it is the point at which we need to escalate care.
So today for phototherapy and for exchange, we have two set of charts. One with neurotoxic risk factors, one without neurotoxic risk factors. So this baby has two risk factors. This is a preterm, there is setting for hemolysis, so we would use the neurotoxic risk factors chart and plot it against the gestation. It crosses the threshold, you put it to say this baby needs this format for intervention. What is the drawback of this chart? The drawback is it is not meant for babies less than 35 weeks of gestation. It would require you for all such babies to start on intensive phototherapy. And C, you would always take the decision based on total serum bilirubin and not on indirect bilirubin. That is what we need to keep in mind. And lastly, rightly said by Dr. Priyanka, that this is a simple tool. If you don't want the charts, just put these into online and you would get an immediate scoreable action of what best we can do. And lastly, last 2 minutes, Dr. Bijan, this is a rapid fire. Have a look at this baby, because this was an update which came recently.
With continuous EEG, that is you have to treat. Second is that suspected seizure with amplitude integrated EEG, you treat. Clinical seizure beyond this focal clonic or clonic or tonic, that is called the probable seizure. So if I do not have any continuous EEG monitoring or amplitude integrated EEG monitoring, this case I will diagnose as a probable seizure.
Yeah.
Probable seizure.
So definite seizure is with an EEG abnormality, probable seizure is with an amplitude integrated EEG abnormality or focal tonic or focal clonic. So this baby has a probable seizure, and possible seizures are what you and me are diagnosing.
Correct.
All are clinical without any documentation in terms of amplitude integrated EEG or EEG. What is the drug of choice?
See, if it is a
first drug of choice,
first was a whatever is the etiology of the first was a phenobarbital. Phenobarbital. Second important thing is that if it is a probable seizure, you might treat, you might not treat. You may consider treatment. So new guideline says if you want to actually treat a baby, you need the help of a EEG, because many patients may not show clinical seizure, there may be EEG abnormality.
So the drug of choice is phenobarbital. Levetiracetam is not the drug of choice. Levetiracetam is a drug of choice if you think there is a possibility of an underlying cardiac disease.
Yes.
And lastly, should I treat the seizures even if the EEG report is normal or abnormal? What is the current update?
If irrespective of the EEG or MRI availability, if there is no seizure, we have to stop the drug before the baby is discharged.
So the only, so do not go by the EEG or the MRI to decide. The key point here is if it is an epileptic in origin, what does it mean? Family history, refractory seizures, sequential seizures. You would consider that as genetic, otherwise there is no reason why you would give an extended course of anticonvulsants to any of such
Only
newborns.
thing is that if there is repeated seizure or repeated EEG abnormality and some structural abnormality, in those things you can continue after treatment. So there is no, MRI can tell you the prognosis if there is HIE or some structural abnormality, but MRI does not help whether to start therapy or stop therapy. EEG has got a role. Because to stop therapy, if there is EEG abnormality, at least 24 or 48 hours, baby should be along with the clinical seizure, there is no EEG changes, then you can stop.
Okay. So at this stage, we will stop. The entire objective here was to check our academic pulse from time to time. We may be clinically alive, academically dead, trying to practice experience-based medicine, trying to put in same mistakes again and again, forgetting that we have to look at current evidence and change our practices. Thank you so much for your patient listening.
Thank you.
Thank you so much, expert faculty.
Thank you, Dr. Rishikesh Thakre. May I request our principal to hand over the mementos. Dr. Thakre, the panelists Bijon Shah, Khya Ghoshuttam, Amrita Roy and Devdeep Mukherjee. Please kindly go to the back. So I call upon for the next session, which is endocrinology cases, by Dr. Vaman Khadilkar. Dr. Vaman Khadilkar is going to be introduced by, hey, memento, go at the back. Go at the back. I request Dr. Mautushi Rai Chaudhary. Mautushi Rai Chaudhary has come. So, Dr. Mautushi Dasini? Mautushi So, Dr. Vaman Khadilkar, please continue.
Okay. Thank you. Good morning, everybody. First of all, I would like to thank Dr. Apurva Ghosh, Dr. Jaideep Chaudhary, and the team ICH for inviting me here. And in the coming 20 minutes or so, what I'm going to do is take you through some interesting cases in pediatric endocrinology. So, I've got a huge number of cases, so I would like to finish as much as I could, but at the end of the last case, you might be left with many more interesting cases that I wouldn't be able to complete. So let's move on with case 1. So this is a general overview of pediatric endocrinology. There's no specific theme that I am following. I'm just giving you the flavor. So here is a 4-year, 3-month-old boy who's short. His height is 75, weight is 6.2. And his birth weight was 1.7. He was a term SGA baby. Now, you all know me as IAP growth chart man. So, without the anthropometry, I don't move forward on any case. So, the first thing is going to be plotted on a growth chart. And as you can see here, he is way below the 3rd percentile. So, he is severely short. And I also gave you one important information, he was an SGA baby. Thank you. So this particular slide speaks volumes, and I think any short child that you see in your practice, you should think of this slide first. So what are you looking at? Are you looking at a child who's very severely short or just about 3rd percentile or below that? So if you have got a kid who is just below the 3rd percentile, you are looking at this group: idiopathic, familial, constitutional delay, chronic malnutrition, or SGA. But this baby, despite being SGA, is way below. Whereas the second group is again skeletal dysplasia, hormonal disorders, syndromic children, bone disease, and severe chronic disease. So when they're so short, you are looking at a significant pathology. Whereas the first conditions that you are looking at is physiological, largely, or chronic disease. Now continuing the case, this is his clinical photograph, and there are certain things to note. So this child has a thin face, has a narrow chin, hemiatrophy of the face and whole body, as you can see. See, the hands shown are at the same level, they are not at different level. So significant hemiatrophy, there is limb length discrepancy, impalpable unilateral testes, and a faint murmur. So the question is, what is the likely diagnosis? And normally you would think severe SGA sequelae, or also known as Silver-Russell syndrome. Because of one undescended testis, you must also think of Noonan syndrome, but it doesn't have the classic phenotypic features. Now the genetic test for Russell-Silver is typically uniparental. It can be one of the several mechanisms, but these 3 are the common ones: uniparental, methylation, and as yet unknown. Now when would you treat this child with growth hormone? And the answer is, don't wait too long. When there is a deficit of that degree, start at 2 years. But if the deficit is less, you can wait until 4 years. And how long will you give for? Minimum 4 years. So that's how you would treat an SGA who is severely short. Start at 2 years, give growth hormone, give for 4 years. Many parents by then say that, doctor, we cannot continue any further. So you may have to give a break and restart at puberty. Now let's move on to the second case. Once again, a very severely short child. There's absolutely no history of anything significant on the right side. but the thing on the left side is significant. So mom has hypothyroidism, she also has SLE, and there is a significant family history of short stature. So a whole lot of people in the family are short, and if I show you the family tree, look at that. The numbers in the red are severe short expressed as Z scores. So you have a family where from both sides there are short people, and they are segregated in a variety of manner, but it comes from familial short stature from both sides. Now this is where you see the anthropometry. He is very severely short. He has a Z score of minus 6.4 on IAP growth charts. Weight is relatively spared. Now important clue, weight is relatively spared. So you are not looking at malnutrition or chronic disease, you are looking at a specific disorder of growth. But the mid-parental height score is also minus 2.8. Now as a pediatrician you may not always calculate this, but if you have the numbers which the IAP growth chart application gives you now, the IAP growth chart application gives you the Z score as soon as you enter the numbers, so please use them. So when the discrepancy between the MPH Z score and the child Z score is more than 1.5 SD, 1.5 SD, it's severe even for the family. So this child is short even for a short family. So don't disregard this as familial short stature. That's the important message. So even his BMI is maintained. So that's what I'm saying. You're not looking at a malnourished child. A well-nourished child who is profoundly short. Same is weight for height, well maintained. His proportions are normal. Now this is how he looks. So he has a midfacial hypoplasia, he has a broad toes. See, the great toes are really broad. He also has posteriorly rotated ears, a broad forehead, genu valgum, no joint issues at the moment, no brachydactyly, goiter, genitals are normal, and he is prepubertal. This is how his hands are. Even his even his thumbs are broad, and he definitely has a frontal bossing. Short parents. In fact, mom is a dentist and father is a general practitioner. He is really short even for them. And those broad toes again. Hands are fine. So we followed him for a short time, and his growth velocity is slightly lower. And importantly, his IGF-1 came below 20. Screening for inborn errors of metabolism was negative, and his kidney ultrasound was normal. His bone age using TW3 is advanced. Now this is weird. Normally whenever you see a kid who is short and has an endocrine disease, you normally expect that the bone age would be delayed. But here is a situation where your bone age is advanced. So you're looking at something very different here. So short child who looks like growth hormone deficiency, but his bone age is advanced. So you are not looking at an endocrine disease. And when we did a genetic analysis, and fortunately we have geneticists amongst us here today, he has ACAN gene positive. This is agrican gene. Now agrican gene is known to cause severe profound short stature with an advanced bone age, which gets much more advanced as they become more and more mature. They're born SGAs, they have got these phenotypic features, and ACAN gene leads to relentless progression of bone age, causing very severe short stature. Now this is a situation in which you need to give growth hormone at a much higher dose, which we have started, and the child has actually responded in the first year. In the first year, the child has grown 7 centimeters, which I would consider quite okay, considering that he has an ACAN gene. So the message here, short stature, which was when I learned my pediatric endocrinology at Great Ormond Street Hospital, we were told that short stature is a disease of growth hormone IGF-1 axis. Yes, it is, but only to a very small extent. We now know in 2020s that it's a disease of the growth plate. And ACAN gene causes disease of the growth plate. There are a number of new genes which have come up, like natriuretic hormone, atrial natriuretic hormone genes, NPR2, ACAN, they all express on the growth plates. So short stature, remember, is a disease of the growth plate, and a minor proportion is that of hormonal axis. Let's move on to the next case. 8-year-old girl was admitted to neurosurgical ward for surgery of this pituitary mass. So this pituitary mass was detected because of headache and she was admitted for surgery. This is how she looks. She is short, her weight is well maintained, but she had thelarchy and menarche at 8 years of age. So obviously you are looking at a girl with precocious puberty, but she is short. Now the standard teaching is girls with precocious puberty are tall. This one is short. That's a growth chart. You can see that there is bone age retardation, increasing the chance of an endocrine abnormality, and you have a pituitary mass. So you would think there is a pituitary mass that's compressing the pituitary gland and causing hormonal deficiencies. Her LH is low, FSH is 4.1, estrogen is high, and prolactin, focus on the prolactin. This is elevated prolactin. So are we looking at prolactinoma? No. Prolactinoma would raise prolactin to hundreds and thousands. So this is not prolactinoma. Bone age is retarded. Once again, coming back to that slide, you are looking at a kid who is very short. So you are looking at skeletal dysplasia, hormonal disorder, syndrome, bone or chronic disease. Now let's continue with the case. Her abdominal ultrasound showed that she had massive ovarian cysts causing elevation of the estrogen. So the estrogen is high because of the ovarian cysts. At this stage, we were asked to look at the patient and we did hypothyroid screening, and the TSH is 1250 with a very low free T4. So as I said, her bone age was retarded, so she had hormonal deficiency. Now what's that mass that you are seeing in the pituitary? That's the question, isn't it? Now remember, prolactin would be marginally high if your TRH is elevated, and so would the FSH, because TRH is going to drive both. Hence the prolactin is marginally elevated and so is the FSH, causing ovarian cysts. And here you start her on thyroxine. This is also known as Van Wyck-Grumbach syndrome because they were the first one to describe it. And this was the MRI before, and 2 months after thyroid replacement, the thyroid gland now becomes normal. So what was it? It was not a mass, it was just the hypertrophy of the thyrotropes, because they had to produce so much more TSH that they become big. Very common, every now and then you will see a case like this. So when you see a mass in the pituitary, don't forget to do a thyroid function test. Next one, 14-year-old girl with no signs of puberty, short girl, weight 35, prepubertal. Again, bone age is retarded. So very short girl with retardation of the bone age. This is how she looks. Now I want you to look at this child. Does she look like a 13-year-old? No. She looks much immature. Now the standard teaching in pediatric endocrinology or pediatrics is if your patient doesn't look his or her age, then think of growth hormone or multiple pituitary hormone deficiencies. And also notice the central obesity. Can you notice the central obesity? Now I want you to look at her eyes. There is an obvious squint. Obvious squint. But parents are absolutely certain that this is a recent onset squint. So you have got a girl who is very immature looking, short, centrally obese, pointing towards growth hormone deficiency, and has developed a squint recently. So something is affecting the pituitary gland, and it's of recent onset, it's not congenital. These are her values. Very low LH, very low estrogen, again elevation of prolactin, IGF-1 low, free T4 low, cortisol low, sodium potassium osmolarity normal. So the anterior pituitary hormones are low except one, that is prolactin. Now remember one very important concept in pediatric endocrinology or endocrinology in general, that hypothalamus always has stimulatory role over the pituitary gland. Hypothalamic hormones and factors stimulate the pituitary gland. except one, that is dopamine. And dopamine inhibits prolactin. So if you have got something that is pressing between the hypothalamus and the pituitary, you will have all low pituitary hormones except prolactin. So the prolactin is elevated. So here you know, looking at the prolactin, that I am going to see something there which is compressing the pituitary stalk and the pituitary gland, and that's the MRI. You all must have recognized there is a cystic and solid component that has completely pressed the pituitary and in fact destroyed the pituitary gland. Sadly, this is the acquired form of multiple pituitary hormone deficiencies because of craniopharyngioma. Very sad, and I already told you the interpretation. So hormonal deficiencies due to physical damage and high prolactin due to compression. Next case, 15-year-old boy, primary complaints of micropenis, lack of puberty, short stature. Very short, weight preserved, mid-parental height not very tall. So that's his chart, but once again, way too low, way below the 3rd percentile. Same thing again, so we are looking at a serious form of short stature, and this is how he looks. He looks very similar to that girl, immature, central obesity, micropenis. Bone age retarded, low LH-FSH, low testosterone, low free T4. Here the prolactin is low, so nothing is compressing on that pituitary stalk, but he is not producing prolactin. Cortisol 15 milligram, which is within normal. Again, severe bone age retardation. Growth hormone stimulation test shows all values below 1 nanogram, and that's his MRI. So you can see the pituitary stalk, and then there is a gap, and the anterior pituitary is hardly existing. So this is what is known as the pituitary stalk interruption syndrome, which used to be caused by breech extraction. As the practice of breech extraction has reduced, this is seen less and less. Empty sella syndrome, combined pituitary hormone deficiency, but this patient had PROP1 gene defect. PROP1 leads to multiple pituitary hormone defects. Maybe I'll have one or two cases more and then I'll stop. 16-year-old girl, no secondary sexual character, short stature, height 135, weight 45 kilos. Her bone age is not retarded. Not retarded. So you are not looking at an endocrine deficiency, you are probably looking at a syndrome. And I'm sure many of you will diagnose this. Broad, shield-shaped chest, short fourth metacarpal, no signs of puberty in a girl child, Turner syndrome. So FSH 0.9, free T4 0.9, TSH more than 50. FSH high, primary ovarian failure, IGF-1 normal. Now, why I have put up this case is not to show you Turner syndrome, but remember that with syndromes like Down and Turner, do not forget to check for other causes before dismissing the short stature as syndromic. They often have hypothyroidism, celiac disease, and many autoimmune disorders are associated. So check for those as well, they get overlooked. And of course, you have a very rudimentary uterus, you also have karyotype which shows 45X, single X. My last case, 4-year-old, laughing fits and irrelevant talking, pubic hair growth, aggressive behavior. You can see how tall he is, adult genitals, test is large. Height age 7, weight age 6, he is already in puberty, testicular volume 12. So central precocious puberty, not peripheral. Bone age advanced, LH-FSH pubertal, prolactin normal. His MRI shows a hypothalamic hamartoma. Now, if you have got a patient with precocity and gelastic seizures and a pediculated or pedunculated, it is called hamartoma, you can remove it. But this one is sessile, so you can't remove it. So treated with GnRH analog, fits of laughter continued, he was put on anti-epileptic. I think I'll stop here because I don't have time for many more cases that I have, so I'll go straight to the last slide and let's go to the conclusion. So to conclude my talk, anthropometry and use of growth charts should be a starting point to evaluate all cases after history is carefully taken. Not in pediatric endocrinology, but in every branch of pediatrics and of course pediatric endocrinology. There is no alternative to clinical examination. Hormonal tests need to be interpreted in the context of age, sex, time of the day and the assay method used. Genetic testing has tremendously improved our understanding further. Thank you.
Thank you, Dr. Baman Khalidkar. May I request our principal, Dr. to kindly hand over the memento? Please, sir, at the back. And now I call upon for the prestigious Dr. Shishir Kumar Bose Memorial Oration. May I call upon the stage Dr. Sugato Bose to kindly give a brief introduction, and the deliberation will be given by Dr. Govindo S. Murthy, and he will be talking on clinical and non-clinical roles of pediatric surgeon in NHS UK.
Jai Hind. We are gathered here on Independence Day. So let me begin by telling you in very brief Dr. Shishir Kumar Bose's contributions in India's great freedom struggle. He was just a 20-year-old medical student at Calcutta Medical College when his Ranga Kaka Babu, radiant uncle, called him and asked him, "Amar ekta kaj korte parbe?" That kaj or work was to help plan and execute Netaji Subhash Chandra Bose's Mahanishkraman, or the Great Escape from Calcutta, India. And so on the night of 16-17th January 1941, Shishir Kumar Bose drove his uncle from Calcutta all the way to Gomo station on the first leg of the escape, which was the first step towards the foundation and the building of the Azad Hind movement, the Azad Hind Forge, of which Netaji Subhash Chandra Bose became the supreme commander in 1943. Dr. Shishir Kumar Bose suffered imprisonment in the Presidency Jail of Calcutta, an underground cell of the Red Fort in Delhi. He spent long months in solitary confinement in the Lahore Fort, and finally he was a prisoner in Lalpur jail. After independence, he played a very major role in building two institutions, Netaji Research Bureau at Netaji Bhavan and the Institute of Child Health. His father, Sharat Chandra Bose, had asked him to go back to his medical studies, so he became a pediatrician. It is very apt that Dr. Murthy has come from Sheffield to deliver the Dr. Shishir Kumar Bose Oration. That is because Dr. Shishir Kumar Bose earned his DCH from the Great Ormond Street Hospital in London, which was mentioned by the previous speaker, but then he went for further training to Sheffield and also to Vienna and Bern. And this June, my younger brother Shumantra and I visited Bern, where Dr. Shishir Kumar Bose had spent 6 months in 1948 training with the leading figure in the field of blood diseases in children. And I, as a 2-year-old, had the good fortune of going with my parents, Shishir Kumar Bose and Krishna Bose, to Boston, when Shishir Kumar Bose got a Rockefeller Fellowship to the Harvard Medical School and trained in pediatric radiology with Dr. Ed Newhouser, who was truly a wizard in that field in Boston Children's Hospital. So I very much look forward, along with all of you, to hearing Dr. Murthy's Dr. Shishir Kumar Bose Oration on this day, 15th August, our Independence Day. Jai Hind.
Medallion to Dr. Murthy. So Dr. Murthy.
Okay, thank you. Is there a laser pointer? Laser pointer? নমস্কার, প্রথমেই উপস্থিত বৃন্দের সকলকে আজ ৭৯তম স্বাধীনতা দিবসের শুভেচ্ছা জানাই এবং ডক্টর অপূর্ব ঘোষ এবং ওনার আইসিএইচের অন্যান্য সদস্যদের আমাকে এই ওরেশনটা প্রদান করার জন্য আমন্ত্রণ জানানোর জন্য আমার ধন্যবাদ জানাই। ডক্টর সুগত বোস ইন্ট্রোডাকশনটা দিয়েছেন, সেজন্য আমার এই বিষয়ে বিশেষ কিছু বলার নেই, কিন্তু আমি স্মরণ করি যে ডক্টর বোস এবং অসংখ্য জানা এবং অজানা ভারতীয় নাগরিকদের ত্যাগ, দূরদর্শিতা এবং নিষ্ঠার জন্য আজ আমরা এখানে দাঁড়িয়ে এই ধরনের একটি অনুষ্ঠান করতে পারছি। স্বাধীনতা এবং স্বতন্ত্রতা এই দুটি বিষয়ে দুটি কথা বলা অনুপযুক্ত বলে আমি মনে করি না, সেজন্য রাখছি। খুব সম্ভবত বিখ্যাত এথনোগ্রাফিস্ট ভেরিয়ার এলভিন্স বলেছিলেন যে প্রধানত স্বাধীনতা 5 ধরনের হয়: রাজনৈতিক স্বাধীনতা, অর্থনৈতিক স্বাধীনতা, ধার্মিক স্বাধীনতা, ব্যক্তিগত স্বাধীনতা এবং সামাজিক স্বাধীনতা। এবং গান্ধীজি আমাদের চেতাবনী দিয়েছিলেন যে ব্রিটিশ সাম্রাজ্য থেকে মুক্তি পেয়ে আমরা কেবল রাজনৈতিক স্বাধীনতা অর্জন করছি, বাকি স্বাধীনতাগুলো এখন অর্জন করার জন্য বহুদূর হাঁটা পথ বাকি আছে। এবং এটার সঙ্গে আমি জুড়তে চাই, বিশেষ করে আমি আরজি করের ছাত্র, এবং এই সপ্তাহে এটি উপযুক্ত এইটা বলা যে নারী স্বাধীনতার আমাদের সমাজে আজকের দিনে ভীষণ অভাব এখনও রয়েছে। এবং অবশেষে আমি যেমন তেলুগু আমার মাতৃভাষা, আর এখানে যারা উপস্থিত আছেন বেশিরভাগেরই মাতৃভাষা বাংলা, কিন্তু আমরা এই পারস্পরিক যে আলোচনা করি সেটা আমরা নিজেদের ভাষাতে করার সামর্থ্য রাখি না, আমি তো রাখি না, আমাদেরকে সেই ইংলিশেই ফিরে যেতে হয়, যেটাতে আমি এখন যাচ্ছি। So Dr. Ghosh asked me to present some clinical cases, but I did a reflection before I started this presentation that, okay, looking at my own journey, I've been a consultant pediatric surgeon in Sheffield Children's Hospital for nearly 20 years now, and it's not all been clinical. In fact, at the moment and over the last few years, most of my working time is spent in non-clinical matters rather than clinical matters. Of course, I'm a surgeon, I operate, I'm a clinician, but other things have taken over, and rightly so. It is important to recognize that, of course, a surgeon needs to know how to operate, but most importantly, there needs to be some thought and thinking behind it, and I have therefore put up one of my favorite sculptures by Auguste Rodin of the contemplative thinker. So both those are important, and hopefully through the rest of my talk, I will be able to demonstrate the value of both of these. Also, it is pertinent, me coming from England, I'm nearly 60 years old, I spent half my life in India and half my working life, or most of my working life in the UK. To have a comparison between the two health systems, which all of you are surely aware, but I will reiterate some points, in particular because the delivery of healthcare is very related to those freedoms or the lack of those freedoms that I had alluded to earlier. In the UK, treatment is free at the point of care. There are well-established networks by which referrals are made so that the patient gets the right treatment. There is a transport system for transporting, for in my practice, neonates and children. And clinical decisions are not made by budgets. Whereas in India, while that is our aim, when I was a student, we used to hear the slogan "Health for All" by 2000, but that sadly has not come to pass. Access to specialists is a problem, and various studies have shown that 40% of health expenditure is borne by the individual or the individual's family, with sometimes devastating long-term consequences. So all you clinicians, and I really admire, I've spent the last week in ICH, and I'm overwhelmed by your dedication and your hard work, and how within the limited constraints of finance and socioeconomic factors, how you perform your duty with such dedication and care. And I feel like anything, the history and the context is important. These two graphs demonstrate how much money what percentage of the GDP each of these countries have spent. So currently, the UK spends about 11% of its GDP behind health. No wonder they have a very good health system. Whereas we here in India, since independence, not even in one budget have we been able to spend more than 2% of our GDP behind health. So hence, that is very well reflected in the condition of the Indian healthcare system. But all is not so dark. The infant mortality rate has dropped over the decades from 1900, has come down to 4 in 2019. And incredibly, India, in spite of all the odds, these were the rulers and we were the ruled, we have managed through your dedication and hard work to drop the infant mortality rate to 32. As we know only too well that any graph, the last bit, is the hardest journey, and that's where you're embarked upon now. And I'm sure in the decades to come, it will go down further. So that context is important. So like I have said, I have tried to divide my talk into these various aspects. So I'm going to share some clinical aspects on gastroschisis, bilious vomiting and abdominal pain pathway, and I'm going to share some examples of teaching, patient safety and governance. So gastroschisis, as we all know, is a congenital anomaly where the bowel is exposed at birth, and it is best wrapped in a cling film and IV access provided, and sepsis is most important, and then transferred to the ward, and then it is easy surgery wise it is easy to close the abdomen in the majority of cases. However, an asepsis in the remaining part of the patient's journey is very important. However, the outcomes vary between the UK and in India. In 2012, there was a study that showed a mortality rate from gastroschisis of only 1.5%. Only recently, just last month, my good friend Professor Subhashish Roy Chaudhary from Kalavati Saran Hospital has published this paper, which I admire very much, where they have documented the survival rate is 72%. So there is a long way to go. I will also share two unique cases. One was a male infant with a giant gastroschisis. Normally, like I said, it's easy surgery, you can put everything in, but in this case, we had to resort to various patches, and then they fell apart. And then we used other patches, and over 7 months of time, eventually there was epithelialization with a ventral hernia. So we treated like an exemplars. Recently, we had a gastroschisis that was 24-weeker, only 530 grams. So again, the antenatal diagnosis was made, and we have closed it. The survival of 24-weekers is 60%, so the outcome remains to be seen. But modern technology is making this possible. There is a national campaign in the UK of getting it right first time. The negative appendicectomy rate in the UK is still 10%, whereas in USA and rest of Europe it is less than 2%. For that reason, they have what the new things in appendicitis is twofold. One is to use a scoring system, and I recommend this to the practitioners here because appendicitis very often might come to a pediatrician or a general pediatrician before it reaches the surgeon. To use various scoring systems to try and reduce the negative appendicectomy rate, and also if you treat an appendicular mass conservatively, please do not offer a interval appendicectomy. The evidence is in that direction. Now we are all, as you're fully aware, bilious vomiting in a newborn child can be life-threatening, and the most important thing medically, most of them have sepsis, but you must do an upper GI contrast study to exclude malrotation with midgus volvulus, because there the child has the risk of losing its entire small bowel. But how many of the people, healthcare visitors, general practitioners, or even pediatricians, and very rarely even pediatric surgeons are actually aware of the color of bile? So a study was done where they sent this panel of colors, and asked GPs, parents and midwives to identify what is the color of bile, and it was very surprising that 30% of patients, parents, half of GPs and a third of postnatal midwives did not recognize the color of bile. That has consequences for in both directions, with the patient not receiving the best treatment or not receiving timely treatment. So I would recommend to you in this day of telemedicine and WhatsApp that you carry this on your phone, and if you get a phone call for bilious vomiting, you send them this panel and ask them to identify which of the colors are marked over here. Because the disastrous consequences of non-treated malrotation can be entire gut loss because of necrosis, and that becomes very difficult. Now, like I said, I'm very interested and involved in teaching, and the question to you as an audience is, can someone like me as a surgeon, who usually does the end point of treatment as surgery, be involved in preventive medicine? And hopefully, when I share this story with you, the answer will be yes from your side. So let's look at quickly, just to reaffirm, the normal perineum, just by looking at meconium, this is to do with missed anorectal malformations. A normal perineum cannot be said to be so unless the meconium is wiped off and we look at the normal anus and the anatomy, both in the female and in the male, as shown in the pictures there. I will show you a series of anorectal malformations. In females, that's a perineal groove, a vestibular fistula, and a cloaca where there's no opening at all. Or in males, where you can get anal stenosis or perineal fistula or no opening at all. So with that background, I have a sad story to tell. In 2019, when I was a registrar in one of the hospitals in the UK, a child that had been sent home without with the diagnosis being missed came back at day 7 with pneumoperitoneum and peritonitis and sadly died. 2002, going forward nearly 17 years, we had a child that similarly came, when I was a consultant in Sheffield Children's Hospital, a child came back 3 days later with a missed anorectal malformation, and I could not even operate on this child because the child was so ill and died. So in the UK, there is what is called the NIPE, the Newborn and Infant Physical Examination. It's a national screening program whereby midwives and pediatricians and neonatologists and GPs and community midwives and healthcare visitors are mandated to check every baby from head to toe, and one of the checks is to check for the anus. However, we know now that despite that national screening program, within the UK, 27% of anorectal malformations can still be missed, and worldwide, 22% have been missed in the recorded literature, and this can lead to various complications, including death, as in those 2 cases. This, I believe, is just the tip of the iceberg. There are a lot more cases, but these are the ones that have been reported. Moving forward, in Sheffield itself, in our practice, over the 13-year period, 16% of anorectal malformations that came to us were missed, of whom 19 out of 20 had been sent home and came back with complication, and one of the patients actually died, and 5 had missed vectal problems with other. As we know, if you have an anorectal malformation, they can have other problems, and if you miss the original diagnosis, we miss diagnosing the rest of it as well. So the problem for me and my neonatologist colleague was how do we address this, and we decided that the best way forward was to educate all these people who are involved in the management of these children. And we produced an educational module, We produced an educational module that if you Google detecting anorectal malformations, there is an educational module that teaches people how to look for a normal perineum. Patient safety, as we know only too well, and it is well highlighted by Dr. Atul Gawande from the US's work. If we provide a safe environment, then we are avoiding harm. The less safe we are, the more the risk of harm to the patient, needless to say. So one of the changes in our practice is previously, and it happens in Kolkata too, I'm sure, the surgeon is doing an outpatient or actually practicing in another hospital, and then he says, start the operation, anesthetize the case, I'm on my way. We also used to do that, I used to do that, but that is no longer possible in our practice. I have to be present in the hospital before the case is started. So we have changed, I have had to change my behavior in order to enhance the safety of the care we provide. I don't know if you heard of never events, but the Department of Health in England has specified 14 never events. It's actually a misnomer. in that these events should never happen. 3 of them, as highlighted there, are related to surgical care. One is wrong site surgery, where you take out the wrong, one is wrong implant or prosthesis, and retained foreign body object or post procedure, like leaving behind. We look in the news and we hear about a swab being left behind, for instance. In the UK, in 1 year, there were 370 recorded never events. So I wonder how many of those are happening in India, for instance. And that is more or less 1 every day. So in a very safe, well-funded system, harm is still happening. And why is that happening? As you will see, there were 179 cases of wrong site surgery. There were 81 cases of foreign object left behind and wrong implant in 37 cases. And actually there is a name and shame list of all the worst hospitals with regard to these never events. So there is information for the public there. So what's happening in Sheffield? When I took over as a lead of clinical governance about 5 years ago, on my inbox was 6 never events had happened. There were 7 serious incidents and 94 near misses. And you may be aware of this, the Heinrich or the accident pyramid. If there is one crash of an aeroplane, it is seen in the background there are 30 near miss, 30 incidents that have happened that are low grade. They have not killed anybody, but they are low grade. And further down there are 300 near misses. So what the bad thing that we see at the top is because of lots of little problems that are happening at the bottom. So we need to tackle the fundamental base, the base of the pyramid, if you want to avoid the bad things that are happening at the top of the pyramid. So what were the 6 never events that happened in Sheffield? One was a wrong injection given to a patient. One was a wrong site incision. 2 anesthetic blocks were put on the other side, like on the right hand instead of the left hand. 1 wrong surgery was done. They took the wrong organ out, and there was 1 retained foreign body. So I was scratching my head as to why are these happening? These are all experienced pediatricians, anesthetists, surgeons, yet this is happening to them. And why is that happening? And I think that is because of human error. Now, what is human error? That's very difficult to define. But there is this new science that is well established in the airline industry, but is coming into the health industry as well, which is human factors. Because we all are human beings, we are prone to error. Sorry. So when we walk, do we walk straight away? When we learn to ride a bike, are we able to do it? No. We make mistakes, we fall, then we get up and learn. That is the intrinsic nature of learning, that it is error prone. Why will it be any different in the healthcare setup? So we are prone to making mistakes. It is our desire to try and design a system whereby safety is enhanced. So if we study these cases, and if we then design a system whereby safety is enhanced, like me having to be there before we send for a patient, then, and that science is human factors, where we study human behavior and try and remove the errors out of the system. Sorry for that. And I also see in the UK, there is a lot of restrictions on the number of hours that people work. Here, especially the surgical registrars in ICH are working endless hours, and there is no stop. There is a huge population, there is a huge demand, and you can't stop. But it has been seen that 17 hours of wakefulness is equivalent to a blood alcohol level of 0.05 milligrams per deciliter. And what does that mean? At that level, you are not functioning very well. There is reduced coordination, there is a reduced ability to track moving objects, difficulty steering, and slower. So if you are a driver, you shouldn't be doing that. Why as a doctor should you be allowed to do that? Why should you be working so long for so many? That is something for all of us to reflect upon. The new thing that is now doing the rounds in the UK is civility. Have any of you been rude at work? Have any of you suffered someone else being rude to you at work? And the answer to both those questions, for myself included, is yes, we have been rude at work, and we have also been subjected to rudeness at work. What does that do? It reduces, if someone is rude to me at work, if my consultant shouts to me at the beginning of the day, the rest of the day, my cognitive ability, and scientific studies have shown, is reduced by 60%. So I will not assist well in the theater, I will not behave well with the patients, and therefore there are higher likelihood of mistakes happening. And it has also been seen in studies on behavior and of nurses that if somebody has been uncivil to them, there is a 50% increase in their chances of making a drug error miscalculation. So there is an increasing, just like human factors, there is an increasing recognition of these factors. So like I said earlier, this was the problem that was in our inbox. What did we do about it? We created a human factors faculty. They went away and got trained by airline pilots. The airline industry with their simulation and everything are best with regard to this, and they got trained, and we created a human faculty team. There's 150 theater staff in our department, and over a 2-year period repeatedly we provide human factors training as a half-day course to try and reduce the hierarchy difference between consultants and the rest of the team so that the flow of information is better. So in conclusion, ladies and gentlemen, when I started as a young surgeon, and those who are here in the audience that are my surgical colleagues will surely agree, I was very interested in operating. I just wanted to get the operation right. But over time, of course I can operate, but more and more my registrars operate, I train them, I'm interested in outcomes. In other words, in the beginning I was interested in structure, now I'm interested in function. And I'm interested in education, like I've shown with the missed endorectal malformation E module, in enhancing our outcomes. And I try and follow the science. Every day go to work, I'm aware and I'm reflective about how my behavior as a healthcare professional should be, and I follow the science to try and reduce human error, which we can only do, of course, by increasing the funding, but also by changing team behavior, improving the system design, and providing training. Thank you.
Thank you, Dr. Govind Murthy. Before I call upon Dr. Kishan Chuk, let me have the honor of, today is the Independence Day. May I call upon our patients of Minalini Cancer Research Center to have our national anthem sung by them. Dipshika, please, you also come. Dipshika, and where is Dr. Sneha? Dr. Sneha Agarwal? Not come. Sneha, if you are here, please come.
Hello.
So good morning everybody. On this Independence Day, we have our little warriors from the Minalini Cancer Research Center, Institute of Child Health, Kolkata. Also accompanied with them are their mothers. So they would like to pay tribute to the country today.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंग बिंदु हिमाचल यमुना गंगा उज्जल जलधित रंग तब शुभ नामे जागे তব শুভ আশিস মাগে গাহে তব জয় গাথা জনগণ মঙ্গলদায়ক জয় হে भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
আমার নাম প্রণতি সর্দার
and this is little Rian.
শুভশ্রী রায়চৌধুরী শৌরি
Shouri.
ওমাইরা তাহের
Sheikh Mohammed Zubair.
Thank you on behalf of Team Pediatric Hemato-Oncology ICH Kolkata.
So, thank you, please come down. So, may I call upon Dr. Kishan Chub? Please, sir. Dr. Kishan Chub will be talking about difficult to diagnose respiratory cases.
इसको ऊंचा कर दो। Good morning, everybody. Good morning to all the ICS present and past members, and a big thank you to all of you for giving me this opportunity to be here in this city of joy on this auspicious day, the important national day, the Independence Day. My talk today is on pulmonary cases, and unlike the endocrine cases, I'll take a few of them and go into somewhat more details into each one of them and see how many we can cover. I've listed only 3. So let's start. First case is this who had mediastinal lymphadenopathy, nodular lung shadows, and we will try and decipher this case. He had a fever of 30 days. It's a 15-year-old boy, 41 kg, well grown. Cough of 45 days, no sputum. There are night sweats, decreasing appetite, and no response to antibiotics. This is the X-ray. You can see mediastinal nodes there and a small nodule there, which probably is not as clearly seen. We'll come to that. This is the date on which first X-ray, 6th, 12th, 6 days later, another day, another X-ray. These are all done before coming to us. And a CT scan was done on this date, and the CT scan was reported this way. CT findings are suggestive of ground glass opacities in right upper lobe with nodules in right lower lobe with mediastinal and hilar lymphadenopathy, likely infective etiology, Cox to be ruled out. Please correlate clinically, the standard language of our radiologist friends. This was the CT scan. As you can see, large nodes there all over, lymph nodes basically, and these small nodules which I have pointed out were seen on the lung windows. These are the nodules, as you can see, along the fissure, along the horizontal fissure. This was 14/7, and exactly 2 months later, when the child was already on anti-tubercular treatment, this was the CT scan, X-ray, which is very similar. So what should be our next step? At this time, ATT had not been started, and the question was, should we start? And it was started, the first line ATT. The patient improved in 2 weeks. There was no fever, night sweat settled slowly. Activity and appetite improved. 6 months ATT was completed. However, there was a recurrence. Symptoms reappeared in the beginning of May 22. A few months only had passed well. Night sweats were very, very disturbing. They consulted a pediatric pulmonologist and repeat investigations were ordered. 14/9, Next year, 35, it looks something similar, not much of a change. So question is, what should be our approach at this time? What are the possible causes for this recurrence? A CT scan was again ordered, and as you can see, again there are lymph nodes. Large ones, slightly different in their location, but they're still very large. And they are nodules. In fact, the nodules seem to have increased. There are many more. They are peripheral, they are along the horizontal fissure, as can be seen here. Ground glassing, which was not there earlier, is also seen now. Just enlarging those to show you those nodes, and again enlarging this side to show you the small nodules. Ground glassing, better seen here. Again, on this picture you see everything, ground glassing as well as all other features. The tiny nodules, again, as you can see, they are peripheral as well as along the fissures. So what does this distribution of nodule pattern tell us? If it's a random distribution, more likely that it is miliary tuberculosis, fungal hematogenous metastasis, or LCH. That means basically a blood-borne distribution. Centrilobular are seen in hypersensitivity pneumonia, bronchitis, infectious diseases, bronchoalveolar carcinomas. And the perilymphatic ones, which are there in our patient along something like this, are seen in sarcoidosis, silicosis, lymphangitic carcinoma, and amyloidosis. So, 3 different categories, and our patient falls in the lowest one. So, large mediastinal nodes are still there, no necrosis in nodes still, multiple small nodules in the lungs which have increased, and there are areas of ground glassing. So, lab investigation, CBC is normally, SR is nothing specific, ACE is very high. Angiotensin converting enzyme is high, normal in our lab is up to 60. Induced sputum, expert is negative, ZN stain is negative. This is the spirometry, I'll show you in some more detail. Here is the crux that both FVC and FEU1 are more or less similar, which indicates it's a restrictive lung disease. And when we did the volume studies, this is what we found, that total lung capacity of the lung is low, and DLCO, the diffusion studies are also showing a poor diffusion, a somewhat decreased diffusion. And when we put all these findings into this algorithm, we come to this conclusion that it is an interstitial lung disease. So now the questions come again. What should our next step be? Should we restart ATT? Should we consider second line ATT or MDR tuberculosis? Or should we investigate further? So we decided to investigate further. We did a bronchoscopic examination of the airway, bronchial lavage, cryo lung biopsy, EBUS for endobronchial ultrasound guided TBNA, mediastinal lymph node aspiration, and a ROSE rapid on-site examination by the pathologist right in the bronchoscopy suite to tell us, yes, we have given him a good sample. So that is what we are doing. He is there doing a biopsy using this C-arm and a cryoprobe. We did an ultrasound guided TBNA through this port, and this is where we stationed our needle to go into this node, which is shown graphically, and here it is shown in the video. As you can see, this is the lymph node. There is the picture-in-picture showing where the bronchoscope is, and here is the needle coming in and out. We jab, and that's what we get. Lymph node, needle passed, jabbed, material aspirated, given to the pathologist, who tells us, yes, there is enough tissue. I'll give you the full report tomorrow. And the report comes, primary bronchial lung biopsy, granulomatous inflammation suggestive of, granulomatous inflammation suggestive of infective mycobacterial etiology. They are saying it is mycobacterial, although it is pathology and not microbiology. Same block somehow was taken, the same tissue block was taken by the parents to another group of pathologists, who have substantial experience in pulmonary histopathology. In fact, the group where this sample went is the guru of our own pathologist. So she also agreed, yes, second opinion should come from there. And this is the second opinion. Granulomatous inflammation, interstitial location favors sarcoidosis. However, moderate lymphocytic infiltration and the larger peribronchial granuloma favors tuberculosis. This is what the guru says, both sarcoidosis and tuberculosis. So what do? We are the clinician. I have to treat my patient. What should I do? So I started the child on first line ATT again, added oral steroids, made my diagnosis as sarcoidosis but not taking a risk for tuberculosis. Waited for the MTB culture report to come. We stopped the ATT after the culture came in negative, which was about 8 weeks. Low dose steroids were continued. Child did well. So our question is how to differentiate between the two. Tuberculosis, if you see causation, probably almost 100% against sarcoidosis. TB export would be positive in tuberculosis, negative in sarcoidosis. TB culture would be positive, would be negative in sarcoidosis. Necrotic nodes would be seen in tuberculosis, not seen in sarcoidosis. Remember, our nodes were not necrotic. Effusions are seen in tuberculosis, not in sarcoidosis. Nodule distribution is random in tuberculosis. It was nodule is perilymphatic, which we showed you in some detail that it was perilymphatic in our patient. ACE would be normal in tuberculosis. It was high in our patient. And serum calcium would be normal. Serum calcium was slightly high in our patient, not really beyond the range. After 2 months, all those nodes have become much better. ACE has fallen to 63, ESR is okay. So we think we made the correct diagnosis. Why the differentiation is difficult? Because sarcoidosis and tuberculosis are both granulomatous diseases. Present with similar constitutional symptoms, respiratory symptoms, multiple organ involvement, hilar and mediastinal lymph node involvement. Hence, the diagnosis of one from the other may pose significant difficulties. In fact, I have deleted some slides which also say that sometimes the two can coexist. So, it's a difficult situation. Thankfully, sarcoidosis is not common in children. Second case. Okay. This patient came with cyanosis and clubbing, and we had to decide what to do. This patient came in February 25, very few months back, developed fever which was high grade, followed by weakness of right upper limb, followed by right lower limb. She was admitted in hospital in Iraq. MRI done showed on 18/2/25 showed a left parietal lobe abscess in the brain. Started on medication, multiple IV antibiotics, meropenem, vancomycin, liposomal amphotericin B, voriconazole, and so on. MRI brain was repeated on 13/4, 2 months later, and on 18/5, poor response. Past history of left hemiparesis was also there. This time it was right hemiparesis, earlier it was left hemiparesis, and that was also because of a septic emboli, probably an abscess. That was a year back, 2 years back almost, 1.5 years. So respiratory rate was 20 per minute, cyanosis were there. This is a peculiar finding, brain abscess having cyanosis, bluish discoloration on nail beds, lips, tongue, everything, no doubt that's a central cyanosis. SpO2 in all 4 limbs, 80, around 80. Clubbing, grade 4 present. Chest is normal, CVS is normal, abdomen is normal, CNS, there is mild hemiparesis still persisting, although she is fully conscious and can walk around with a hemiplegic gait. TLC, DLC, everything looks okay. Left TKFT is normal, CSF is done, and it shows no cells, gram stain, everything negative. Multiplex PCR is negative for bacteria and cryptococcus. Smear for expert TB is negative. Echocardiography is normal at our place at the Fortis Research Institute in Gurgaon, which was done twice before coming to us and once by us. This is the abscess. So the report is that this is an abscess of so many millimeters and all. On post-contrast study, there is areas of heterogeneous enhancement are seen with mild peripheral rim enhancement. This is important to the surgeons. And further, functional MRI mapping is again important to the surgeon who says, I cannot touch this. If I touch this, motor fibers will be damaged. So it is a medical case to be handled by Dr. Chok's unit. So our questions are why the cyanosis and why the hypoxia, why the clubbing, and why recurrent abscesses. Obvious answer, is there an unrecognized, undetected right to left shunt, something like a fellow's tetralogy. But we have done echocardiography thrice, it is totally normal. I'm just reminded of another case that I saw many, many years back. This is the child, not this current one, this is a past child. You see a opacity there, this opacity would be there for months and months, and that was the child, again had cyanosis. You can already see blue lips there. This child had this CT scan, nothing much, till we did this scan. And there is the answer. A big pulmonary arteriovenous malformation. That was that case. But what about this one? We did a CT, contrast CT, nothing. It is a normal CT. Triple phase CT scan of the abdomen was done to see if there is anything in the liver around anywhere in the brain, in the abdomen. Brain has been checked, chest has been checked. So we checked for a shunt in the abdomen, and this is what we found, Abernathy malformation type 1B, which says the superior mesenteric vein and the splenic vein join to form the portal vein, but the portal vein does not go to the liver, but goes and drains into the inferior vena cava. So this is what was happening. The portal vein has been formed, but it drains into the IVC and does not go into the liver, which it should have gone. So those are the pictures of my patient. So you can see it is going into the heart, the inferior vena cava is going into the heart. This is the superior mesenteric vein, that is the splenic vein, joining together to form the portal vein, which is draining into the inferior vena cava. Same thing is seen here, and this is a reconstruction by my colleagues in the radiology department. So key characteristics, pulmonary issues are there. The patient has a hepatopulmonary syndrome in this kind of situation. And that hepatopulmonary syndrome is a lung complication, liver disease, characterized by abnormal oxygen levels in the blood due to dilated blood vessels in the lungs, which are small vessels. They will not be picked up by any CT scan or CT angios. Treatment is liver transplantation. So portal vein is seen draining into the intrahepatic part of IVC to suggest portosystemic shunting, Abernathy malformation. Shunt found, we are very happy, but this shunt is a veno-venous shunt. Left to left, sorry, right to right. There is no right to left shunt. Venous portal vein has gone into the inferior vena cava, which is again a vein. So our point is not fully explained, so we'll look for this. Contrast echocardiography is done, which is supposed to be gold standard for proving hepatopulmonary syndrome. That shows that we inject a few air bubbles into the vein, into the venous circulation, and see what happens. That these air bubbles go in from the pulmonary artery. This is the left side, and they are going to the right side. Pulmonary veins are making these air bubbles go into the from the atrium to the. So significant reduction was seen in the patient. So we have an explanation why the problems are there. Significant reduction in the MRI brain is seen on this date. Further treatment still is going on. We have lined up the patient for liver transplant, which hopefully will be done next month. Okay, a third case. This patient had possible malignancy, possible tuberculosis, possible necrotizing pneumonia, or let's see, cough for 1 month, fever for 10 days. Child was apparently well, all right for 1 month back when he started having productive and cough, which is associated with pain in the left upper part of the chest. Sorry, right upper part of the chest. There was no diurnal variation or blood in the sputum. Cough increased in frequency and intensity over the past 15 days. Child also had a fever spiking up to 100 degrees centigrade, used to decrease with antipyretics, and there was nothing else important in the history, except that he is a known asthmatic. On examination, nothing very specific there, no hypoxemia, no pallor clubbing cyanosis, oral cavity is normal, respiratory system is normal, no adventitious sounds. Well, he comes with a blood count of 22,000 with volume of 71% and eosinophils of 0.2% only. His other reports are okay. His ESR is high, the rest are normal. His AB stains and the smear examination are negative, and immunoglobulins are MGA are normal, E is high. There is a small nodule plus a large opacity. CT scan shows this picture, a cavity, some variegated kind of non-uniform opacity there, which can be seen with more cavities around. This is the lung window showing more nodules separately, many nodules around besides the original large opacity. So what is the diagnosis? CT was reported this way. This is from Patna. Large irregular heterogeneously enhancing mass lesion is seen in the right upper lobe, and it is possibly neoplastic. This is the report. Refer to Medanta, Pediatric Hematology Department, where everything is tested again, and it is found that PET scan is also done. They say it is not a malignancy. Immunodeficiency panel also negative, and no evidence of chronic granulomatous disease. No evidence of malignancy, no evidence of CGD, so possibly ABPA, TB to be ruled out, referred for bronchoscopy and further workup to me in Fortis Hospital. This is what we do, bronchoscopy, and we find this material coming from inside. This material is pulled out, tested, and what we find is in the bronchial lavage, everything is negative. Galactomannan is positive, which is a sign of fungal disease. So is it ABPA? Is it malignancy? Have we really ruled it out? Is it tuberculosis? Have we ruled it out? And should we do a lung biopsy? So ABPA, we look at I'll take a minute more. ABPA diagnostic criteria are given here, that there has to be a background of CF or cystic fibrosis of asthma, exacerbation of symptoms, bronchiectasis, total IG should be high, aspergillus specific IG should be high, and aspergillus antigen should be positive. These are the stages, but we also had all these positive. We treated just with as ABPA with itraconazole and steroids, and after a few days, this is the X-ray more or less cleared. So what did we learn? That originally it was interpreted wrongly. Whenever bronchiectasis is seen and it is central, cylindrical, cystic, all kinds are seen in one patient, high attenuation mucus, ham, denser than paraspinal muscle, 80 to 110 Hansfield units, this is a pathognomonic sign of ABPA. Multiple impactions and all these were also seen in our patient. So this is another patient showing similar changes, and this is also ABPA. You see the same thing there, ham. So if ham is seen, it is tuberculosis and not anything, sorry, it is ABPA. That clear should have been the diagnosis from the beginning. So we were taken around because of a long CT reading. Thank you so much. Thank you, Calcutta.
Interesting is the pediatric dermatology. We have been 20 minutes time. Report.
Good morning, and thank you very much. Sincere thanks to Paulson's Derma for not only sponsoring this particular session, but also giving huge support to pediatric dermatology and pediatric skin care in our Institute of Child Health. Thanks to Mr. Parthopal, MD of Paulson's Derma, who is present here. Well, we do not know, none of us know actually what President Donald Trump has got on his plate and President Vladimir Putin has got on his plate in Alaska to offer on the table. But I can tell you for sure that I have got a plate today, a bouquet of pediatric dermatology interesting cases, common and interesting cases. So let us come to the cases. This is the story of a 10-year-old boy who presented with eczematous skin lesions, high fever, fatigue. Skin lesions were present since 2 years. However, fever and fatigue developed over the last 2 weeks when the patient got admitted. It was earlier diagnosed as atopic dermatitis. At this time, some new lesions came up. So please do remember that I don't believe in monologue. It will be an interactive session. So you have to interact with me continuously. What do you think? What do you think? What is the previous lesion I have told? Atopic dermatitis. What are the current lesions? You can see, this clustering of vesicles. Can you see? Clustering of vesicles. Yes? Correct. I can hear the correct answer. See, there is nice clustering of the vesicles on an erythematous background on the ear rim. This is suggestive of herpes, isn't it? Herpes simplex. So, in an atopic child with atopic dermatitis, moderate to moderately severe and extensive herpes simplex, what is the diagnosis? Yes, eczema herpeticum. You are spot on. Eczema herpeticum. But diagnosis is just a small part of it. You have to remember that eczema herpeticum is a medical emergency. Please don't treat any child of eczema herpeticum on ambulatory basis. Immediate admission should be the first advice. And the child was admitted because the child needs IV, acyclovir for 5 to 7 days. This will be followed by 4 to 6 weeks or sometimes even more of oral acyclovir, because this is very notorious for relapse. And just see, within 48 hours the fever subsided, and what you see, the subsidence of the skin lesions, this occurred after 10 to 14 days. Keep on seeing the lesions, how they have cleared so nicely. There was no immunodeficiency. We did all sorts of immune deficiency parameters, including HIV and everything, so all came negative. Coming to another case, 3-year-old girl, history of mild fever for 10 days, skin rash for 7 days. Anything crosses your mind? You see the clustering of the lesions here also. Can you see the clustering of the lesions? I will show you a better picture. See the clustering of the lesions. As if the vesicles have collapsed. Right? So, what it is? And there is a background eczema here also. But this is a different virus. This is a virus for hand, foot and mouth disease, Coxsackie. So this is called eczema coxsackieum. Nowadays it's not uncommon, fairly common, rather it is underdiagnosed. So this is how hand, foot and mouth disease presents. The difference is with mostly varicella or chicken pox. I have seen many cases in my practice being diagnosed as chicken pox and given acyclovir. Please don't do that. And also don't give acyclovir with a diagnosis of hand, foot and mouth disease, because acyclovir simply doesn't work in hand, foot and mouth disease. It is a Coxsackie virus, RNA virus. Acyclovir works against mostly DNA viruses. Please do remember that. Because if you give acyclovir, parents will go to the net and they will search, they will see that there is no role of acyclovir written. Next day they will come and charge you. So be careful about that. That is the reason you should not give. Clustering of the lesions over the palms looks exactly like varicella or chicken pox. But what is the difference? Anyone? Difference is these are all monomorphic lesions. See, these are all monomorphic lesions. There is no underlying erythema. They are not polymorphic lesions like chickenpox. They are all vesicles, and this type of clustering, just like grapes, is very much suggestive of hand, foot and mouth disease. Like this. This doesn't occur in chickenpox or varicella. Ulceration over the mucosa. How many of you have thought that what is the difference between our ulceration of mucosa in hand, foot and mouth disease and chicken pox? Ulceration of the mucosa mostly in hand, foot and mouth disease is over the tip of the lip, tip of the tongue, inside the lip, on the lips, or maximum over the anterior aspect of the palate. Chicken pox, it is mostly the posterior, though some vesicles may be seen. It is not written in anywhere in the textbook. This is what I am telling from my experience. So that's why you need to attend such seminars. So this is hand, foot and mouth disease, this is chicken pox. Another very important difference is that you see a child and you think that this may be chicken pox, but you can immediately make a diagnosis. You see the child is running around in your clinic. Only the parents are worried. It cannot be chicken pox. Chicken pox children are very sick, just like the sick-like look of the child having high fever. In hand, foot and mouth disease, by and large, there is no fever. If at all, it is of very mild degree. Polymorphic lesions. You see some lesions are vesicle, some are collagen vesicles, some are papious, some are macules, like this. This doesn't occur in hand, foot and mouth disease. As I said, you have to look inside the mouth. When you are suspecting chicken pox, examination of the palms, soles and inside the mouth, particularly the palate, is extremely important. And if you look at the palate, you see where are the lesions located. See. Can you see? This doesn't occur in hand, foot and mouth disease. Please do remember. Yes, mostly it is on the posterior palate, posterior aspect of the palate, but sometimes one or two vesicles you may see on the tongue also, tip of the tongue, like hand, foot and mouth disease, but not very common. So these are the mucosal examination as well as examination of the palms and sole in varicella. Okay, herpes zoster is not, common by and large in pediatric age group. Can you raise your hand? How many of you have seen herpes zoster in children? See, so few. There must be, nearly 800 to 900 people inside. I could see hardly 18 to 20 hands raised. That means chicken pox, herpes zoster is not uncommon. Not common in children, sorry. But please do remember one thing. This is very well delineated. Ophthalmic division of the trigeminal nerve, and tip of the nose you have to see, examine for corneal ulceration, which is known, or erosion, which is known as Hutchinson's sign. But see the well demarcated dermatomal distribution of it. Why I am telling and emphasizing repeatedly, there is a reason. Reason is, what is this case? This case was particular case when brought to me. This is the doctor's, daughter. Already been given acyclovir by 2 doctors. And you see here the pattern is absolutely bizarre. There are hardly any vesicles and their zigzag doesn't follow any dermatome. I'll show you more pictures. Look at it. Eyelid is swollen, and the moment you see, you ask only one question to the child. What do you feel? Do you feel that somebody has sprinkled acid on your skin? The child will say, yes, it is burning, doctor. It is burning, as if somebody has poured acid on me. And that makes the diagnosis that this is insect bite hypersensitivity. Insects have crawled the way they have crawled, they have left behind their marks over there. So this is not well delineated like herpes zoster to a dermatome. It has got nothing to do with the dermatome. Insect doesn't move in a dermatome. Insect is not a neurologist. So this is insect bite hypersensitivity mimicking herpes zoster mostly. Well, this 3-year-old boy was brought to me, 2-year-old boy was brought to me by the mother, saying, doctor, that my child is having this for nearly, 1 month, and so already received 2 courses of antibiotics and now subsiding. Do you have any clue what it could be? Excellent, brilliant. So I immediately suspected, retrospectively, probably if the child would have brought to me, I would have also thought of a bacterial infection. I'm just kidding, I would not have thought, certainly. But there was rationale of giving antibiotic. But when two courses of antibiotic failed, you are left with no other option but making a diagnosis of herpetic whitlow. I gave acyclovir and you see the result of it, just after 7 days. I was just wondering how did herpes affected the child's thumb like this. Then I saw the mother just is touching the thumb of the child in my clinic only, and the mother has an ulcer on the lip. Immediately I got it. This is a show of affection of every mother to their children. That is how the child got it. Well, I am sure that there is no difficulty in making a diagnosis here. Do you have any difficulty? No. What it is? Whenever you are in doubt, search for web spaces. And another area, don't forget, umbilicus. So this is a straightforward case of scabies. Diagnosis is not difficult, but difficult is treatment. This is, I am telling you from my experience over last 3 decades in pediatric dermatology. Most difficult part of treatment of scabies is the proper treatment. You won't believe over last 6 months, at least 16 children have been brought to me with scabies, treated partially, permethrin given not for enough duration, not for enough frequency, not simultaneously all the family members were given permethrin. They said casually, apply permethrin. They didn't apply. As a result, ping pong infection kept on occurring. And another thing I am giving you, this is also not written in any textbook anywhere, my experience. Whenever you see the scabies is not responding, give a course of anti-staphylococcal antibiotic. My favorite is augmentin. Give an anti-staphylococcal antibiotic for 7 to 10 days. Most of the time secondary infection prevents the proper permeation of permethrin into the skin after application. Another issue is, if there is atopic diathesis or atopic dermatitis, this child is less likely to respond to only permethrin. Sometimes we have to give a topical steroid, or in bad cases even oral steroid also have given for short duration, 7 to 10 days. Scabies in children very typically affects scrotum, and as you can see, these are the classical burrows of scabies, burrows and nodules of scabies. In newborns, it produces vesicular lesions. So don't mistake it as epidermolysis bullosa. I have seen, what I am saying, I have seen it then being diagnosed as epidermolysis bullosa by someone. So this is nothing but neonatal scabies. You don't have to treat it separately. You treat scabies with permethrin and everything will be fine. Everything will go. Give anti-allergic and antibiotic. By and large, I try to treat them with antibiotic also if I see they have already have received number of courses of permethrin and not responding. Let us come to some spotters, quick spotters. What is this diagnosis? Suckling blister, excellent. Neonatal suckling blisters. What is this? If you go to NICU, then you can make the diagnosis. Many, it's erythema toxicum neonatorum. Only thing that parents are worried, my pediatrician colleagues are sometimes worried, I have to allay the anxiety of both. Look, name is toxicum, but it is nothing toxic in it. If you are suspecting a septicemia, first of all, the child will be having a lot of other symptoms, features of septicemia. Second is the child is quietly sleeping. And if you still have doubt, just scrape one of the pustule or papule and see it under the microscope, stain it with gyms and see under the see under the microscope. If you see neutrophil, there is a chance of infection. But by and large, you will see eosinophils, which suggest it is erythema toxicum neonatorum. Only treatment is good counseling of the parents. My last case. What is this? I have kept 3 minutes for you to ask questions. You see, amputation of the fingers, intrauterine. Look at the band. Do you remember anything? This is This is amniotic band syndrome, also known as constriction syndrome. So all these pictures are from my book. I am sure many of you have seen, Color Atlas and Synopsis of Pediatric Dermatology. This is the 5th edition, and I am pleased to share with you, this happens to be currently the only book in the world in pediatric dermatology in skin of color which has seen the light of 5th edition. And I was invited to present, thank you very much. Thank you very much. I was invited to present on this book in recently World Congress of Dermatology, which is a once in 4 years event in the city of Maradona, Buenos Aires, Argentina, on this book. So there was a book presentation and I was invited to present on this book. There is a very good sale of book all over the world, and I presented there my journey over 25 years, from 2000 to 2025, 5 editions, 1 edition each 5 years. That's it. Thank you very much. Jai Hind.
Thank you, sir. Now I would request Dr. Arup Roy to present the memento to sir. Up next, we have our next discussion of changing clinical scenario of pertussis in recent times by Dr. Ritobroto Kundu.
Pointer. Pointer nahi? So, good morning everybody. So, just like every year we celebrate the 15th August as an ICH annual day, and today I'll be talking a little bit about the changing scenario of the pertussis. These days we have come to diagnose pertussis very often, and one of the reasons is that we are doing a PCR from the nasopharyngeal swab, and as we thought before, the pertussis is a disease of young infants, but now we are coming across pertussis in different age groups. So at the outset, I'd like to say this is a sponsored symposia, and I myself not, but our hospital has received grant from GSK, financial help from GSK because of this symposia. So you see the number of pertussis cases is not that high, but it does not reflect the true situation because we hardly report pertussis when we come across. The burden of the disease is much higher than seen. And now if you consider the bacilli, pertussis, Bordetella pertussis, it contains numerous antigens, some of which are immunogenic, some of which are pathogenic, some causes protection on these. The wholesale pertussis vaccine has all the antigens, but the antigens used by acellular pertussis differs from vaccine to vaccine. All the vaccines contains pertussis toxoid. This is the number 1. Number 2, the next is filamentous hemagglutinin. Number 2. Number 3 is pertactin, and beside this there are 2 fimbriae. One is type 2 and type 3. And based on this we have 1 component, 2 component, 3 component and 5 component vaccine. The 1 component vaccine contains only pertussis toxoid, it is not found in our country. The 2 component vaccine has pertussis toxoid and filamentous hemagglutinin. This is marketed by Sanofi Hexaxim. The 3-component vaccine contains pertussis toxoid, filamentous hemagglutinin and pertectin. This is the Infanrix Hexa, and there is also a 5-component vaccine, and each claims to be better than each other. Let's see what's actually the situation is. So we will talk about the pertectin, which is the 3rd component of the 3-component vaccine. Pertectin has 2 very important roles. Pertectin helps the body tail of pertussis to cling or bind to the ciliated respiratory epithelium. Not only that, it prevents neutrophil mediated clearance of body tail of pertussis. So it helps in the pathogenesis by these 2 ways. Number 1, it helps to body tail of pertussis to adhere to the respiratory ciliated epithelium, and also the clearance of body tail of pertussis won't be there if you develop antibodies against pertectin. Now, after the introduction of wholesale pertussis vaccine, it was seen that the strains of body tail of pertussis started lacking pertectin. In the year 2014-2016, pertectin negative strains were in the tune of 15 to 25%. This was the survival advantage of this bacilli against the vaccine. Next, in 2017-20, pertectin negative strains become the majority of the circulating strain, peaking as high as 65% in 2018. But the situation 3 or 4 years down the line changed. In Belgium, it was seen that in year 2021-22 there was no pertussis cases, but there was an extreme surge of pertussis cases in the next year, 2023. And ELISA and whole genome sequence showed that all clinical isolates of body tail of pertussis became pertectin positive, which was negative before. And the most strains post-COVID was pertectin positive. In France, where quantitative PCR was done to diagnose whooping cough, the number of cases of whooping cough increased from 495 in 2023 to more than 5,500 in the first 5 months of 2024. And of these, 99% produce this pertectin. In contrast to isolated collected in France just before COVID-19 was only 50%. So also in Slovenia, in May 24, 100% of the isolates who were body tail of pertussis positive pertectin. So what we have seen in recent years, the number of body tail of ER diagnosis is becoming pertectin positive. And if antibodies against pertectin is not there, this body tail of pertussis is not going to be phagocytosed or not going to be killed. When they are incubated with anti-pertectin depleted serum, the number of phagocytosis, which were as high as 100%, fell to very low percentage. So anti-pertectin is needed to kill the body tail of pertussis. And a study was done in France where 361 infants were included, and they were studied whether they had pertussis or not. 9% of them have fulminant pertussis. Fulminant pertussis is defined as lymphocyte count more than 40,000 and at least one of these criteria. It might be respiratory failure, pulmonary hypertension, shock, or multi-organ failure. And it was seen that of these 361 body tail of pertussis, 81% had pertectin. So the importance is that these days the pertectin has increased, and if you don't protect against pertectin, it will be a very serious type of body tail of pertussis infection. Why? Because number one, antipertectin containing Vaccine will clear the body tail of pertussis much earlier from the lung. It will help the phagocytes to take up the bacilli, and body tail of pertussis is very important to adhere to the ciliated epithelium. And another very important thing, to have a proper action against body tail of pertussis, you need Th1 and Th17 response. If you don't have a Th17 response, you yourself will be protected against body tail of pertussis, but you are going to transmit that. And these pertussis containing vaccine generate this Th17 response. And the vaccine Infantryx hexa demonstrate a high efficacy against pertussis containing body tail of pertussis, and also it gives a very good protection. So this is the vaccine efficacy as compared to both. One is vaccines which are protecting has an efficacy of 84 to 85%, whereas vaccine which is one component or two component which does not have protectin has an efficacy lesser than that. Now regarding the immunogenicity, long-term immunogenic persistence, real world effectiveness, these I think you all know. So if you see, after 3 doses of Infantryx hexa, 1 month after the 3rd dose, it was seen the antibody levels against all the six components, diphtheria, tetanus, 3 types of polio, hepatitis B and HIV was very high. So also all the antibodies against the 3 pertussis antigen which the vaccine contained, pertussis toxoid, fibrinated hemagglutinin and pertentin, is very high. Now when after giving 3 doses of this Infantryx hexa vaccine followed by a booster dose at 12 to 23 months, the antibody level was studied at the age of 4 to 6 years and again at the age of 7 to 9 years. And it was seen the antibody levels, this is after in the 4 to 5 years, this is in the 7 to 9 years. It is very high excepting anti-pertussis toxin, because this low antibody level, because there are no further pertussis has occurred and there was no natural boosting. And there was little fall in tetanus level, but again if 5 years booster is given, it goes up. So hepatitis B, it was seen that after 3 doses of hepatitis B given at 2, 3, 4 months followed by a booster dose, study was done at the age between 14 to 15 years. 53.5% of these recipient of 4-dose vaccine had a titer of anti-hepatitis B as high as more than 10 microunit, which is protective titer, and the rest didn't have. But once they were given a single dose of hepatitis B at that age, 92% showed an anamnestic reaction. So what does it mean? Though your antibody titer will fall down, if you have a natural infection with hepatitis B, the antibody level will go up to the protection level. So this was in Spain, where first whole cell pertussis vaccine was introduced. Because it caused so much pain and other problems, the coverage was very low. So acellular pertussis was started at this year, and then the coverage gradually increased and the number of pertussis cases started falling, and it was almost nil by the year of 2012. So also in Sweden, when acellular pertussis was introduced, the number of cases fell down to very low level. So this is the real world situation. Following first year of vaccination, the vaccine effectiveness was as high as 100%, and follow-up was done about 12 years, still it was high. From 100% it fell down to only 85%. So it is through and through the vaccine effectiveness is very high. Regarding another very important point about Infanrix hexa is that it can be given in preterm low birth weight or very low birth weight infants. We have studies which show same level of seropositivity and seroprotection as compared to term infants. Their safety profile is also same and they tolerated the vaccine very well. All you have to do, stabilize the child, and once the child is stabilized, you can give the same vaccine as per the chronological age. So these are the comparison of the antibody levels between term, preterm and full-term infants. They are almost same in both of them. And the vaccine safety has been studied because it is very important. If your vaccine develops problem, then safety concern is a very important concern of the parents. It has a negative impact. If your vaccine is causing problem, parents are reluctant to take vaccine. So every vaccine must be very safe. And if you compare the acellular pertussis vaccine with the whole cell vaccine, persistent screaming in acellular pertussis is very low as compared to whole cell. Hyporesponsive hypotonic episodes, seizures, encephalopathy, everything is less as compared to the whole cell pertussis. And a big study was done where systemic literature review was done. Ultimately 17 studies were initially identified, of which 6 studies were selected for the meta-analysis, which are nearly head to head. And what they found in the summary, if it is an Infanrix hexa 3 component vaccine, the pain is 25%, whereas whole cell is 50%, whereas whole cell from Serum Institute 78%, and 2 component vaccine from Sanofi is 30%. So if you compare redness, also Infanrix hexa is much better, so as swelling, and the number of cases having fever is also. So with this, Infanrix hexa has a 20-year of experience, numerous trials used in 94 countries, more than 7 crores. And to sum up, Pertussis epidemiology is evolving, and recently Pertectin positive strains are very much high. So Pertectin containing Pertussis vaccine is going to show more protection, and 3 component vaccine shown up to 7 years of immune persistence. And a meta-analysis safety outcome was very well defined, and reactogenicity outcome was also superior. So with this, I thank you for your patient hearing.
Thank you, sir. Now I would request our principal, sir, to present the memento. Up next, we have our next discussion on cephalosporin use and abuse in pediatric practice by Jagdish Chinnappa.
Good afternoon, everybody. I thank Dr. Purva Ghosh, Dr. Jaideep, and all the Dr. Manjuri and all the others from the ICH for inviting me here repeatedly for this wonderful program. So, yeah, thank you. So to start off, I would just ask you to take a minute and reflect on how you choose an antibiotic in practice. Well, there are a number of steps over there, at least 9 steps. The first thing is, you should know what the organism is. That's the first thing, or probable organism. The second is, you should know what tissue you are looking at, because the antibiotic is going to penetrate and the disease is going to spread faster depending on the tissue. The third is, you need to look at what is the host who is going to have this infection. The fourth is, which clinical situation are you looking at? That means, is it something which is emergency, or you can wait and decide on what antibiotic to start. Fifth is the environment. Which environment you are practicing in? Are you practicing in a tertiary care center, or are you practicing in a primary care health center? Finally, we have to decide what is the antibiotic you are looking at. Another very important thing is which doctor is prescribing the antibiotic, because a lot of the patterns of antibiotic prescription is in the brain of the doctor. So we have to look at that a little carefully. Then of course the pharmaceutical influences, which I am going to look at a little more, and finally of course the patient acceptance. So your simple task of writing an antibiotic is going to depend on a lot of things, at least these 9 factors, and you can make a mistake in any one of this. Organisms, as we know, are various groups are there: gram-positive, gram-negative, anaerobes, spirochetes and atypical. Mechanism of action, we know that all antibiotics work only on 4 ways. They work either through inhibition of the cell wall synthesis, cell membrane activity, metabolism, or the nucleic acid. And if you look at the cephalosporins, they are primarily, they act by the cell wall disruption, and that is true of all beta-lactams. And therefore, what we are going to discuss today are going to be the cephalosporins. Another thing which we need to keep in mind is the WHO AWARE framework. The AWARE framework says that you need to look at 3 main groups of antibiotics: the access antibiotics, the watch antibiotics, and the reserve antibiotics. Access antibiotics are economical, narrow spectrum, least potential for resistance, lesser side effects, and are used for empiric treatment. The access antibiotics, as far as cephalosporins are concerned, are only 2 of them: cephalexin, maybe cefadroxil also, and cefazolin, whereas the rest of them will go into what is called as the watch antibiotics. Watch antibiotics have higher potential for antibiotic resistance, sicker patients, usually hospitalized, requires monitoring to prevent misuse. They form the bulk of the cephalosporins which are available in the market in our country, like cefixime, cefotoxime, ceftazidime, ceftriaxone, and cefuroxime. Then we have what are called as the reserve antibiotics. These are antibiotics which are used primarily for MDR pathogens, severe infections, and should be used as a last resort. Here you have ceftazidime, ivibactam, which is available, and you have also other you have the other generation or the later generation, 4th and 5th generation cephalosporins, which will be the reserve antibiotics. Now let's look at cephalosporins. Cephalosporins basically have got plus and minuses. What are the plus factors? Most cephalosporins have low toxicity, they have a low risk of allergy, the bactericidal, very uncommonly you get adverse reactions like nausea, vomiting, etc. They are usually broad spectrum, and majority of them are mostly cheap. They are not very expensive. But the problems with cephalosporins is rapid development of resistance with widespread use, and because they have these good properties, there is an overuse of these antibiotics, and there is an inappropriate use. Irrational combinations are available, and there is a false sense of security if you start an antibiotic. We all know that if a child comes with high fever, starting ceftriaxone keeps you at least nice and sleepy in bed. And many are parenteral only. And one more very important thing for the practitioner is, when you see a child with drug fever, the commonest antimicrobial is a cephalosporin. So therefore, if you have fever which is ongoing in a child and the child is on cephalosporin, drug fever is likely to be a very important thing. Now what is common to all cephalosporins as far as spectrum is concerned? They have no activity against this group of what is called as LAME: Listeria, atypical microorganisms, MRSA, and Enterococcus. Now what are the basic differences between the 5 generations of cephalosporin? As you move from the 1st generation to the 5th generation, the activity on gram-positive will start going down. The 1st generation antibiotics, cephalosporins, are very good for gram-positive, whereas if you look at gram-negative, they are much better as the generations move. And this is seen very easily. For example, if you look at Pseudomonas and other gram-negatives, they are generally very good only when you move towards the 3rd, 4th and 5th generation antibiotics. Another point is that once you reach the 5th generation, there is also now a movement towards the gram-positive organisms. For example, ceftriaxone is basically a very good antibiotic against MRSA and MSSA. So this is what we need to look at. Now what are the generations which we are talking about? The cephalosporin generations, the 1st generation cephalosporin are cephalexin, cefadroxil, and cefazolin. 2nd generation, cefuroxime, cefprozil, and cefaclor. 3rd generation, you have cefotoxime and ceftriaxone, ceftazidime, cefaperazone, cefixime, cefprodoxime, and cefdinir. And 4th generation is cefipime. Fifth generation, you have ceftriaxone, cefdioxyl and cefdipriol. So these are the ones which are there. The first generation cephalosporins, as we mentioned, have got very good activity against gram positives, that is MSSA, group A beta hemolytic streptococcus, and very minimal activity against the gram negative. They are not to be used in meningitis and otitis media. Cefazolin, one drug which is extremely good for bone and joint infections and surgical prophylaxis. In fact, if you find a child with osteomyelitis or septic arthritis, drug of choice is usually cefazolin to start with. Second generation cephalosporins are divided into two groups. Second generation and the cefamycin group have less activity against the gram positive organisms but have got increased activity against gram negative. And they cover H. influenzae, Klebsiella, E. coli which is non-AESBL, Neisseria, gonorrhea and others. Cefuroxime can be used in surgical prophylaxis again. The third generation are divided into oral and parenteral. Oral we mentioned are the cefixime, cefpodoxime and cefdinir. Parenteral are ceftriaxone, cefotoxime, ceftazidime and cefoperazone, and they are useful for a large number of gram negative organisms like H. influenzae, Klebsiella, Proteus, gonorrhea and meningococci. Gram positive also it acts but not very well. MSSA, for example, ceftriaxone you can use in a child who's got MSSA pneumonia, but it's only weak in its action and therefore you need to add another drug for it. Fourth generation covers more gram negative organisms like Enterobacter C and Pseudomonas, and also covers, as I mentioned, MSSA and Streptococcus pneumonia. It has no activity against MRSA, Enterococci, AMC beta lactamase producing gram negative organisms. Fifth generation, of course, many of these are not available, but they are very useful for various highly resistant bugs like MRSA, Listeria, Enterococcus faecalis and others. And there is also a combination of ceftazolone with tazobactam which works wonders in severe intra-abdominal infections. So let's get back to our basics. Now, a 5-year-old child comes with multiple skin pustules for 3 years and high-grade fever. What is your diagnosis here? Obviously, everybody knows this is impetigo, and the treatment would be either you can use cephalexin or cefadroxil among these cephalosporins. You could also use, as Dr. Sandeep Bandar mentioned, co-amoxiclav, because some people prefer to use that for staphylococcal infections. Now, this is another case which you can look at. The 5-year-old who comes with fever for 5 days, unrelenting vomiting and poor oral intake. A spleen is just palpable. And here you have a CBC which shows a low count, a platelet count is normal, hemoglobin is okay, and blood culture sent, because most of these children you will try to rule out enteric fever, right? So then, which antibiotic is your outpatient choice and what is your inpatient choice? Since the child is vomiting a lot, you probably would start off with ceftriaxone and follow up with cefixime. Now the question is, why not start cefotoxime instead of ceftriaxone for enteric fever? Differences are clear. Cefotoxime is basically you need to give 3 to 4 times a day. If you are going to give IM, cefotoxime has much lower pain compared to ceftriaxone. It is safe in small babies and it's good and it's got a primary renal excretion, and therefore you need to monitor the creatinine levels. Ceftriaxone 1 or 2 doses per day. It's extremely painful when given intramuscular. Less than 3 months it's better to avoid. Biliary excretion, and therefore it may be more effective in enteric fevers. Cefotoxime, you need to adjust the dose if there is renal failure and no risk of biliary sludge. Ceftriaxone, there is no dosage adjustment for renal failure. Biliary sludge and risk of cholelithiasis is there. And another point is, do not combine with calcium solutions. So ceftriaxone is the only cephalosporin that does not need to have its dose modified in the presence of renal failure. A very important point that you need to keep in mind. What about the other third generation cephalosporins? Ceftazidime is active against Pseudomonas. Adding avibactam, which is now available, it increases the spectrum. Another thing which you see occasionally is melioidosis, for which it's a first line treatment. It has got poor pneumococcal and MSSA activity. Cefoperazone is active against Pseudomonas, and usually cefoperazone sulbactam is very useful for complicated UTI. Oral third generation cephalosporins, we know cefixime used very often. In fact, the highest selling antibiotic in the last few years has been cefixime. The average sale for last year was 1,200 crores. So it's a very popular antibiotic used in many disorders, enteric, UTI, and for various dysenteries, etc. it's not to be used for infections above the diaphragm, like respiratory tract infections, skin and soft tissue infections, etc. It has got very poor activity against pneumococcus and Staph aureus. Cefprozil is less palatable than cefdinir. It's a second line drug for respiratory tract infections. Now, cephalosporin resistance in India is pretty low. If you look at ceftriaxone for enteric fever, it's less than 2%, and cefixime also is less than 2%. But for UTI, it's pretty very high. It's 80% and 70%. So cefixime may not be the first drug of choice which you look. Coamoxiclav may be a better choice for UTI. Meningitis, again, we know that there is increasing resistance of the pneumococcus to ceftriaxone, and therefore the current recommendation is to add vancomycin to ceftriaxone to treat meningitis. Pneumonia, again, it's a pretty good drug to use, ceftriaxone or cefotoxime. Cephalosporins in newborns, again, there was a mention today morning, most bugs causing early and late neonatal sepsis are resistant to cephalosporins. So therefore, this may not be the initial drug of choice. They have no activity against listeria, which is uncommon in our country. Cephalexin can be used as an oral step-down for neonatal osteomyelitis and septic arthritis, especially when MSSA is considered. Cephalexin also is used for uroprophylaxis in the neonatal period. So, I mentioned that the plus and minuses of cephalosporins. I am just bringing up the slide again to do that. Now, one of the major contraindications for cephalosporins are allergies. Again, let me make it clear that the allergies to cephalosporins in patients who have got penicillin allergy is usually to the earlier generation, the first and second generation cephalosporins, and rarely to the later cephalosporins. This cross-reactivity is due to similar side chains, not the beta-lactam ring. So, in summary, first and second generation basically used for gram-positive infection like skin and soft tissue infections. Third generation have better gram-negative and less MSSA activity and poor anaerobic activity, excellent for GI infections, pneumonia and meningitis. Fourth generation covers ESBL, sepsis, febrile neutropenia. Fifth generation, MRSA and VRA activity is there. Ceftobiprole and ceftoxolone have good anti-pseudomonas activity. So common indications are when you have skin and soft tissue infection, use a first generation cephalosporin. You can use enteric fever, UTI and dysentery, you can use cefixime. In severe community acquired pneumonia, UTI, enteric fever, meningitis more than 3 months of age or severe AOM, ceftriaxone is a good drug. In penicillin allergy, especially the milder varieties, you can use cefotoxime or cefdinir. In surgical prophylaxis, cefuroxime or cefazolin. In ESBL UTI, I mentioned cefoperazone, sulbactam is very good. If you have MRSA and VRE, ceftrolin is very good. In Burkholderia, melioidosis, pseudomonas, ceftazidime is a good choice. So cephalosporin currently available in India. First generation you have the parenteral cefazolin, oral cefotroxil, cephalexin. And second generation you have cefuroxime and cefprozil. Third generation you have ceftriaxone, cefotoxime, ceftazidime and cefperazone. And oral you have these drugs. Parenteral you have cefepime and ceftrolin, which is available in our country. Now we are getting to the interesting part. We have covered all the drugs, we have covered the situation. Now doctors prescribing cephalosporins can be put into 3 varieties. Okay, the first variety are pokerbazi doctors. Okay, so these people will look at giving inappropriate antibiotics when and wherever required. Second group are mutual funds, like the mutual fund Sahi Hai. So they use appropriate antibiotics. And finally you have safe digital banking, where you have what is called as the optimal antibiotic usage. For example, if you look at the pokerbazi kind of doctor, antibiotics can be given for high fever. It can be given for cough. It can be given for loose stools. It can be given for mesenteric adenitis. It is given for burning micturition without doing a urine test. It can be used for ear pain without doing an otoscopy, and antibiotics to prevent secondary bacterial infection. So all these indications are being used by practitioners, and these are what I would call as the pokerbazi kind of doctors. The second are appropriate but not optimal. Here, for example, there are doctors who would start giving ceftriaxone for high fever and elevated CRP. First generation cephalosporins for streptococcal tonsillopharyngitis instead of using the plain amoxicillin, and using lower doses of cefixime for enteric, and using cefuroxime for community acquired pneumonia. They are not wrong, but they are not the appropriate choices. And finally, you have clear choices which are used, like for example, you have first generation cephalosporins for impetigo, cefazolin for bone and joint, ceftriaxone for complicated pneumonia and bacterial meningitis. So I think it's very important to look at this. Then of course we come to the last bit, that is the pharma. The pharma are like makeup artists. See, what they do is they move molecules from inappropriate to appropriate to optimal. Okay, and it's called as medical detailing. So this is basically pharma-led doctors' prescriptions are extremely common and inappropriate, and we have to definitely guard against them. For example, this is the set of irrational combinations that are available in many countries, including India and China. And you look at if you look ceftriaxone, tazobactam, ceftazidime, tazobactam, cefoperazone, tazobactam, all kinds of combinations. And even in India, we have combinations of azithromycin with cefixime, and we have got cefixime with a beta-lactamase inhibitor. So there are so many, clovulinic acid. So I think there are so many irrational combinations which are being doled out by the pharma, saying that to cover the most resistant bugs. So basically from the practitioner's point of view, you have to say no. Now let's look at what happens after a routine circumcision in a 6-week-old baby. Okay, you have 3 groups of doctors, as I said. The first doctor says oral cefixime, topical mupirocin ointment, ibuprofen and phenergan to keep the baby quiet and to prevent further infections. The second group of doctors says oral amoxicillin or cephalexin, mupirocin ointment, paracetamol drops. But the most rational would probably just use a simple antiseptic ointment. You don't need an oral antibiotic for prevention of infection, paracetamol drops, SOS, and follow up with Vaseline. So therefore, the choice of any antibiotic depends on so many factors. And I'm sure in our busy practice, we don't think about all these things. We just write the molecule which comes first to mind. And that is maybe dictated by which pharma representative visited you recently. So thank you very much. I think the ultimate aim should be antimicrobial resistant Mukt Bharat, and I'm sure the speaker after me is going to be Dr. Vijay Yavli. Thank you so much.
Thank you. May I request our head of the department, Dr. Priyankar Pal, to kindly hand over the memento to Dr. Jagdish Chinapal. Now I hand over the mic. We have a very important and distinguished celebration, that is felicitation of our well-wishers and others. So, Dr. Shurupa, please.
Good afternoon, everybody. We will be starting the felicitation program now. Institute of Child Health, Kolkata, over the years has been generously supported by several doctors, notably pediatricians, renowned personalities, industries, and the government for the cause of children's healthcare, and specifically towards ICH's mission of providing quality holistic healthcare at a very nominal cost. So every year, we take this opportunity to felicitate our well-wishers and express our humble gratitude for their benevolence and kind support. So may I now invite on stage Dr. Shomendra Nath Roy. Please put your hands together, ladies and gentlemen, for Dr. Shomendra Nath Roy, Senior Consultant Pediatrician, who has been with ICH for many years now and has generously donated for the cause of ICH. Big round of applause, please. She has authored several. Can I also request Dr. Shushmita Banerjee, graceful daughter-in-law, to please accompany her on stage? Thank you, ma'am. Dr. Krishna Banerjee. Thank you again for your gracious contribution to ICH. We are deeply honored. Thank you. May I now call upon on stage Professor Shapun Kumar Rai. He needs no introduction in this fora. President of West Bengal IIP, eminent Professor of Pediatrics of MGM Medical College, Kishanganj. Professor Ray has been associated with ICH for several years, and we warmly felicitate him on this solemn occasion. Round of applause, ladies and gentlemen. Thank you. We are now honored to felicitate Mr. Deepankar Purakayasto, former MD and CEO of Anandabazar Patrika, who is currently serving the board as its non-executive director. Can we have him on stage, please? Beyond his laudable professional achievement, Mr. Purakayasto is actively engaged in philanthropic activities, supporting education, healthcare, and community development. He has been a benefactor of ICH over many years, supporting us in more than one ways, and we are proud to bestow on him our humble gratitude with a small token. Thank you. May we request Mr. Abhijit Chakrabarti, a warm welcome to stage. Mr. Chakrabarti is the founder of Arush Memorial Trust, committed to fighting leukemia and supporting affected children and their families. The trust has contributed huge amount towards the treatment of over 100 children. Its flagship program, Home Away from Home, eases the financial and emotional burden of cancer-affected families. At ICH, several children have been benefited through their philanthropy and care since 2021. A warm thank you, Mr. Chakrabarti. Yeah. Please.
From our end, just a token for the new building coming up for ICH.
Thank you, sir. Thank you for the donation. Thank you so much. May we now invite Ms. Poonam Bagai, the founder and chairwoman of Can Kids, Kids Can. Can Kids is synonymous with care for cancer-affected children across India. Operating in 58 cities in 22 states, Can Kids has gently touched the lives of thousands of children and their families. ICH is proud to be associated since 2019 and gives us immense pleasure to felicitate Ms. Bagai on our annual CME Day. Thank you. We now request Mr. Partha Paul to come on stage, please. Mr. Partha Paul, Managing Director of Paulson's Derma. This is a manufacturing unit, a pharmaceutical unit that is recognized for delivering innovative, high-quality dermatological solutions with a strong CSR focus. Through the Add Glow to Life campaign with Smile Foundation, the company supports girl-child education across India, emphasizing primary education. Thank you, Mr. Paul. We have finished with the felicitation program, but I would now request Dr. Manjari Mitra, our Deputy Director and Professor of Pediatrics, to come on stage to say a few words about a new upcoming project in ICH, the new ICH building.
Now, I would just like to thank everybody for the donations we require, because as you know, ICH is a NGO organization and we depend on donations to build a very large building. And I would like to thank specially to one person who gave me the motivation to collect donation, Dr. Jagdish Chinnappa, when I told him in 2 years before that we need to generate funds, how to generate that big amount. He said, we have 6,000 doctors, pediatrician, everybody giving 1 lakh. I said, do you think that we will get that amount? So he said, I'll be the first person to give. We will have a lobby which will be 2-floor, and I would suggest we already got a lot of donations from everybody, and that lobby we have planned a brick wall of terracotta where every donor's name will be there. So this donation gives us a lot of motivation to work for the entire community which pediatricians are working at ICH. Thank you so much.
Thank you everybody. We have the last felicitation. All of you here, you know Mr. Somnath Mukherjee. He is one of the, one of the pillars. Without his help, the conferences, the regular show we do, it's virtually impossible. He takes care about the computer work, he takes care of inviting, and he has such a network that he is known from every corner, from south to north, east to west. Everybody knows Somnath. So it's a great honor to give Somnath a medallion. And also we'd like to present this honor. So now we end our felicitation ceremony. The next program will be So our next is the most prestigious oration, Dr. K.C. Chaudhary Memorial Oration, and it will be delivered by Antimicrobial Stewardship from Policy to Action, Dr. Vijay Kumar Yevale. May I request Dr. Vijay Yevale to come to the dais. I request our Deputy Director and our Principal, Dr. Apurva Ghosh and Dr. Joydev Rai, kindly hand over the medallion. Yes, 1 minute. First we will give the medallion. And I won't waste time by introducing Dr. Vijay Yevale. He is one of the pioneers and champions of antimicrobial stewardship, which he has started in our country. And
thank you so much.
Dr. Yevale.
Thank you.
You need a collar mic or you?
I have taken it. Very good afternoon. At the outset, I thank Dr. Apurva and the team ICH for giving me this opportunity. I am truly humbled, and it's really an honor to deliver this prestigious oration which stands in the name of Dr. K.C. Chaudhary. We just heard Dr. Jagdish Chinnappa talk about cephalosporins and the way antibiotics are used or abused. So I chose to talk on antimicrobial stewardship from policy to action, which is the dire need of the hour to tackle one of the topmost global threat of growing antimicrobial resistance. Trust me friends, it is much more complex and worse than the COVID pandemic that we had. And I'll tell you in a couple of minutes why I'm saying so and who are responsible. And we really need to pull up our socks and put our acts together so that we implement antimicrobial stewardship at every level, right from individual to a nursing home to a hospital level. This is the patient that I saw yesterday in my chamber. This 14-year-old boy had a week-long cough, was seen by a pediatrician for a day fever about a week ago. And this is what he was prescribed, levofloxacin and a bronchodilator, terbutaline. I just scanned through the previous medical records and I could realize that this child had received cefixime, co-amoxiclav and azithromycin in a span of about 8 to 9 months. Every time he had a bout of cough on exacerbation of what actually he had was hyperreactive airway disease or asthma. I just sent him off by putting on meter dose inhalers, the beta-2 agonist and the ICS. And these are a few prescriptions that I have seen in last couple of months. A DCH pediatrician prescribing cefixime for a short duration fever and cold, which obviously is a viral ARI. An MD pediatrician prescribing cefixime and metronidazole for watery diarrhea, and an MBBS family practitioner prescribing ciprofloxacin and tinidazole with antimalarial for a child with fever. And this is one of its kind story where I get a call from my resident saying that a child with relapsed enteric fever is admitted, and this is the history seen by a BMS Ayurvedic practitioner. Diagnosis of enteric made on Vidal done on day 2 of fever, receives cefixime and azithromycin in inadequate dose for inadequate duration, then admitted with another physician labeled as partially treated typhoid fever. He gets piperacillin tazobactam, goes to an MD physician who gives cefuroxime, and my resident tells me that we have admitted a child of relapsed typhoid fever. So friends, we saw antibiotics are prescribed by a number of human beings on this earth, especially in our country. You have allopathic medical practitioners, homeopaths, Ayurveds, and even our pharmacies are no less than a doctor, and they just hand over antibiotic over the counter. So if you look at the prescribing practices that we have, it's very sad to say that there is inadequate knowledge and awareness about rational use of antibiotics, both amongst the medical practitioners and medical students. Trust me friends, a few wrong things that I learnt in my postgraduate training days stayed with me almost for a decade before I could change over. But I'm sure I, who did not have any attachment to a teaching institute, could change. Each one of you can also change and try to be more rational. So the antibiotics are prescribed by a variety of persons with diverse levels of training. And if you look at the antibiotic consumption globally, there is an absolute increase by 65% in the decade between 20 and 2010, and the rate also has gone up. And this is primarily driven by increase in usage by a low middle income country like India. Talking about India in particular, we are the second highest consumer of antibiotics, prescriber of antibiotic. There is almost 50% jump in antibiotic usage. Not only do we use a lot of antibiotic, but there is a lot of inappropriate usage of antibiotic. We use a lot of broad spectrum antibiotics where they are not indicated. Irrational fixed drug combinations are used very rampantly. And Jagdish alluded to the WHO classification of aware classification, access, watch and reserve. And our 60% antibiotic consumption is from the watch category. And these antibiotics have very high resistance induction potential. So this is what he was talking about. And this is the data in 2019, where 60% of our antibiotic consumption is from watch. It should be ideally from the access category. And we are living in a paradoxical situation. On one hand, you have excess antimicrobial use, and on the other hand, we do not have access to some important antibiotics like cloxacillin, for example, which are very much recommended and useful for treating some gram-positive infection like staphylococcal infections. So resulted what has happened? There was a pre-antibiotic era where infections would kill. Then we passed through a golden era of antibiotics, where we were almost on the verge of closing books on antimicrobials. Disregarding the warning given by Sir Alexander Fleming himself, we used antibiotics inappropriately. Resistance emerged, and today we are in post-antibiotic era, where resistance is rampant, both against gram-positive, gram-negative, or any living organism for that matter. We have a lot of MDR typhoid. We have CRE coming from the community. And all that has been achieved is on the verge of being undone. It is estimated that 700,000 individuals would die of resistant infection by 2050. And antimicrobial resistance, my dear friends, is one of the top 10 threats which has been recognized by WHO. This is one issue which came up to discussion in 2016 in World Health Assembly. This is the only issue which came up after the HIV/AIDS. It is going to cause us huge impact on our economy also. And the greatest impact will be felt by, again, low middle income country like India. So there is increasing AMR among pathogen, and on the other side there are no new antibiotics which are coming up. And if you look at the main drivers of antimicrobial resistance, it is misuse and overuse of antimicrobials. And again, unfortunately, it is all of us practitioners who indulge in using antibiotics. So we need to really start using antibiotic responsibly and rationally. We need to preserve or reserve this definite source which has come to our rescue, treating and saving us from against deadly infections. And there are n number of studies which have demonstrated a direct relationship between antibiotic consumption and emergence of resistance. But you cannot do away with antibiotic. Antibiotic use is inevitable. And the moment you use antibiotic emergence, this is survival of the fittest. The microbes are going to mount some degree way of, overcoming the onslaught of antibiotic. However, the pace of AMR development can be slowed if you use them rationally. So it's time to redefine our antimicrobial prescription. WHO, recognizing this threat, launched Global Action Plan in 2015. And one of the important pillars is antimicrobial stewardship. Well, friends, you would wonder what this stewardship means. As a PG trainee, I had not heard of this term when I was trained in pediatrics. So stewardship is actually the careful and responsible management of something entrusted to one's care. And when it comes to antimicrobial stewardship, it is a coordinated program that promotes appropriate use of antimicrobials so that the outcomes are improved with the aim to reduce resistance and decrease spread of multi-drug resistant pathogens. Now for a minute, bear with me. I am going to walk you through an ideal situation. And many of you may not be able to relate to this and would say that this is not where I belong to. 1-year-old boy, high fever for 2 days, presents in septic shock, cold extremities, blood culture is drawn, urine is collected. So there is completeness of assessment, guidelines are followed. A broad spectrum antibiotic, broad coverage is given by vancomycin and meropenem. There is antibiotic policy in this institution. Message is sent to the antimicrobial stewardship team, which requires support of IT in a big hospital. There is AMS team in place which comprises of ID physician, microbiologist, pharmacist, infection control nurse, IT team, etc. The moment a reserve category antibiotic is used, justification form is filled. Reports are released. Preliminary reports say that it looks like urosepsis. Microbiologist interacts with the clinician saying that, look, we are growing E. coli, ABST is awaited. The moment E. coli is done, vancomycin is withdrawn, ABST is made available and it shows non-ESBL E. coli. Antibiotic timeout is practiced. Clinician thinks over whether the antibiotic is appropriate or not. Can I narrow down the spectrum? There is de-escalation. Patient is changed over to ceftriaxone. And the moment patient is afebrile, the patient is switched from IV to oral cefixime as per the antibiotic policy in the unit, and the patient is discharged with appropriate counseling about completion of antibiotic for 2 weeks, which is the recommended duration in complicated UTI. And of course, he is advised to carry out further tests, and antibiotic prophylaxis is ordered until such time. So this all is your antimicrobial stewardship in an ideal setting. And these practitioners and AMS team participate in prospective audit, and then they do tracking, and they indulge in educating the clinicians and the public as well. And this requires a lot of commitment from the leadership of the institution, and these are the different players which are required to put such an AMS team in place. There needs to be an accountability to clinicians, they have to report, and there are several actions involved like antibiotic policy making, training, antibiotic timeout, putting all these things in practice, tracking, reporting, and then you measure the antibiotic use, measure the processes, measure the outcome. But then, and finally educate both the clinicians and the public. But I am sure many of you would say this is not my cup of tea, and these rules do not apply to me. I am a common pediatrician, how does it matter to me? But this is far-fetched and this is not. No friends. I understand that AMS is rudimentary or almost non-existent in our country. Even the Western world took more than a decade to establish a good AMSP. Implementation of AMSP has been a challenge all over the world. But you need to try until you succeed. And as I said, it's high time that we start practicing AMSP. There has to be a beginning, and each one of us has to make an effort. These are the barriers, there is lack of awareness, lack of funding, lack of infrastructure. We are overpopulous country with inadequate health infrastructure. There is shortage of trained personnel. But at every level, whether you are an individual practitioner or you are practicing in a small nursing home or an institute like ICH, there is a potential to make a difference. You can reduce incidence of infection, you can indulge in diagnostic stewardship so that the diagnosis is not delayed or it is not misdiagnosed and appropriate antibiotic is written, and then you can practice antimicrobial stewardship. So to combat AMR, these are three important stewardship that need to be put in place: infection prevention stewardship, diagnostic stewardship, and antimicrobial stewardship. What is infection prevention stewardship? Sanitation, hygiene, hand washing, simple measures. And there is ample data to say that this goes along in preventing infections. Vaccination, an extremely important tool to prevent infection and curb use of antimicrobials. So one need to put in measures to control infections in your nursing homes, in your clinic setting, and even in institution. The second is diagnostic stewardship, using the right test on the right patient at right time so that a timely diagnosis is made. I will give you an example. An acute febrile illness in a 6-year-old child presenting in monsoon, you ask for CBC, CRP, NS1, peripheral smear, and maybe rapid malaria antigen test and a blood culture. NS1 is positive, you know that you are dealing with a viral dengue and no antibiotic is written. So these appropriate use of rapid test can improve antibiotic prescribing. So one needs to make these tests available and use them appropriately. So AMS efforts would need improved diagnostic facilities, and such simple, easy to use, rapid, accurate and point of care diagnostic tests need to be made available to the clinician. And finally, antimicrobial stewardship. It involves commitment, and I always say that it has to come from within. You have to be motivated from within to practice AMSP. This is what we have done in IIP Navi Mumbai. We have distributed such posters to all the clinicians. They have been displayed in their chamber and in the waiting area. This has two-pronged effect. One, the clinician who has put up such a poster thinks twice before pinning down an antibiotic. It also helps create awareness amongst those who come to your clinic. Such posters can be put up even in nursing homes. You need to identify one amongst the various consultants who are attached to the nursing home and start implementing this. Second is improving antibiotic prescribing. So there are a few conditions where antibiotics are overprescribed. Like every febrile child gets an antibiotic, that poker kind of thing that Jagdish was referring to. There are conditions which are every sore throat is treated like bacterial pharyngotonsillitis. You need to introspect and revisit this. Wrong agents are used. Pneumonias are treated with cefixime. We know that that's not the drug of choice. And then we lose on opportunities to practice delayed antibiotic use. Mild otitis media. Knowing well that mild bacterial can self-resolve or many of them are viral, we get impatient and prescribe antibiotic on day one itself. To my mind, we need to identify conditions where antibiotics are overused and we need to improve prescribing. And to all those who are sitting here, I am sure this would definitely you will be able to relate to. fever, sore throat, acute respiratory infection and UTI. Even if you tackle these 4 areas, lot of rationality will be put in place. Let's talk about one example, sore throat. 4-year-old boy comes with throat pain, throat is congested, there are small jugular digraphic lymph node and there is mild tenderness. And the parents, pressurize you that it's a long weekend, we have to go out, please prescribe an antibiotic. And you have a choice of a macrolide, a coamoxiclav, amoxicillin, or you have a choice of waiting and reviewing the diagnosis. You choose to wait, you apply Centaur criteria, clinically you think this doesn't look like bacterial pharyngotonsillitis at this point in time. You call the patient at 48 hours, now there are exudates, there are tender lymphadenopathy, you reapply this criteria and now you think that this looks like bacterial pharyngotonsillitis. Where facilities are available, you may even do rapid sore throat test. You put diagnosis on paper, acute bacterial tonsillitis, you write amoxicillin, which is the drug of choice, given the fact that GABS is universally susceptible to amoxicillin. You write appropriate dose, 1.5 tablet for this child, 2 times a day for 10 days. You write the duration. You spend a minute with the parents, counseling them about, the aim to eradicate the streptococci from the throat and importance of completing the duration. And you make a statement, I'm afraid this time I need to prescribe an antibiotic to your child unlike the previous visit. So what have you done? You have made a good clinical assessment, you have followed standard guidelines, you have put a justification note, you have followed the 5 Ds of appropriate antimicrobial prescription, that is choice of drug, dose, delivery, dosing interval and duration. You have made an attempt to educate the patient by making statement, and then you should also use this opportunity to educate or sensitize our peers on what is the first line for sore throat. This, friends, is nothing but antimicrobial stewardship, and this is what has to come from all of us. Look at this example of fever. Every febrile child gets some investigations, may not be at right time, may not be the right test for the right patient, and then everybody goes on an antibiotic. 5 basic questions: degree of fever at onset, interfebrile period, response to paracetamol, trend of fever and associated symptoms, more often than not help to differentiate bacterial from a non-bacterial fever. And if it is a bacterial fever, there are only a few conditions where prescribing an antibiotic on first visit is an emergency. Like if you are clinically certain about a bacterial infection, acute suppurative lymphadenitis. If the infection is probably bacterial, send appropriate test. Or a newborn or a febrile neutropathic child, a child on leukemia on chemotherapy, you would go overboard and prescribe an antibiotic, but after sending a test to establish diagnosis. Get into habit of sending blood cultures. Practice diagnostic stewardship followed by appropriate antibiotic prescription, that is antimicrobial stewardship. ARI, every child with fever, cough, cold, rapid breathing. WHO says pneumonia kills, pneumonia is #1 killer, and what is prescribed for a community health worker is practiced by pediatricians. It's really an unfortunate state of affairs. You put your skills, clinical skills together and try to differentiate those viral causes like wheeze-associated respiratory infection or bronchial asthma or bronchiolitis from pneumonia, which out of this 4 would require an antibiotic. So how do you bring in this change? You need to refer to guidelines, you need to attend CMEs, you need to talk to your peers, you need to train the juniors who attend to such patients in your absence in the clinic or in the nursing homes. And only repeated training and teaching is going to help establish this antimicrobial stewardship. UTI is very often under or over treated. None of us would spend adequate time in counseling the parents on how to collect urine. Very often contaminants are grown and we overtreat UTI. Simple rule: fever without focus more than 38 degrees, more than 10 pus cells, send culture, start antibiotic. But if fever is less than 38, wait, send culture, wait. Anytime the fever crosses 38, give an antibiotic. If culture comes more than 100,000 colony count, and if fever persists, start antibiotic. But if fever disappears, having said that, you have not spent adequate time in explaining the parents how to collect urine for culture, please don't label this child as UTI. If fever, the child gets fever again, send urine routine and then start antibiotic. Fever without focus, if it localizes in some other system, God is not very cruel. He doesn't give you multiple infections in one go in immunocompetent child. So don't label it as UTI. Don't make an attempt to diagnose UTI in such children. We see adolescent girls with vulval redness and repeatedly urine showing pus cells. So they are overdiagnosed as UTI. Let us get out of this habit. Finally, empiric antibiotic use is what we resort to in office practice especially. So friends, empiric antibiotic, as I said before, unless you are clinically certain or unless where waiting is risky, or if your probability of it being bacterial infection is very high, don't prescribe an antibiotic. Send appropriate test, try to establish microbiological diagnosis and then write another. You try and prophylactic antibiotic, every garden variety URI, you don't prescribe antibiotic on first visit, day 3 the child comes back with fever, you tend to become impatient and prescribe an antibiotic. Get out of this habit. Use local guidelines. IAP has come out with standard treatment guidelines. They are wonderful. Refer to them. Make them available. That is an important. This is a challenge that they are not made available. They were not made available. Now they are available on your social media, on your mobile phone. Apply them. A few important critical elements of antimicrobial stewardship is antibiotic timeout, de-escalation and switch from IV to per oral. Antibiotic timeout is after having started an antibiotic at 40 to 72 hours, you sit back and review. Am I dealing with a bacterial infection? Is the spectrum, can I narrow down the spectrum? Would an ID opinion help? Should I discuss this case with my senior peer? And please get into this habit. It may be overwhelming what I am talking, but start with small steps. Use evidence-based criteria. As I said, a lot of guidelines available. Use, don't lose opportunity to practice delayed antibiotic practice, and then you need to train clinician. You get trained and then start implementing in practice what you learn. Audit, it's an extremely important thing. Put justification note on every prescription that you write. At the end of OPD session, you fill form 3C, how much money you have collected. Similarly, you make a chart. How many patients do you use antibiotic? You review and look at the antibiotic that you use. By maintaining this simple record, the antibiotic consumption would go down. You need to audit. What do you look at? Is the choice appropriate? Did I use the diagnostic criteria? Did I use the appropriate agent that is recommended in the standard treatment guideline? And did I apply the correct dose? And did I counsel the parents about the duration of antibiotic you measure the process that you adopt for writing an antibiotic. You measure the outcome. Now these are things which are for institutions where they have a AMS team. DDD, defined daily dose or days of therapy, is a matrix on which you measure the antibiotic use in an institute. Follow that AWARE classification, use antibiotic from access group. And then you look at how many patients develop adverse drug reaction, mortality, what is your MDR rate in the institution, so on and so forth. It is an uphill task. Apollo hospitals where I work, I chair the antimicrobial stewardship committee. We have taken a couple of steps. We audit our surgical prophylaxis and we audit our restricted antimicrobial use. Trust me friends, last 2 years it's been a big struggle and even today the compliance is not 100%. So not only be good prescriber but ensure that the end user also is a good user, adhering to 5 Ds, minimize misdiagnosis and overdiagnosis. AMSP is incomplete without education of clinicians and public. Plenty of such posters are available. Celebrate AMR week, create awareness, antibiotic handled with care. Lot of free to download posters are there in the on the website. Download and put them in your clinic or nursing homes. Now if you look at the barriers to a practitioner, knowledge gap, let's accept it. I mean no offense made, but you need to train, retrain and put into practice what we have learned. There is a perceived pressure to see patients quickly. Plan your day. All of us are used to seeing loads of patients. Cut down. Clinicians concerned about decreased patient satisfaction. You try to counsel, make statements and patient demanding antibiotics, please do not fall prey to this. So these are the remedial measures or solutions to the barriers that we have. So friends, to conclude, it is the need of the hour that all hospitals in India initiate AMS strategies and start implementing to benefit patients and also for spillover benefit to community by reducing AMR. Antibiotic is something which misuse or abuse affects the community as well. There is a need to customize solutions for AMSP in our country. We cannot just follow what Western countries do. Establishing AMSP is a challenge, but it's a stepwise dynamic process. ICH, I am sure there is an AMSP team. Build on what is available, analyze what is available, structure human resources and policies, identify human resources and form a team with term of references, identify one member as the leader, train and partner with outside experts. For example, clinical pharmacists is difficult to employ and difficult to get. Collect antibiotic use data, point prevalence, see how much of aware classification you are adhering to, and microbiology is an essential component. As an individual, this you must carry home, that AMR costs and kills. Increased awareness is the key, both among health care professionals and public. Remain updated, train the juniors and peers, use the available diagnostics optimally, interact with microbiologists, improve antibiotic prescribing by adhering to the 5Gs, start writing a justification note and start auditing your prescription, start tracking it. And I am sure with this, you will not find AMSP a jargon or something that is not my cup of tea. And each one of us can make the difference and be the change that you want to be. Thank you very much.
Thank you, Dr. Vijay Yavale. Now we come to our next session. It will be on trivalent influenza vaccine. An update by Dr. Jaideep Chaudhary.
So good afternoon everybody. After an enthralling session, we will move on to a trivalent influenza vaccine and update. Now over the past few months, if I ask you to raise the hand that have you encountered influenza, I am sure everybody will raise the hand. We have seen an upsurge of influenza cases in children, in adults and everywhere. So influenza as a disease we just cannot ignore. Now I will highlight with a case that was admitted in ICH PICU. It was an 8-month-old boy who had initial cough for 6 days, 4 days fever, lethargic, respiratory distress developed over 1 day on admission, was tachypnic, saturation 84% room air, 96 with 4 liters oxygen, dehydrated, so fluid bolus is given and the X-ray you have seen. No obvious pneumonia or consolidation. Initial ABG, yes, there was acidosis and you can see the subsequent ABG also, it was deteriorating. So the child had to be shifted to PICU. The child was put on HFNC followed by non-invasive ventilation. Routine blood count was normal, CRP was raised, there was mild transaminitis, no improvement even after 12 hours and you can see the deterioration in the X-ray. After 18 hours of hospitalization, there were repeated desaturation even with non-invasive ventilation. The child was intubated and ventilated, respiratory panel was done and it was influenza A, so oseltamivir was started and you can see the deterioration in the X-ray. 6 hours after intubation, FiO2 required was 90, PEEP 10, still saturation low, so prone position was started. Even 6 hours after proning, FiO2 requirement very high, so high frequency ventilation was started. This was the critical condition of the child. ECMO initiated and you can see there was ARDS developed and unfortunately the child succumbed on day 7. So influenza is not always a simple viral upper respiratory infection. We must be very cautious even if it presents in a mild way because it stealthily progresses sometimes. I would like to share with you past 6 months data of influenza cases, courtesy Dr. Shumon Poddar of microbiology department. He has helped me with this data. You can see in the month of June and July, you can see there were Influenza A H3N2 30%. In July it was 66%. Whereas in March it was mainly influenza B, which was 21% of all the open sample, that is open PCR that was done. Mind you, this is just a random analysis because not all the children, they do the viral PCR. So what we got, in the 6 months out of 185 samples, there were 60 influenza A, mainly H3N2, 2 were H1N1, and influenza B was 20, though subtype was not done, whether it was Victoria or Yamagata. And the surge period you can see was June and July. In August till 9th August there were 12 cases of H3N2, and I know that following 9th August there were few more cases. So this is the scenario of one tertiary care hospital from random sampling. So influenza and related complications is on the rise globally, especially in 0 to 5 year children. There are some publications which show there are 20 million influenza virus associated ALRI in under 5 children and about 1 million influenza virus associated severe complications and hospitalization. So like many other diseases, the WHO has also propagated a One Health approach, influenza and One Health approach. Because influenza virus is a paradigm for a pathogen that frequently crosses the species barrier. As we know, there is often avian influenza affecting humans, so from animals to humans, causing often very severe disease. And there are epidemics and there are also pandemics. H1N1, 2009 influenza and avian to human transmission of influenza viruses are recent examples of new zoonoses with a significant global impact. The pandemics in humans were caused by animal viruses or virus reassortants carrying animal virus genes. Underlying the fight against influenza requires the One Health approach. That means it's not only the control and management of human influenza, but also animal and also environment, because it's in a symbiotic relationship, the humans, the animals and the environment. Are Indian children missing animal flu vaccination? Well, flu vaccine is given only in private setup that we know, but still, if we calculate, say 60% Indian children dropping out of influenza vaccine after second year of visiting private pediatric clinics, that's quite common. So if we calculate this is a mathematical calculation, 10 million children in the 0 to 5 years age group are missing the annual influenza protection. That means even if they take the first 2 doses in the first year, then they gradually drop. Even if they take a second dose in the second year, but they gradually drop. So even 0 to 5 years, we have a sizable population who are discontinuing influenza vaccines. And we know that vaccination is the most effective and also cost effective way to prevent infection and severe outcomes caused by influenza viruses. And that's why IAP, ACVIP, just like WHO recommends inactivated influenza vaccine 6 months to 5 years of age, and that has been in the IAP, ACVIP guidelines, and that we all are aware. There are various clinical studies. I will just show you one clinical study. It was a prospective randomized phase 3 Indian study of immunogenicity and safety of 2 inactivated vaccines in 6 months to 35 months. What it shows that there is not much difference. It's the immunogenicity and safety of the 2 inactivated vaccine. There were 343 children 6 months to 35 months who received the vaccines demonstrated non-inferiority. So any influenza vaccine, if we give, it has more or less the similar effect as we can see. The seroconversion rate and also the safety profile are similar. The question that comes frequently, that we all know the cliche that there are northern hemisphere vaccine, there are southern hemisphere vaccine, this has been discussed so many times, but which vaccine should be preferred in India? India lies in northern hemisphere. There is no second thought and second question about it. But the behavior of the weather and the virus circulation in India is more like southern hemisphere. So WHO has put India in southern hemispheric vaccine recommendation region. So India should preferably use the southern hemisphere vaccine given in April, May, pre-monsoon season. Pre-monsoon, the circulation is much more, as we have seen the latest surge in the influenza A also. But again, any patient who approaches for flu vaccine in any other time of the year should be given the vaccine, and in the subsequent year it can be changed to the southern hemisphere vaccine pre-monsoon. A CVIP recommendation about the age group. We know that 2 doses in the in 1 month apart in the first year of life, followed by yearly till 5 years. Above 5 years it is recommended only in high risk children, but again influenza vaccine is primarily given in the private setup. So if the parents ask for influenza vaccine at any age, then we are justified in giving the vaccine. A 40-year-old child comes for flu vaccine, taken only 1 dose last year. How many doses should be given in this year? So any child who has received less than 2 doses in the past should receive 2 doses again in this season, subsequently 1 dose. A 40-year-old child received 2 doses in the first year of life. None after that comes now for flu vaccine. First year 2 doses, subsequent 2 years none. So any child who has received 2 or more doses in the past, irrespective of the year, maybe 1 in 2 years, need not be in the same season, 1 in 2 years, should receive only 1 yearly dose. So 2 doses in the past, 1 dose, 1 yearly dose. After recovering from flu, does a child need a flu vaccine? Yes, there are different strains of influenza. So for protection from other strains, one can take even after clinical recovery. Efficacy of flu vaccine, though, against the culture confirmed influenza is about 65%, serologically confirmed 63%, against clinical illness unconfirmed is 33%. This is studies in different geographic settings have shown different efficacy. And efficacy decreases if perfect match between circulating strain and that in the vaccine is not there. We know that efficacy is 65%, but we are using many other vaccines with efficacy around 60%. And when the disease is so severe, so we are justified in giving a vaccine with low efficacy also. And 65% also we cannot ignore, because the child has come for best protection. Then the debate, split versus subunit vaccine, which one to go for? Yes, there are some difference. Split is a 4th generation, subunit is a 3rd generation. The viral protection and immunity, more viral protein in split variant has more immunogenic and efficacious, but subunit has less viral protein, so maybe less immunogenic and efficacious. Across age groups, split has got better immunogenicity. Effectiveness across all pandemic variants of influenza, split is superior. South Asian guidelines, split vaccine. So there are some debates, some claims, but on a practical field, as per the recommendation, both can be used. Those split variants are said to be more immunogenic in younger age group. It's claimed that more reactogenic also. And subunit contains only outer protein, so less reactogenic. So it is a win-win situation for both. So whichever we prefer, we can go for it. Uniformity in inactivated influenza vaccine strains, WHO's role in global health. So what WHO does, the selection of vaccine strains by the National Institute of Biological Standards and Control collaborates with the WHO to review the global influenza activity. They collect the isolates and developed a candidate vaccine via CVV. And they use the classical reassortant, and that's why it is passed on to the company. So global recommendation, quadrivalent to trivalent vaccine. So what's the basis of it? Now, currently the 2005 strains of influenza vaccine, that's what we have, are the H1N1, influenza A, H1N1 Victoria, A Croatia, H3N2, and B Victoria lineage and B Yamagata lineage. So these 4 are currently we are having. So this is the way the companies decide the global influenza surveillance. The WHO decides the Southern Hemisphere vaccine available around March, April, Northern Hemisphere September, October. Now there are certain publications. This is the WHO from the WHO site, the recommended composition of influenza virus vaccine for use in the 25-26 Northern Hemisphere season, and also the recommended composition of influenza virus for the use of 2025 Southern Hemisphere. So following this WHO guideline of recommending the trivalent vaccine, the CDC has also approved the use of trivalent vaccine. So the recommendation is from European Medicine Emergency Task Force 2014 about the trivalent vaccine, removing the Yamagata component, citing what's the cause of removing? No natural circulation of influenza B Yamagata for over the last 4 years. Risk of reintroduction through reassortment in vaccine. So because there are no Yamagata strain over the last 4 years, so if we still continue to give the vaccine, there is chance of reintroduction through reassortment. So this has been endorsed by American Academy of Pediatrics and CDC 2025, and the 2025 US immunization schedule reflects shift to trivalent influenza vaccines containing 2 strains of A and Victoria of B. So this is the recommendation, no additional antigen needed, and the risk reduction, removing Yamagata from the vaccine reduces the risk of reassortment. And this is the precision vaccine also, which matches the vaccine type of the population needed. And that's why, coming back full circle, the One Health approach, enhancing education, raising awareness and advocating disease prevention through a unified One Health approach. This is the logo of One Health. So we must be responsible citizen. We must follow the guidelines. It may be upcoming, the trivalent vaccine, because the world is shifting from quadrivalent to trivalent vaccine. Maybe in near future, we all will be using trivalent vaccine and going to control influenza through One Health approach. Thank you so much.
Thank you, Jaideep. May I request you to kindly go at the back? Dr. Priyankar Pal will hand over the memento. So now we are going to call our next recent advances in pneumococcal vaccine by Dr. Manjari Mitra.
Yeah, where's my first slide? A very good afternoon to all. This is not the first slide. Can you put the first slide on? Yeah. So basically, pneumococcal vaccine is an evolving vaccine, which we all know. And why it is evolving, this is my disclaimer. I'll just roughly go through, we don't have much time. We will go through why it is evolving, the rationale of the evolving of the pneumococcal strains and the subtypes. So basically the structures, we know it's a polysaccharide capsule, and that is one of the most essential virulence factor for the invasive pneumococcal disease. And there are 93 known serotypes, and the different serotypes have varying potential to cause disease. Few of the serotypes are definitely much more serious in nature. So the polysaccharide capsule is one of the most important virulence factor, and the distinct chemical composition and the immunological properties are responsible antigenically for subgroups and subtypes. The streptococcal pneumonia serotypes vary in the prevalence, density, duration, and the invasiveness. Even it differs between the geographical regions, age groups, time periods, including regions with comparable socio-economic, and also the prevalence of the antibiotic use and differential uptake of that particular society on the PCV. So the global prevalence, after the PCV7 was launched in 2002, there was a surveillance constantly, because we all know that prevalence, there may be a replacement of serotypes. So this constant seroprevalence did give us, and does give the pneumococcal vaccine manufacturers to decide, strategize which serotypes to be put in the particular vaccine during a particular time. Now what we see, the various serotypes are common for use of IPD globally in children less than 5 years. Before the widespread use of PCV, serotypes 1, 5 and 14 together was accounting for 28 to 43% of the cases, and 19F and 23 was responsible for 19 and 80%. The serotypes which I mentioned are more likely to be the resistant in microbials. That is another component to decide which serotype to be given, because you have to have a backbone structure where you cannot include all 93. It's not possible theoretically. So this is another study which India had done immediately after the launch of Prevnar 13 to understand what is our prevalence, whether India needs coverage of all the serotypes which was present in 13, and this was an ACIP study across India. In fact, ICH was also a center, and what we saw that the less age than 5 years were 1, 5, 6A, 6B, 14, 19A, 19F. So you people have heard a lot about the different serotypes. The predominant serotypes in children more than 2 years was 1, 5, 19 and 14 and 19F. And one of the important which we have heard, I'm sure all of you have heard, the serotype 19A had become a very important component along with serotype 3 during the prevalence study. Now that study ACIP was done by the Pfizer GSK initiative, and the PIDOP study was done by the Pfizer initiative, and both that was started in 2011. This was in 2013. Basically after the launch of 2010, the prevalence of the studies which results was there in the previous in the global country, and PCV13 was one of the important parameters. What are the components, serotypes of PCV13? That gave the inspiration to Indian companies to do a serotype study. Now regarding the vaccines, we all know there are two types of vaccine. One is the conjugate and one is the polysaccharide. The importance of this vaccine difference is basically, I'm sure we all know that the conjugate elicits a T cell dependent response with the establishment of the B cell memory and the long-term immunogenicity, and that was one of the reasons it could be given less than 2 years, but the polysaccharide, because of its innate nature, we had to give it more than 2 years. And we all know the burden of the disease and the incidence of the pneumonia in particular, which is one of the common cause of pneumococcal disease, is less than 2 years. So the polysaccharide conjugate vaccine, the first was PCV7, which was developed in 2002 and launched, and it greatly reduced the rate of infections, children less than 2 years and unimmunized individuals in the same community, because there was a vast coverage and they had a herd effect. Now what is the rationale, in particular today's context, what is the rationale behind the PCV14? If you see all the coverage of the serotypes, all the serotypes vaccines which are available in India have more or less all the coverage of the serotypes which we are seeing. And you can see there is a strategic decision between the various types of the vaccines available in India based on the indigenous manufacturer. It was based on the prevalence they found on the serotypes available in the Indian study. So you see they have taken care of, some has taken care, particularly the indigenous PCV10 has taken care of 3, not to put 3 instead of putting some other vaccines so that they can maintain the 3. Similarly, 14 has tried to put all, and they have not taken 6A to manage 14 serovalent. The reason there are adequate studies which I'll show you, there is definitely a cross protection between 6A and 6B. So that was the advantage of them to keep 14 at the same time introduce 22F and 33F, which was an upcoming global strain. Now the serotype replacement following PCV is an important thing. The increase in incidence of non-vaccine type disease after the use of PCV phenomenon refers as serotype replacement, and the incidence of the vaccine type IPD decreased annually till 7 years after the introduction of PCV7, whereas the incidence of non-vaccine type after year 7 was also seen, and then a single serotype 19A was becoming a very concern. The non-type vaccine IPD was on the rise after the introduction of 7. So automatically, as all the vaccines who are the developers and manufacturers of pneumococcal are always on a constant development phase, so the moment 7 was launched, Pfizer was also into a process of incorporating the other vaccines, and by 2010, the 13 prevalent vaccine came, where all the prevalent serotypes which was available globally, and even we can say that it was also available in India, and our study showed, and all those were incorporated in that vaccine 13. Now after 13, the prominent prevalence of 13, the concept is you have to do in one end your serotype prevalence, which has to be done globally, which now India is lacking. After 2011, there was hardly any all over India prevalence study, excepting some sporadic studies were done in southern India. But again now ICMR has come into, and 2 or 3 more companies, particularly the vaccine manufacturers, are into the prevalence study to understand the serotype. Now today Indian manufacturers has also to do the prevalence of serotype, because they have to strategize what are the new serotypes they have to add on. Now the proportion of IBD cases in Spain was 22F and was 1.8% in 2009, and slowly we rise, we get the concept the serotype replacement is happening, and it became 6.23 in 2018, and similarly the 33F was also on the moderate rise, and hence all the newer vaccines which is there in globally, excepting the one which we have in India, that is 2014, the PCV14, excepting that none of the vaccine available in India has 22 and 22F and 33F. But all the newer vaccines which are being developed globally, 22F and 33F has been taken care. We have recently, the PCV20 has been launched in India for the adults. We are doing the study for the pediatrics, and the pediatric study, more or less the enrollment is completed. The study will be end soon in the September, and we will get, which is covering the 22 and 33F, which is also shown to cause severe invasive diseases. We have known that we are seeing that we are having previously our pneumococcal, streptococcal pneumonia causing lobar pneumonia. We were not having so much of difficulty in treating them, neither the duration of hospitalization was not so long. And today what we are seeing, resistant strains are coming, and particularly the pneumonia is more important. Collapse, lung abscesses, empyema, pericarditis. Even recently we are seeing a lot of pneumococcal necrotizing pneumonia. I'm sure we are getting that, and we know how difficult it is. So that is one of the reasons we have to think of the newer strains incorporation. And again, I would say that that strategy is being developed. It's a developing vaccine. In other words, it's a developing vaccine, and we should rationalize our thought process in selecting which vaccine to cover up all the strains which are of importance. The global prevalence of serotype after introducing 7 and 13 is basically, we have to understand, this is a very classic milestone study of Illyrim. It's over 20 years, 2 decade study, where it was seen the isolates of streptopneumonia normally from the sterile body fluids. There was a shift, and most prevalent strains were 19A, 3, 7F and 22F. Now this was a very important milestone which has given rise for all the newer manufacturers, be it MSD, who has a 15 strain, 21 strain, GSK pipeline vaccine is 24 strain, all of them have incorporated these important newer strains, non-IPD strains. The serotype prevalence in India, once we saw the other strain which was showing 22F, and this was showing 33F, which was also prevalent amongst the non-vaccine pneumococcal serotypes. The serotypes 3 and 19 were causing IPD in India. After the launch of 13, we have to re-evaluate, and there were sporadic studies, as I said, across India, particularly south. What are the strains prevalence? So now this incident, the interest of looking into the serotypes, there are not many centers in India who does the serotype. We do get PCR positivity, we do get culture positivity, but it is also important to know the types. It may be a research question to understand the serotype, but today for the development of a vaccine we need to know, and it's very important to know the serotypes. So this was another South Indian experience which we saw, the 19F, 19A, 14, 9V and 9A was a new one, and 6B and 6A now was also there. Now why this is another important thing, if you look into the indigenous PCV10, as I said, everybody has to rationalize the serotypes. In 10 they saw, we don't have 18C, but in our study we are seeing the serotype 18C is prevalent in India, causing very serious streptococcal, either pneumonia or meningitis in the process. So the prevalence of the PDOP study which I showed, serotype 19A was 3%, serotype 3 and 18C was 2%, 4 and 22F is 1.32%. We are trying to focus on 22F to find out the rationale of why PCV14 has taken, it's an indigenous vaccine developed in India, why it has considered 22 and 33F in the vaccine. The other important, we know since it's 93 and serotypes, and we know that the cross-reactivity, because all the antigens, they have a very similar linkage pattern, and that is the reason there are adequate studies to show there is definitely a cross-reactivity, and this cross-reactivity helps in strategizing the number of serotypes to be kept in the vaccine. The cross-protection of 6A serotype with 6B has been established by various studies. There are many questions which say that if 6A is 6B is there, most of the vaccines has 6B, so it will protect 6A. But there are some questions that if both 6A and 6B is there, probably they'll protect 6C. Now the question is, there are some vaccines in India which doesn't have 6C, because as of now our prevalence, though I won't say it's a very well structured prevalence, but haven't shown yet 6C. So importance was given more on the cross protectivity of 6A. So the cross protection, as we discussed, in 1999 to 2006 the incidence of serotype A was seen, and it was decreased with the cross protection, 91% among individuals less than 5 years, and it also was 58% among those who were more than 5 years, and it had shown that there was a decrease in the cross protection. This is the overall licensed vaccine in India, and if you look into the different serotypes present, barring 7, if you look, most of the serotypes are having same, more or less, excepting 13, 14, which is covering more, and advantage of 14 over 13 is the newer strains which are being prevalent is being added. Again, to repeat, all the newer vaccines which are coming in the global pipeline, it is always there, which will come in India, is covering these two important strains which has been identified over the years. It is so shown in the prevalence, seroprevalence, even in Indian strains, we are finding that over the years. So the PCV immunogenicity, the study was done in 2019 subjects, 1290 subjects, and based on WHO serological criteria, we have to consider the percentage of PCV recipients with immunoglobulin G as a cutoff, and even the geometric mean titer as a cutoff. And it has been seen that most of the subjects, if you look into the total variety, and the comparator was 13, we see most of the serotypes between the groups did match. And when you don't have a serotype of a particular newer vaccine, which will be a regular thing, so you can compare with the lowest titer value of the serotype existing, and as a result we see 22F and 33F. If I compare with the lowest PCV13, it had a significant immunogenicity. Similarly, the OPA, which is a functional unit of a PCV, it also showed a significant importance in both the groups PCV13 and PCV14 when we compare the same thing, the serotype on the lower margin and serotype on the higher margin. And this is what we discussed, serotype 6A and 6B. And this is the safety. It was well established. There was not any safety issues. And when you do a catch-up vaccination, there was one vaccination study which was a phase of phase 3 study. Before that, the phase 2, which did with the toddlers between the 14 and 13, PCV 14, 13, and it was seen the immunogenicity was well established between the two groups. So we have a toddler study which was done previous to the phase 3, a regulatory component, and we have the phase 3 study. So as of now, if we want to use strategically which vaccine, we need to consider the various strains, and we need to be updated with the IPD prevalence, the strain prevalence across India causing IPD, and based on that, we should make our judgment on selection. Thank you so much.
Thank you. May I request you to collect your memento from the back? Our next session is on dengue symposium. I will request Professor Ritupoto Kundu to speak on this, and the moderator will be Dr. Manjuri Mitra.
This is just a context setting of the dengue vaccine, which is not there in India. But why we are discussing on dengue vaccine? We have never seen in this history that we discuss about a vaccine which is not there even in the market today. We all know that dengue vaccine has a challenge, had a challenge. And the challenge was basically the Dendexia, which was developed by Sanofi. And what we had seen, that the most important cause was ADE. We all know in dengue fever infections, dengue infections, we have the antibody-dependent enhancement. This antibody-dependent enhancement is an immunopathological phenomena where when a virus enters, because of the subneutralizing antibody, they develop an antibody virus component, and this antibody virus component, they will cause infection, secondary infections of the phagocytes and the monocytes, and this will be able to enter the cell and the immune cells particularly, and they have a logarithmic increase in the replication, and because of increase in viral replication, they will lead to very severe infection. This particularly happens what we know as a secondary dengue, and we are well aware in our clinical practice, but this also happened in the other vaccine. Because that vaccine, the backbone was chosen as yellow fever, but to mitigate all the problems which we had already seen with that vaccine, and to some extent I wouldn't say it is a failure because it had been used over the years in the Western countries, but again recently it has been stopped because everybody was cautious in using the vaccine, and it was only to be used in vaccine positive cases who are already seropositive, then you can use. To mitigate that, the newer vaccine which we are going to discuss in detail, we have taken the backbone of dengue 2, because that is the most common cause of dengue fever, and taking that backbone, it has been genetically engineered with the proteins of the pre-membrane protein of M and E, that is the envelope protein, from the other three strains, 1, 3 and 4, and that creates increases the innate activity of the immunity with both T, B and CMI. And because of this, the ADE, which was a concern, has been decreased significantly. Nearly 28,000 population has been studied, various studies with this vaccine, and none had the adverse events of ADE. That is one thing, and because of the NS protein, which is also incorporated in the vaccine, that gives you can see in the study, the details with Dr. Kundu will say, that gives a long-term immunogenicity, and it also has a disease-modifying effect by reducing the severity. Now with this, we do know about the studies because we build a confidence in us to use the vaccine, and you can see that so many subjects has already been used. The vaccine is there already market from 2022, and there are various countries other than obviously India, Thailand, Brazil, and Brazil has also taken it as in their EIP, and nearly 15 lakhs vaccine has been used without serious side effects. And even the criteria which was there in Envaxia that you have to use only in seropositive status, here you can use both in seropositive and seronegative status, which becomes easier for a community vaccination. Over to Dr. Kundu.
So, yes, I'll come to it. So, good afternoon everybody. At the onset, I'd like to thank Takeda and also the Institute of Child Health to give me the chance to talk about dengue, and this inspired me to go through dengue again, and I studied the vaccine in detail, and it was really fascinating to know about how dengue behaves and what happens. So it's as a disclaimer, I myself, our institute has received some financial grants because of this, but I'll try to deal with science only. So first question is, how huge is the dengue disease? We don't know exactly in our country because only those dengues which are hospitalized, they are reported, but dengue coming as a disease is not being reported. According to the World Health Organization, if the seroprevalence is positive, what do you mean by seroprevalence? if you have antibody against any one of the 4 of the dengue viruses above 10, you are taken as seropositive. If the seroprevalence of dengue in children under 9 is more than 60%, or if the maximum age of hospitalization due to dengue is in children below 60%, we call it high seroprevalence or high transmission zone. Though India does not have any data, but I think India belongs to a high transmission zone, as dengue is reported from both the north, south, east, west, almost everywhere. There is not a single state where dengue is not being reported. And if you see what are the prevalent strains, it is the dengue 2 which is maximum. How do you interpret this graph? The thicker the color, more is the number. So yellow is maximum. So the maximum number is dengue 2 serotype, be it north, east, central or south. Next comes the blue, that is dengue 1. Dengue 4 is very few cases are reported from Nagpur and few cases are reported from Andaman and Nicobar Islands. So it is the dengue 2 which is the most prevalent, and a vaccine which is highly effective against dengue virus serotype 2 is going to be a very useful vaccine for our country, not for our country, for everywhere else, because dengue 2 is the most seroprevalent everywhere else also. So why do we need a dengue vaccine? Unlike other infection, what happens, we don't have a therapy. So all of you know, during the dengue season, we almost move from pillar to post to find a bed for the patient who has a severe dengue. And prevention currently is only on vector control, that is mosquito control. Mosquito control will never be possible. As long as there is water in the earth, mosquito will be there. So this is an utopian thing. And thirdly, the only way to combat dengue is by having a vaccine. So what happens here, if you have a dengue infection, then supposing by serotype 2, then you develop lifelong protection against serotype 2. With other serotypes, you develop protection, but it lasts only for few months or at the most years. So it's a very short-term heterotypic protection. Now, when you are infected with another serotype, what happens? These antibodies are not very good. They have poor affinity, poor avidity. So what happens? These antibodies cannot prevent dengue. More and more dengue virus will enter your cell, and there will be a huge cytokine storm, much higher than the primary infection, and that is known as secondary infection causes severe dengue, as because the cross protection do not last for more than few months or years. So what will happen? So this is known as antibody dependent enhancement. Your antibody will not protect, but it will give you some more danger. And so that is the thing, that you need a tetravalent vaccine, a vaccine which will be able to cover against all the 4 strains. Now before going to this vaccine, let us take a very quick look at a dengue virus. The dengue virus is an RNA virus. It has 2 types of proteins, structural and non-structural proteins. Neutralizing antibodies are produced against structural proteins, membrane protein and envelope protein. Neutralizing antibodies are produced against membrane protein and envelope protein, and NS1, which belongs to the non-structural proteins. Neutralizing antibodies. Beside this, we produce T cells. It is the CD4 and CD8 T cells. They give protection against the other non-structural proteins, and also give some protection against the E envelope protein. So to get a proper protection against dengue, you need neutralizing antibodies which will take care of the structural proteins, particularly M and E, and also you need CD4 and CD8 T cells to get protection. And of this, one more important thing I tell you, this NS1 antigen is notorious because it causes leak in the endothelial cells, and the leak in the endothelial cells will give rise to pouring of the fluid, pouring of the plasma, serum, and give rise to dengue shock. So you need very good protection against the NS1 antigen also. So all these things are required for protection against dengue. So now what has happened? The Takeda vaccine, it is the type 2 dengue which has been taken, and this virus is attenuated. What is attenuation? Attenuation is to decrease the virulence of the virus, but to keep its immunogenicity intact. So what we did, we took a type 2 dengue virus and we decreased its virulence but preserved its immunogenicity. On that, what we have done, we have 3 attenuating mutations we have done. By genetic engineering, we introduced envelope protein and NS1 antigens of type 1, type 3 and type 4. So the vaccine contains attenuated viruses, 4 types, with type specific membrane protein, envelope protein and NS1 antigens. So what happens? It is a live virus. We have attenuated, we have not killed the virus. So when a live virus enters your body, it remains alive just like other pathogenic virus, and it multiplies. So when the live virus enters your body, first it multiplies and draws in the dendritic cells or the patrolling cells, macrophages, dendrites, which are patrolling your body to find who has entered. And this is known as innate immunity. So the dendritic cells, they detect the virus and they started secreting certain cytokines, interferon gamma, to invite more and more cells. And then they get hold of the antigen and present it to the B cells. The B cells in turn will produce antibodies. Antibodies against membrane protein, envelope protein and NS1 protein. And at the same time, the follicular T cells, they will also be engaged and they will turn themselves into CD4 and CD8. CD is T helper cell and T killer cell. T helper cell will help the B cells to transform into the memory cells. So when you have a second infection, the memory cells will come back and produce antibodies. And CD8 cells are T killer cells, they will kill the virus infected cells. So the Takeda vaccine is unique in such a sense that it produces innate immunity, it produces humoral immunity and it produces T cell immunity. So this immunity is totally complete against all sorts of viral attack. So first the innate immunity will give rise to gene expression of the virus and produce INF gamma to draw in more and more cells. Then the B cell immunity will produce neutralizing antibody response, and not only antibodies, these antibodies are of high affinity and avidity, which will come later, and also they are complement fixing antibodies. And not only that, they will produce antibodies against the NS1 antigen, which is the principal cause of pathology of dengue by causing transgression of the fluids through the endothelial gaps between the endothelial cells, and it will produce also cell mediated immunity. So all the three aspects of immunity has been covered by this vaccine. So this vaccine was studied in a huge number of countries in North America, in South America, in Europe, and also in Asia. 14 countries were studied where phase 1 to phase 3 style. Phase 1, phase 2 studies are usually safety and immunogenicity study. We don't study the efficacy of the vaccine. These are mainly safety and immunogenicity. As much as 28,000 participants were taken from the age of 1.5 to 60 years, and they found about 28,000 patients, subjects taken, a good number was seropositive. That means they already are infected with dengue and they have antibody against the dengue virus, and some were seronegative, that they were never exposed or they were dengue naive. Next comes the real study, which is the study which sees the efficacy, safety and immunogenicity. This study was done in only those places where dengue was epidemic. For example, these are the South African countries in 1, 2, 3, 4, 5, and 3 countries in Asia, Sri Lanka, Thailand and Philippines, where the study was done. So this study was double blind, randomized and placebo controlled. 20,099 children was taken in the age group of 4 to 6 years. Of these children, 2 received the vaccine and 1 received the placebo. Before giving the vaccine, immunological assessment was done to see the serostatus of the individual who either received the vaccine or received the placebo. At the end of 12 months, 1 year after the second dose of vaccine, the primary endpoint was decided. What is the primary endpoint? It was the vaccine efficacy against virologically confirmed dengue. Virologically confirmed dengue vaccine efficacy. We didn't bother about the seropositivity. We didn't bother about whether the child required hospitalization. What type of dengue was it? 1, 2, 3, 4. We didn't bother about that. We only showed vaccine efficacy against virologically confirmed dengue. The second point was done after 18 months. Here we took into account the serotype, vaccine efficacy against the serotypes, whether the child was seropositive or seronegative, how severe was the dengue and how many of them was hospitalized. And the ultimate, after 4.5 years, a long-term again follow-up was done to see the efficacy and safety. Through and through, once the child entered the study, an active febrile illness surveillance was continued, and each fever the child had, the child was investigated whether the child has dengue or not. So it contains a huge sample size of 20,099. 72% was baseline seropositive. That means 72% of the children who received vaccine had a dengue infection in the past, and 28% was dengue naive. They never had any dengue infection, and follow-up was done for 4.5 years. And let us see what is the result of this study. First of all, what we neutralizing antibody. We measured the neutralizing antibody against the 4 serotypes. As I have told you before, previously it was thought if you have a neutralizing antibody more than 10 GMT, you will be taken as protected against dengue. But ultimately it was found there are no protective level. To our utter surprise, we found that those who were dengue positive means already infected to dengue, all the 4 serotypes has neutralizing antibodies more than 100. And those who are dengue negative, seronegative, also in them the neutralizing antibodies were of more than 100 in them also. And we studied what type of antibody it is. We studied the affinity and avidity. What do you mean by affinity? Affinity is how strongly an antibody binds to the antigen epitope. And what is avidity? How many of the antibody sites binds to the antigen. A antibody which has high affinity and high avidity will be just like a Velcro. The Velcro, you know, it binds very strongly with all the points. So it was found that the neutralizing antibodies against this vaccine was of very high avidity and affinity, and also it was complement fixing antibodies so that you could neutralize the virus. So another study we done, we saw what was the antibody concentration against NS1 antigen, because it is the NS1 antigen which promotes vascular leakage, the hallmark of the dengue disease. So it was seen that at least till 15 months it was very high with all the four, particularly against the dengue virus type 2, which is the most dangerous of all the types of dengue virus. So the efficacy of the vaccine at primary endpoint at the end of 12 months, the efficacy against vaccine confirmed dengue, irrespective of serotype severity, was as high as 80%. What do you mean by efficacy? How many cases occurred in the placebo group and how many cases occurred in the vaccine group? By this we study the percentage. It was seen at the end of 12 months efficacy was 80%, and at the end of 18 months efficacy against vaccine confirmed dengue was as high as 90%. So efficacy irrespective of serotypes against vaccine confirmed dengue is very high. So next we studied what was the vaccine efficacy against vaccine confirmed disease at the end of 4.5 years. It was seen that overall efficacy, if you don't take the serotype into account, it is 61%. And those who are seronegative, that means those who have never had dengue in the past or dengue in them, it was 53%. And those who are seropositive, it was 64%. So this is a good amount of protection considering the seroprevalence or the number of cases of dengue. So much so that every 1,000 vaccinated you can prevent 5,000 cases in seropositive and 4,300 cases in seronegative. So now comparing what is the vaccine efficacy against hospitalized virally proved dengue at the end of 4.5 years. If you take overall, it was as high as 84%. If it is seronegative, it is 79%. If it is seropositive, it is 85%. So this vaccine gives a very good protection against hospitalization. Now comes what are the efficacy of the vaccine against different serotypes. The efficacy of the vaccine at the end of 4.5 years against dengue type serotype 1 52, 2 is 82, 2 is the most dangerous. It's a highly effective vaccine against type 2. Dengue type 3 is 42%, type 4 is 48%. And what is the vaccine efficacy against hospitalization? Again, it is very high with dengue type 2. This is 100%, I will come a little bit later, why it is 100%. So now if you come to the vaccine efficacy in all the 4 dengue serotypes in baseline seropositive and seronegative, the size of the circle depends upon the number of cases. So those who are seropositive, that means already they had dengue in the past, in them against D1 the vaccine efficacy was 56%, against serotype 2 was 80%, in serotype 3 was 52%, in serotype 4 was 76%. But if the child was baseline seronegative, then the vaccine efficacy was very high with dengue serotype 1, serotype 2. But with serotype 4, the vaccine efficacy was not there, it was negative. Why? Because the reason is the number of cases of the 2099 cases, dengue virus 4 was reported only in 3 cases. The basic, if you have only 3 cases, then you cannot come to a meaningful conclusion. So that's the reason why it showed such a abnormal result. And similarly also during those period, the circulation of dengue 3, these are the 2 less common type of dengue we find in these countries, was also very less. So that's the reason why these 2 shows abnormal results. And Takeda has now planned, they will do a long-term study to see the efficacy of the vaccine against these 2 serotypes. And these are a future study which is being done, and the results will come out shortly. Now what is the rationale, why you are giving 2 doses? Measles vaccine, how many doses you give? Measles vaccine, you give more than 2 doses. It's a live vaccine. Similarly also, it has been seen if you give a live vaccine, at times your body does not take the vaccine. So after a single dose, seropositivity is only 85%. But if you give a second dose after 3 months, then it goes high to 99.5%. So that's the reason 2 doses were planned, given 3 months apart. Is the vaccine effective in adult? What they have done? In adults they have taken patients and they have given vaccine, and after 9 months of giving vaccine, they studied the antibody level. It's a non-inferiority study which the antibody level was similar to those seen in children after 9 months against all 4 serotypes. So this vaccine is quite safe also in adults also. And not only safe, this vaccine is immunogenic. It produces almost equal amount of neutralizing antibodies. So non-inferiority proves that this vaccine is going to be effective in adults also. And regarding the safety, it is a very safe vaccine. As you compare, there is no evidence of increased disease severity which was seen in the previous vaccine, no increase of hospitalization, no death, nothing. So it was very good safe. Next, of the safety analysis which was done, solicited adverse effects was there, but these are, rash was the most common adverse reaction. Beside this, we had injection site pruritus, little bit of bruising, it's a pyrexia, fever occurred in 8.9 after any dose. So these are negligible side effects as compared to the severity and the problem the disease causes. So what is the regulatory status? It was in 2022, in Indonesia the vaccine was first licensed for 6 to 45 years. Then the European community has given license from 4 years and above. Then it was UK, Argentina, Brazil, Thailand and Colombia. They also have given the vaccine license, the vaccine. Regarding 2024, these are the 4 countries, and our country is at the verge of giving the license. According to the World Health Organization, if dengue is a high prevalence or there is a high transmission, dengue is there, this vaccine should be given. And I have told you what are the markers of high dengue transmission. If your seropositivity rate in under 9 children is more than 60, or the maximum number of hospitalization with dengue is less than 16 years, I think this vaccine follows, and very soon it will be given license by DCGI. And these are the forthcoming things which are studies. Efficacy of the vaccine against dengue 3 and dengue 4. This is the study already going on. Results are soon expected. Whether it can be given in older adults and in patients with comorbidities, because dengue is a very serious disease. If you have diabetes, if you have cardiac problem. And thirdly, what is the real world population impact? And we still don't know whether a booster dose will be needed or not. As of now, till 4.5 years booster dose is not needed, but later whether we need or not, that will be decided. And so this is to sum up. The live Takeda vaccine elicits serotype specific neutralizing antibodies and cross-reactive humoral and cell-mediated antibody with high titer of seroconversion. Robust clinical development plan to more than 28,000 subjects has been studied, and the follow-up was done for 4.5 years, which shows a very good protection, 61% protection against virally confirmed dengue and 84% protection against hospitalization. Already the vaccine is approved in 40 countries and European authority approves in more than 4 years. And WHO has recommended this vaccine. It is included in National Immunization Program in Brazil, and globally more than 12 million doses with no safety signals. And in India we are waiting for the DCGI, because dengue vaccine is a vaccine which is really the need of our.
Yeah, thank you, Dr. Kundu. I think we had a very elaborate discussion. I'll just take 1 minute because most of the audience was not there during the initial discussion. So what is most important about the dengue vaccine? We have heard about the safety and immunogenicity that is well established. Why the previous vaccine failed, or rather why the previous vaccine had lot of side effects, which was a very severe concern for the vaccination world like us. So one of the important things, this particular vaccine has taken care and tried to mitigate all the problems which the previous vaccine had. The antibody dependent enhancement, which was result of a severe dengue infection, which in our clinical terms we understand secondary dengue. Now what this particular vaccine has used, the previous vaccine had the yellow fever backbone, but this vaccine has used the vaccine 2, serotype 2 as a backbone, and serotype is one of the most prevalent types which is available, which is seen in the dengue fever. And along with that, they mitigated the seriousness with the protein, the C protein M envelope and the NS protein, which Dr. Kundu just explained. NS protein is one of the most serious notorious thing. Now this genetically engineered protein has prevented the ADE, and all the subjects which we have seen over the years in the study, nearly 20,000 population did not have a single ADE in spite of seropositive or seronegative status. And even the NS, because of the NS1 protein, NS protein which is incorporated in the vaccine, it had a longer life of safety and longer life of prevention, because that has a disease modifying effect, and that is what is important for us to understand. When we get the vaccine, we should not have the concerns which was there, and many of us may have the concern, but I think a time has come when we should not have the concern anymore. Thank you so much. There was a question for Dr. Kundu.
Thank you, ma'am. We would request you to please collect your memento. Up next, we have a session on vaccine tete-a-tete by S.G. Kasi and Nitin K. Shah.
I don't have, I took enough time to understand these two vaccines. I didn't go to the Panacea vaccine.
What about the children below 4 years?
They will do studies very soon, children below 4 years. Chalo.
You should also ask, what about 4 to 6 years? You should also ask him, what about 4 to 6 year old children? Okay friends, so first of all, we are very happy to be here again, and we really thank the ICH and Dr. Apurva Ghosh. And I always tell,
people are complaining they cannot hear.
Acha, can you
call on mic?
No, not call on mic. It's okay, it's okay. We'll see. You keep it here. Okay. So when Dr. Apurva Ghosh invites, we cannot say no. That is the principle in my life. I really love that person. He's devoted his almost entire life to the growth of ICH. And I think 3 cheers for Dr. Apurva Ghosh. Even at this age, he still continue to work for ICH progress, and I'm really happy. So he gave us very important session. This is what you call a tete-a-tete, or that's like a private chat between 2 people. We'll of course make it public for you. And what we thought is that we'll take some common scenarios in vaccine and ask question to one another. And then I request, if you have any questions, please pass it on, or maybe use one of the mics if possible, and you can ask question on any vaccine which you think is right. So with that format, between 2 of us we have made some question, and we will be asking cross question to one another. We are all old people here like me, so we need to understand as to that adults also need vaccination. Especially when we are healthcare workers, we are more prone to diseases, and our patients are more prone to get diseases from us. So my first question to Dr. Kasi is that, which are the vaccines that a healthcare worker should take definitely?
Yeah. Thanks to the organizers. Healers, take care of yourselves. We have to take care of ourselves, only then can we take care of our patients. So we should not try
limited way unless you are immunocompromised, which means it's already working in presence of antiviral antibody. It will work in someone who is totally naive. I mean, that's why I'm saying it should actually replace varicella vaccine sometime.
Yes.
Now coming back to this, would you give it again if you had zoster? The answer is yes, because the recurrences are known. In fact, there was a beautiful study done in Korea where they looked at the chances of recurrences of zoster after you had zoster in the past, and they found that it's more common in those who had bad post-herpetic neuralgia in the past, especially lasting for more than 90 days, in females, in people who are above the age of 60 or 70 years, and if you have autoimmune disorder or you are immunocompromised like malignancy. These all have a risk which is more than 1, which means hazard risk is 1.5 to up to 4.5. And usually it happens up to 5 years after the last zoster. So once you have zoster, you should try to take it as early as possible, because don't wait for the second zoster, which could be bad.
Is the second episode generally more severe than the first episode?
So it is not proven, but generally because it's going to happen after 5 years,
Right.
maybe it will be more severe, if not as bad as in the previous one.
Okay. Yeah, you can change it. Now, we are hearing a lot of exciting news about newer pneumococcal conjugate vaccine. PCV20 has just arrived in our
Yes.
country for adults.
Yes.
Dr. Nitin, will you throw some light on the newer PCVs, how they differ from each other? Why is it not licensed for children in our country?
Correct. So PCV20 is an extension of the PCV13 brand by adding 7 more serotypes. Let's not name them, but it also has a 22F and 33F, which is there in the PCV14 from the biological E. And there are other 5 serotypes like 8, 9, 10 and 12F. But the question is, once US has started using PCV since 2000. First PCV7, then they moved to PCV13, and now it's more than 25 years. After that, those vaccine serotypes have disappeared from the community, not only in children but adults. Now what remains is the remaining disease burden, which is very small in number in children but quite significant in adult, but they have a different serotype than what is the existing vaccine. So to cover those remaining serotype, the extension brands are made. So you have PCV20 from Pfizer, which is 13 plus 7 serotype, and you have PCV21 from MSD, which has 11 different serotypes than PCV13, and 7 serotypes which are very unique, which are not there in any vaccine, including polysaccharide vaccine. Right. Now this additional serotype in USA, after 25 years use of PCV in the national program for children and in adults, it covers 55% of the serotype when it comes to PCV20, and almost 85% serotype when it comes to PCV21. So they have now replaced PCV13 by PCV20 or 21 for adult population, and even in children, because whatever the disease burden is remaining is the additional serotype. So they have switched from PCV13 to PCV20 even in children. In our country, as the studies are just over for adults, the license is given for 18 years to 49 years for those who are at risk of severe pneumococcal disease, and above 50 for everyone, like how it is for PCV13. Below 18, it is not licensed in our country because the studies are still going on. And you know now the DCGI does not allow any vaccine to come without a local study. Once the local study in children is over, I am sure PCV20 will replace PCV13 even in our country.
Now, Dr. Nitin.
Yes.
if you see US has a very strong surveillance system.
Yes.
So after PCV7 they knew which are the serotypes.
Absolutely.
So then came PCV13.
Yes.
Based on the same data now PCV20.
Correct.
Do you think the same thing applies to our country? We are using PCV10.
Yes, and
So
we also use
will
PCV14.
PCV20 have additional benefits?
We also use
If
PCV14.
yes, how much?
We also use PCV14 in public health. Now 50% of the states are using PCV14, 50% using PCV10. So when you don't have surveillance, you have no other choice but to take from the countries which have surveillance. And generally, if you see, the serotypes in the developing countries are similar. In fact, if you look at the PCV10 of Serum Institute of India, it has taken the 10 commonest serotypes in children from the world. It's not an Indian vaccine, though it's made in India. So I think, I'm very sure that the type of serotype replacement that we will see, not replacement but of the remaining disease burden, would be very similar. Except some countries like Bangladesh, suddenly 12F as a very high, but that's one off. But generally the trend is similar all over the world. So I would use PCV20. Mind you, it just costs 1,000 rupees extra than PCV13. In fact, I just ordered 2 doses yesterday, one for me and one for my wife. So you can say that it's a safe vaccine. It's as painful or as simple as the PCV13, but definitely worth, because we don't know. I mean, if you take PCV13, it will cover those 13 serotypes. You take 20, another 7, there is no harm. Maybe some of those serotypes will emerge in India, will be protected better. The advantage of taking PCV20 and PCV21 is that you don't need PPSV23 to be taken after, as you need after PCV13. So it's just one shot in your life for any pneumococcal disease.
And Dr. Nitin, if one of us has taken PCV13 and now PCV20 has come, is there any minimum interval you have to keep between the 2 doses?
Take it after 2 years. Or, so 2 to 5 years is because there are a lot of antibodies against those 13 serotypes. If you take anything which is very nearby, then it will dilute the effect of that 13 serotype. But you are interested in the remaining 7 serotype more than the 13 common serotype.
Done.
And that's true for even PPSV23. You don't take it for at least a year after the last PCV13 in a non-immunocompromised host.
So I think we are all eagerly waiting for PCV20 for children to be licensed.
Yes.
And I don't think the day is too far off.
That's too far. It's maybe 6 months to 1 year.
Right.
All right, Dr. Kasi, I come back to you. Now, rabies, lot of confusion on rabies. In fact, I conduct the monthly vaccine seminar for the IIP Maharashtra. That's not a vaccine samvad. It's on the first Friday of every month. And this next month, September Friday, first Friday is on rabies, because there's so much of confusion about rabies. So I will narrate this. Dr. Kasi, a 4-year-old has completed pre-exposure prophylaxis. Now we are saying, because rabies exposure is so there, plus these monoclonal antibodies are expensive, people don't know when to use it. If you have taken a pre-exposure, then 1, you don't need to use those, and 2, you only need 2 more doses instead of the all set of 4 or 5. So pre-exposure prophylaxis was offered to this child, and he took it on day 0 and day 7. Now day 8 there is a bite. What do? You continue another 2-3 doses, you restart. Do you give monoclonal antibody? You don't give. What is your take on this?
Okay. When does protection begin after you give a vaccine? It doesn't begin the next day or an hour after you give the vaccine. There is a time interval. Generally, for all vaccines, it's at least 2 weeks. What about rabies vaccine? Now, this is a study which has shown the antibody titers following intradermal and intramuscular pre-exposure prophylaxis. If you look at the arrow at day 8, very few have reached the protective titers of 0.5. So in essence, this child is unprotected as far as this immediate exposure is concerned. So he requires both passive protection and further doses of the vaccine. So you give monoclonal antibodies, the rabies immunoglobulin is necessary. Now if you are given the monoclonal antibodies immunoglobulin, what happens to the previous 2 doses?
Correct.
Will they work? Will they not work? There is no data, no study to show, but generally in Syrian hamsters, studies have shown that intralesional immunoglobulin administration does not interfere with the vaccine take. So in this case, you give monoclonal antibodies and you have 2 choices. You either finish the schedule as a post-exposure prophylaxis or you restart and give it again. Personally, I would like to restart because rabies, there is no question of taking any chance.
So if when you restart, at least the day 8 can be taken considered as the day 1?
Day 1.
So you'll give 3 more doses.
Yes.
Day 1 is already over, day
Yes.
3, day 7 and day 14 to 28.
Yes.
I think perfect.
Right.
All right.
So This is what I just said. In case of rabies vaccine, earliest to get the protection is at least 12 to 14
Correct.
days after day 1. So day 8 there is no protection. I think this is something that you may come across, so please keep it in mind what is to be done in such a situation.
So remember, the local monoclonal antibody which are given are never to be given intramuscular. So there is no chance of it interfering because there is no absorption from the local side. Unlike in the past where the immunoglobulins were given half local, half intramuscular, where there was definite interference with the vaccine uptake if given beyond 7 days after you have started the vaccination. So that rule probably does not apply here. Let's take one more situation.
Dr. Nitin.
Yes.
A kid has a category 3 exposure. He goes to the closest PHC. He is
Right.
given intralesional immunoglobulin and he has given the first dose of the vaccine. Somehow they are not happy.
Okay.
They come to you in your clinic.
Okay.
Now you are an expert in ID. You
Okay.
give 15, 20 newborns BCG
Okay.
in a month.
Yes.
First question, will you use ID rabies vaccine in your clinic? Second, if you say no, how are you going to
Correct.
consider the first dose as invalid and restart, or is it valid and will you continue? And the next question is, if you don't have the same brand, are rabies doses interchangeable?
I think this is a very important question. So number one, will I give intradermal? No, I will switch to intramuscular because I don't have enough number of patients that I am going to save. Intradermal is a dose saving mechanism. If someone can afford, give intramuscular. Giving intradermal needs an art, and if you are not very good at giving intradermal, if it goes subcute, it won't work. So I will not take the chance. Second, what am I going to do with the remaining vaccine? I'm going to throw away. Instead, I would give intramuscular. Now the question, can you switch from intradermal to intramuscular and vice versa? So there's a beautiful study done by Dr. Sudarshan group from Nimans and Bangalore, and they did it not by choice because WHO says that once you have a route, you continue the same route, and once you have a brand, you continue the same brand. I mean, that's true for most of the vaccine. But as Dr. Kasi said, there is a shift from intradermal to intramuscular because people don't want to go back to public health, and vice versa. They have taken first dose in an emergency with me, now they cannot afford my charges. So they want to go to public health and they want to take intradermal. And they also saw that the brands are based on the tender committee. So sometime a tender of an X brand is taken, next time it is Y, third time it is Z. And some of them are the same Viro cells, some of them may be pure chick embryo vaccine, like Rabipur is pure chick embryo vaccine, Indirab, Abairab, etc. Rabivax, they are Viro cell vaccines. So can you interchange? So they did this study in almost 90 bites which were suspected rabies bites, and in group A they switched from intradermal to intramuscular or intramuscular intradermal, and they found what they did, what was the endpoint? Number of subjects achieving more than 0.5 neutralizing antibodies, the RVNA, on day 14 because that is protective against rabies. And they found that whether they switched from intradermal to intramuscular or vice versa, all subjects achieved that titer of more than 0.5. In the group 2, they had children, they had adults who had, subjects who had taken one brand, but that was not available to complete the schedule, so they switched to the other brand and vice versa. So from chick embryo to Viro and Viro to chick embryo, almost similar number of subjects, and they again studied the 0.5 as a cutoff at day 14, and they found all subjects achieved at that 0.5 cutoff. Not only that, all subjects in all the group achieved 15-fold higher antibody titer, which means not only it worked, but it worked very well. And then subsequently they did an actual study in 20 volunteers. 10 volunteers had received intramuscular vaccine in the past of chick embryo, the 10 had received the Virorab, intradermal and intramuscular, and next time they gave a booster, 2 doses after 2 years, switching from intradermal to intramuscular. So if someone had received intramuscular in the past, they had received intradermal and vice versa. And again 0.5 as a cutoff on day 14, they found all subjects achieved the titers, and again 15-fold rise in antibody titer. I think this is a landmark study for developing countries' point of view, that you can, one, switch from intramuscular to intradermal or vice versa, and two, use any brand which is licensed in your country.
So the message that should be given is interchangeability should not become a standard of care.
Yes.
But where inevitable, change of route, change of brand is permitted.
Absolutely, by default, not by choice. Right. All right, Dr. Kasi, let's continue with the last case of, and this is again things which keeps on coming in WhatsApp group, especially if you are in the Gujarat WhatsApp group of people who are working in peripheries, that the 3-year-old child was playing with the dog at the home, probably were not vaccinated, we don't know. He was found licking the saliva around the mouth. Very common. Children kiss dogs and cats, right? and after 1 month the dog died and was found to be actually having rabies. Now the parents are in panic mode. What do you do?
Yes.
All right.
Right. Now, 3 situations. There is a high risk of rabies, there is a low risk, and there is no risk. How many will opt for high risk? Some risk, no risk. I think all hands raised do not even come to half of the people in the audience.
I think the question is, was the dog having rabies in the saliva at that time?
Yes.
And is mucosal exposure a cause to worry or not to cause worry? These are the 2 questions that Dr. Kasi please answer.
Just go to the next.
Yes.
Now, if you see the pathogenesis of rabies in a dog, it is just like humans again. Now, what happens? A bite occurs through the nerves, it goes to the spinal cord. From the spinal cord, retrograde axonal transport to the CNS. From the CNS to the saliva, and the virus comes out to the saliva. That means the virus is in the saliva after the CNS is involved. The question is, if the CNS is involved, can the dog be asymptomatic? So can virus be shed in the saliva in the incubation period?
Correct.
Somehow it seems that no, how can that dog remain asymptomatic if the CNS is already involved? So,
yes.
There was a, come, next slide, just go ahead. Now, previous.
Okay.
Now, dogs begin to excrete the virus in the saliva shortly before clinical symptoms occur. Infectious viruses has been detected in the saliva up to 10 days before symptoms start, meaning the animal is contagious during the late incubation period as well.
Correct.
And literature states just around 10 days, not more than that. So in this case, this occurred 1 month ago. There was no subsequent exposure to the saliva. So you can convince the patient that the risk is not there, but you can always use this as an opportunity to start pre-exposure prophylaxis.
Perfect.
So these are some of the intricacies of rabies which we wanted to bring out.
Yeah,
in
but
this
suppose
particular
this had happened and the dog dies within 5 days. Now that's
Then
a very
it's a-
high risk exposure.
It's a very high risk
He's
for
proven rabies, the dog is proven rabies. So now, how will you give the monoclonal antibody when you have mucosal exposure?
Now, generally, in someone who is old enough to gargle,
rinse.
You will give monoclonal antibodies or the immunoglobulin, dilute it and ask them to thoroughly rinse the oral mucosa. If the child is very small and incapable of rinsing, this is one situation where you may give intramuscular immunoglobulin or monoclonal antibody.
And same way you will do for any conjunctival exposure, you just rinse it with diluted saline and the monoclonal antibody?
Well, you can dilute. I mean, how much you dilute to
Yeah.
is really
There are
not
no-
very.
absolutely.
I mean, how much? 10 times, 20 times. Studies have shown that even if you dilute it 500 times, that antibody is still effective.
So that brings to the question that there have been deaths of rabies where multiple bites were happening.
Yes.
Everything was done including monoclonal antibody and proper vaccination. Why the rabies still happened? Probably some wounds were left
Yes.
behind because the volume was not diluted enough to cover. Generally what people do is cover the major ones and forget the minor one. If there is a minor cut on the pulp of the finger, that's more dangerous than a bite on the thigh or on the abdomen, because this is an innervated area as compared to the abdominal cavity. So remember, first calculate what is the surface area, then you know how much ml you are going to need, then you know what is the volume of monoclonal antibody that you can actually use based on the weight. So how much dilution is required? 1:1, 1:2, 1:10, 1:15, dilute it and then use it in every wound. Probably you will not have any
And one more
issue.
take home message. Younger the child is absolutely essential. You should strip the child and examine every
Yes.
inch of the surface.
Because the child,
so that you may not miss out any minor.
the child sometimes refuses to tell what happened, so in a scared child always strip and see. And monoclonal antibodies are now easily accessible, they are cheap, they are available. You should keep 1 or 2 vials in your clinic, they have long expiry. I think generally 90% of the wounds in children are category 3. We tend to underplay because we don't want them to expose to a little expensive medicine, but I think it is a disservice, especially if it's a rabid bite. Fortunately, we get away by not giving monoclonal antibody in a case where it is required because the bite is not from a rabid dog or a cat. But believe me, if you are domestic, not a domestic but a wild cat or a dog bite, and that dog disappears, then it's a big problem because you don't know what's going to happen the next. All right, let's switch gear, Dr. Kasi.
Right, Dr. Nitin.
Yes.
Everyone is excited about nirsevimab or Beyfortis.
Okay. Is it because is it because of the cost? Is it because of the cost that they are excited, or because of the efficacy?
Availability, and that enthusiasm is dampened by the cost.
Perfect.
Okay.
All right.
Now, what is it? Is it a vaccine? Can you give us some, briefly describe this, and how does it compare to maternal immunization, which is more cost effective?
So this is not a vaccine, it's a monoclonal antibody like your rabies monoclonal antibody. It is for prevention, but it doesn't act as a vaccine. So it has a limited protection till the time it remains in the body. Unlike vaccine, which probably may give you lifelong protection. It's an IgG1 kappa antibody against the pre-fusion protein of the virus. So what it does is, because of the antibody, it blocks the virus in the pre-fusion conformation. It does not allow the infection of the respiratory epithelial cells. So it blocks the RSV entry into the epithelial cells, and that's how it prevents RSV disease. And it acts against both RSV1 as well as RSV2. Alright. Now this is also changed by two or three different mutations done to increase its longevity. So the half-life is so much that even one injection will give you immunity up to 5 to 6 months. Unlike pelivizumab, which was the previous monoclonal antibody, which had a very restricted use only for the extreme preterm, that too with CLD or a chronic lung disease or chronic heart disease or a immunocompromised host, etc., which would cover around say 2% of the population in any country, preterm population. Whereas this monoclonal antibody is not only for that type of indication, but also for late preterm and full term babies. So actually the entire birth cohort is eligible to receive RSV monoclonal antibody nirsevimab, because it is a very wider coverage and a wider indication and a very long half-life. Now single injection before RSV season gives you protection up to 6 months, definitely as studied, but now we know the antibodies persist for even 1 year, so probably protection will last also for 1 year, as also was seen in South Africa, where the monoclonal antibody was given, but the season only began after 6 months. So up to 1 year they studied and they found that the efficacy was good. Now this monoclonal antibody works a single dose. The efficacy trials are done in 3 different categories. One was from 29 weeks to 35 weeks preterm, where it was compared with placebo. Second was in late preterm, 35 weeks onwards, and full term as a second cohort. The third was the extreme preterm, 22 to 29 weeks, which were also eligible for pelivizumab, where the comparison was done with pelivizumab. And lastly, based on these studies, they looked at a post-marketing study like Harmony, what they call, 3 different countries, and they looked at more than 20,000 children given this, they were late preterm and full term given this RSV and studied the season. All these studies showed that the medically attended RSV, which means someone who needs your attention, was prevented to the tune of 75%, and hospitalization for severe LRTI caused by RSV was prevented to the tune of 80 to 85%. And all those countries which have included this monoclonal antibody in the national program, like Spain was the first one, and when they studied, the season disappeared from the second year onward after RSV molecule was introduced. Like what happened with rotavirus, similar way. And they continue to remain low with more than 90% coverage. After that, Chile has used it, and Chile also showed that when the monoclonal antibody was not there, there used to be around 15 deaths per year in the country because of RSV, and moment this molecule was introduced in the national program, there was not a single death in the next 2 years. So there was some mortality benefit shown indirectly. And now more than 55 countries this monoclonal antibody is licensed and is being used in more than 15 to 20 countries. It's available in our country at Beyfortis. It's so dose is 100 milligram for below 5 and 50 below 5 and 100 above 5, and if used in the second year, especially for those with chronic lung and heart disease, is 200 microgram. Now the cost of 50 or 100 is the same, and that is 40,000 rupees. So that's the problem, that where do you use it. I would definitely use it in NICUs where the babies were admitted for sick, like meconium aspiration, preterm, RDS, prolonged stay. They are the ones who will come back with RSV and you can lose them. And they are the ones who have paid heavy bills for preterm care. I think they should not come back with an RSV. So to start with, maybe those, and those who can afford 40,000 rupees, maybe every full-term child, theoretically can receive it, because it's not that RSV happens only in preterms and those at risk. In fact, 65% of those who are admitted are actually healthy full-term babies. So it's indicated in that sense in all the babies. Coming to the maternal immunization.
Suppose you are in charge of ACVIP.
Yes.
Do you think you will recommend this as a
I would
routine
say
vaccine?
that this monoclonal antibody should be recommended or to be exposed to the parents, because we cannot be judgmental as to who can afford, who cannot afford. The efficacy and the benefits are so overwhelming, and we have all seen RSV morbidity and mortality in our day-to-day practice in the first year of life. I think it will be disservice to say it should be indicated only for preterms or at-risk babies.
Do we have robust data about epidemiology of RSV in India?
Oh yes, there are several studies on RSV in India, including the seasonality and the age group involvement, etc., which looks very similar to what is seen in the Western countries. Yes.
Fine. I think so. The new kid on the block, but an expensive kit to maintain.
Yes.
Let's see what we are going to do about it.
So there is also, so the question is why there is no RSV vaccine for children? Now, as you heard in the previous session about the antibody dependent enhancement of the disease in dengue, similar thing happened of antibody enhancement disease for RSV when the first inactivated RSV vaccine was used when we were student. It led to more mortality than benefit. So no one would venture to do that in infant, but there is vaccine available for adults above 60 years. In fact, there are two vaccines, one from GSK, one from Pfizer, and the Pfizer vaccine is also licensed for use during pregnancy. So you give between 26 to 34 weeks single dose of this RSV vaccine. They have studied the benefit to the baby who will be born thereafter up to 180 days. The medically attended RSV comes down by around 50-55%. So it's not as strong as 80% with the monoclonal antibody. That's why more and more countries are preferring monoclonal antibodies rather than RSV immunization, except there are 5 countries which have both immunization for the mothers to prevent the baby getting infected, also giving a choice to the parents to take the monoclonal antibody.
Anti-RSV neutralizing antibodies are much higher after Beyfortis versus maternal immunization.
Absolutely. And they are higher than with Pelizumab.
Right.
And they remain high up to 1 year as compared to Pelizumab, where there is a yo-yo effect. So that's why this monoclonal antibody is the one which is going to rule the world. All right, Dr. Kasi.
We'll go a bit fast now.
Bit fast, yes.
Okay.
JE. There is JE vaccine in the national program around Bangalore, but not in the city of Bangalore. There is JE vaccine in the public health in Navi Mumbai, Dr. Yevle's place, but not in Mumbai where I am there. And I every Tuesday go to his place. Can I get bitten and get JE? Should I take it when I am in Mumbai or I am in Bangalore?
Okay. Now, let's talk about Bangalore. We have an adjacent district called Kolar, which is hyperendemic for JE. The line between Kolar and Bangalore is an artificial boundary which probably the JE virus is not aware of, that such a boundary exists. So it can freely move around. But at least for the past 30-35 years, there has been no indigenous JE case in Bangalore. So, why is that so? Now the WHO has very clearly said that even in the absence of surveillance data, if an non-endemic district adjacent to endemic district has got favorable circumstances for JE transmission, like you have pigs, you have water birds, you have open bodies, and you have the particular strain of mosquitoes, one can consider initiating JE vaccination. One more thing. Tanjavur is a district in Tamil Nadu, adjacent to it is Nellore. Nellore is JE endemic, Tanjavur is not endemic. No JE cases, just sporadic cases. But over the past 20 years, JE positivity in Tanjavur has been increased manyfold.
Serology.
Indicating silent transmission.
Correct.
Yes.
Correct.
So, should we wait for the first JE outbreak to occur, or should we take cognizance of the fact that asymptomatic JE seroconversion is happening and at some time the volcano is going to erupt?
Absolutely.
So, taking these things into consideration, adjacent JE district, in your own district you have factors favorable for JE transmission. I don't think we should wait for the government to declare it as an endemic district and start vaccination.
Absolutely.
This is my personal opinion.
In fact, I share the same personal experience, and I also say that of late, since last few months, I have started putting JE vaccine as a recommended vaccine in my folder, so that unless it's there on the folder, you don't remember to expose the parents, because there are so many vaccines. And believe me, It's a cheap vaccine, it's not that costly, and when you say something about brain fever, people are worried. So more than meningococcal vaccine, there is more acceptance to take JE vaccine because it's a cost-effective vaccine. So a lot of people are taking JE vaccine in Mumbai, at least as far as I am concerned in my practice.
Right. Dr. Nitin,
Yes.
my doctor friend calls me up one day and says that I got a needle stick injury from a HBsAg positive source.
Correct.
The doctor had received 3 doses of hepatitis B vaccine in childhood, but he has not documented a
Correct.
response to it.
Yes.
What is the course of action?
Yeah. So when you have a needle stick injury from a HBsAg positive source, your worry is that you will get the hepatitis B infection, which after 6 to 8 weeks may become symptomatic because there's a long incubation period, and then you may become either acute hepatitis, a chronic carrier, and over 20 years may develop chronic liver disease and even a CA of the liver. That's your worry, and that you don't want to happen. Now, if you have taken hepatitis, if you have not taken hepatitis B vaccine in the past, there is no question. You are not protected. You take your immunoglobulin and you start your vaccination 3 doses, and then you show that you have seroconverted at the end of the 3rd dose. But if you have taken the vaccine, then maybe you are protected because 95% adults who have taken vaccine, or even children up to 98% will seroconvert, and once you have seroconversion, you are protected. So his doctor has taken 3 doses in the past, but he has not documented. Had he documented seroconversion after the 3rd dose when he was a child, he is protected, he doesn't have to do anything. Don't even do the test to show the titer. If he has done the titers below 10, no worries. But here he has not shown the documentation, so he will do first of all his anti-HBsAg antibody titer. If they are above 10, then forget, he is protected, go, rejoice. And now next time take a proper precaution not to have a needle stick. But remember, needle stick doesn't only lead to hepatitis B, it can lead to hepatitis C and HIV also, for which there are no vaccines. Now if his titers come below 10, we don't know whether the titers have fallen as would fall in 40% over 20 years, or he was a primary non-responder. There is no choice, he has to take the immunoglobulin and the dose of vaccine again, and again show that the titers rise. You have choice, either take only 1 dose of vaccine or 3 doses. People say nowadays to complete 3 dose schedule. If you take 1 dose, then after 1 week you can do the titer. If there is an anamnestic response, the titer will jump to thousands. You know you are a responder. In any case, you have taken the immunoglobulin and the vaccine. Or better to finish the 3 doses. Remember, the dose of immunoglobulin is 0.06 ml per kg. So over a 50 kg person is 3 ml. But none of us are 50 kg anymore after taking the Mishti Doi and Rasagulla which was there outside. So we will probably need 5 ml. You take 5 ml of intramuscular injection, you will remember what I am saying. And the cost involved, 1.5 ml dose is some 3 or 4,000. Your 5 ml means you are going to spend 40,000. That is why Dr. Kasi said, for medicos, it is good to show seroconversion after the vaccine if possible, because then you know that you are definitely protected.
How many of you all have had your titers done? Miserable. I think tomorrow go and get your titers done, and if it is low, please take the vaccine.
Okay, we have the last 5 minutes. If there are any questions from the audience, otherwise I will continue. We can take 1 or 2 from the structure that we have. Okay, we continue, Dr. Kasi. So I will ask you this question. Now the booster, 16 to 18-year-old booster, for the 16 to 18-year booster and the subsequent, like they say every 10 years you should keep on taking. Should you take Tdap or TD because the cost is different?
Well, you can give either, but Tdap is more expensive. As far as diphtheria and tetanus, there is no difference whether you give Tdap or TD. Now, is there any benefit of giving repeated dose of Pertussis? Please remember, Pertussis duration of protection becomes less and less with every dose that you give after the first decade of life.
Absolutely.
Giving Pertussis vaccine to older individuals is not going to alter the epidemiology of the disease. You are also creating a situation where the person is protected. If he gets infected, he is protected, but he is going to transmit the virus silently, and he may in fact be a threat to the community. So from all these points of view, there is no actual benefit of giving Tdap over TD. But if you opt to give Tdap, it is safe.
Yeah.
Data has shown that it is safe. The choice is yours, but there is no benefit of Tdap over TD.
In fact, the efficacy of Tdap against Pertussis has been studied in several studies, and it has shown that the efficacy remains up to 3 to 4 years only. After that, it becomes 0. So from that point of view, and Pertussis in adult is not severe disease. It's just little cough for 15 days. So I think if someone cannot afford, don't push Tdap, you can give TD.
Okay, Nitin.
Yes.
Late one evening, a colleague calls you up. He's frantic. He has given the chickenpox vaccine to a child with nephrotic syndrome who is on MMF.
Oh.
And we all know MMF is more immunosuppressive than steroids.
Yes. Well, and there is no safe dose.
What is the risk? Now, he has recently been started, so
Correct.
obviously he's on a high dose
Correct.
only. Now, what is the risk that this virus will multiply and cause disseminated disease in that immunocompromised child?
Correct.
What will you do in this situation?
Correct. So, first of all, varicella, wild varicella is more dangerous in this situation because the mortality can be as high as 20 to 40%. We know even a neonate exposed to mother in the first 5 days of life, the mortality can be as high as 10%. In malignancy patient, it has been shown to be as high as 20 to 40%. So, wild varicella is extremely dangerous in immunocompromised hosts like this. But even a vaccine virus, though attenuated, will multiply and can lead to disease in these children, which will not be as severe, so Dr. Kasi, like the wild disease. But you don't want to have that type of disease. So it is not a good idea to give vaccine in this manner, a live vaccine to a child who is immunocompromised. So either on steroids or on MMF. And for MMF, there is no safe dose. Till the time MMF is on, you can't use any live vaccine. So you can see on the left hand side the mortality with wild varicella, and the right hand side what are the chances of developing varicella, though not mortality, lot of morbidity. So what will you do now? Now you have inadvertently given it. So what will you do? You will give him acyclovir. But when will you give it? Not immediately. With the replication of the vaccine virus will be maximum after day 6, day 7. So you will start acyclovir as a prophylaxis on day 7 onwards and give your complete course. If it's a very severely sick immunocompromised host, give IV acyclovir, but most of the time we are able to give oral acyclovir. And in spite of all that, if the child develops varicella-like disease, then again there is a chances that he may develop a primary vessel pneumonia. So you will definitely admit him and give him IV acyclovir because you cannot afford to now give oral acyclovir as you had done during the prophylaxis. Now there was a study done in leukemic children. And you know, those who are practicing chemotherapy, leukemia child develop varicella is a hell. I mean, it's a nightmare for an oncologist. Fortunately, now we get children who have taken varicella vaccine, but in past that was the problem. So there was a study done of giving varicella vaccine, but not during induction, during the maintenance phase. And there you stop chemotherapy for 1 week before and 1 week after. And still, 40% of children you should develop varicella-like lesion, which had to be aborted by acyclovir. So, you know, it's not a good thing. So, you should check, is your child healthy, is the child on any drug, any long-term drug, all the checklist you should do before giving any live vaccine to a child, and then you will not have this mishap happening. Especially if he has nephrotic, you would have known that he is going to be on some immunosuppressed.
How can you prevent such an error?
So,
are there some steps?
Yeah, so checklist. I mean, so 5 questions to be asked. How is your child today? So if he has got acute febrile illness, you postpone for 2-3 days. Has your child received any vaccine the past 4 weeks? Then you cannot give live vaccine if he has received a live vaccine within the last 4 weeks. Has your child been hospitalized any time in the past 1 year, which would tell you that there could have been something wrong, like this child having nephrotic syndrome? Is your child on regular medication, like someone is on salicylate, you can't use certain vaccine, and so also any live vaccine immunocompromised? And has your child had any reaction with the previous? Suppose child had an anaphylactoid reaction with first dose of hepatitis B, and you give it now next time without having all precaution, it's a crime. No one can then abuse. So I think this type of checklist is must, not only for the nephrotic syndrome mishap, for every vaccine you do in your practice.
Okay, so the last message, pre-vaccination checklist before each and every vaccine for each and every child. We have run out of time. Thanks Dr. Nitin, and thanks for the wonderful audience.
Thanks Dr. Kasi.
Thank you both Dr. Kashi and Dr. Nitin.
So I always say Dr. Kasi is my vaccine guru. And every time I share dais with him, I learn something from him, and I really have more admiration for him than ever before. Thank you.
Please take 10 questions. No questions. We are running 15 minutes late. Question. So please, you take. So we are coming down. Coming down.
Sir, one question. Our child get vaccine, hepatitis B vaccine at birth at 6 weeks, 10 weeks and 14 weeks. This child may be a doctor in future. When he intern, he contact with the hepatitis B patient. Now, everywhere titer not possible. No, not possible, not available.
NTH, SBG titers are easily available. Yeah, you have to do it. You have spent lakhs of rupees on his study, sir. Please spend 100 rupees on his titer.
So, before going to the next session, I'd like to declare the prizes of the morning competition we had, nephrology. So, our participants who have not won the prize will get rupees 1000 each. Dr. Sahiti and Dr. Shagota. And the third prize goes to Dr. Shreya Mishra. Second prize goes to Dr. Ritodip from ICH, and the first prize goes to Dr. Ujan from Apollo. So please collect your prizes. So now we come to the next part, vaccine, mythbuster decoding PCV realities in Indian healthcare.
So thank you Dr. Kundu. Before I start my short talk, I would like to request all of you, we have our delegates group for the CME. Please do not exit from the group. After today's CME, we plan to convert this group into an ICH inquiry group, so that if you have any query regarding ICH, OPD or investigations, you can put your query in the group and we will try to address it, because sometimes you feel that you want some information on ICH. So please do not exit. We will keep this group just for ICH related inquiry and no good morning, good night or happy birthday wishes. So thank you so much. So with this I move on to a very interesting part in the vaccinology nowadays, the PCV. Well, we have the choice of plenty. So many PCVs. So let us burst the myth, decoding the realities of PCV in Indian healthcare. You all are aware there are about 100 serotypes of pneumococcus and each serotype is unique. The antibody one serotype will not recognize another serotype. It's so specific, and that's why in PCV each of the serotype specific vaccine is a unique vaccine and they are combined to deliver a PCV in totality. There are over 100 serotypes, but the role in their disease is not equal, and we are fortunate for that. There are about 20 or 25 serotypes which are more lethal than the others, and that's how the PCVs are selected. Some serotypes are critical for pneumococcal disease, 4, 6B, 9V, 14A, 14, 18C and others, as you know. Initially the PCV7 was developed. Following the footsteps of PCV7, after judging the serotype prevalence, it was upgraded to PCV13 with 6 additional serotypes that were significant contributors to the pneumococcal disease. That's how PCV has evolved from 7 to 13 and now to 20. Though 20 is beyond the scope of today's discussion, but now 20 is available for adults only. The 13 serotypes of PCV were chosen meticulously keeping in mind some of the clinical conditions and pneumococcal disease manifestations like invasive pneumococcal disease, pneumonia, otitis media, mortality, and also, of course, antibiotic resistance. So different serotypes contributed to some of the conditions. Now seeing the current PCV landscape of India, excluding the PCV20, which is still not for children, it's only for 18 and above. Above 15, it's for above 50, it's for all, and 18 to 49 is for high risk adults. So we have the PCV13, which is CRM 197 conjugate. Then we have the old PCV, the new PCV10, the new PCV10, the PCV14 and also PCV13 with TT as the conjugate. So this is the graphical representation of the landscape. So if you summarize, The old PCV10 lacks 3, 6A, 19A. The new PCV10 lacks 3, 4, 18C. So both the old and new PCV10 lacks 3. PCV14 lacks 6A, but it has included 22F and 33F. That we will come. Then the conjugation technology is different between the two PCVs. So the available PCVs are different in more ways than just the number of serotypes. We have to look a bit deep into it. So there are some myths around PCV. How to select? Now one myth is that 6B provides adequate cross protection against 6A, and the cross protection is equal to direct protection. See, serotype 6A is responsible for 1/6 of the overall pneumococcal burden in Indian population. That was detected and declared long back, and that's why the Purple Book also mentions that serotype 6A is one of the top five most common serotypes in Indian children below 5 years with invasive pneumococcal disease. So can we ignore such a serotype? Is it wise to choose a PCV that does not contain serotype 6A and ignore 1/6 of the overall pneumococcal disease burden? And 6A is responsible for invasive disease, high mortality, acute otitis media, also antibiotic resistance. If we see the vaccine effectiveness, if we compare vaccine effectiveness, the PCV13 contains 6A. The effectiveness is around 92%. The PCV7 did not contain 6A, so effectiveness was 32% around. The older PCV10 also did not contain 6A, it was less than 10%. So you see the reflection of direct and indirect protection. And if we see this study, here you can see the direct protection obviously provides higher immunogenicity versus cross protection. Here you see the primary series, 1 month post-primary, the post-booster, and there if you see, it is the IgA geometric mean titer, and you can see the older PCV10 without 6A and the PCV13 with 6A, you can see the booster effect. That's the second year booster. So that's why the Purple Book definitely says that direct protection against serotype 6A is definitely superior to cross protection. 22F and 33F are more important than serotype 6A. Well, if we see the pneumococcal burden of pneumococcal disease due to serotype 22F and 33F, here you can see this is the collation of all the available studies that we have, right from the Nisarga study, the Balaji, Monohar and all that. If we collate, it is 0.8 and 0.6%, the 22F and 33F. And mind you, we do not have any serotype prevalent study after this. So we are banking on 0.8 and 0.4. Vis-a-vis 6A was 1/6. And this is the estimated coverage of pneumococcal conjugate vaccine based on the serotype isolated in the various studies that we had. You can see the Vandana, Monoharan, Balasubramanian and all studies. And there you see PCV13 definitely has a better coverage than others. Now coming to another point, that are all PCV13 vaccines same? Well, let us discuss. So let us discuss on few headings. First, the approved indication and approved age group. If we see the product insert of the available vaccines, the PCV13 with CRM conjugate, it is mentioned for IPD, pneumonia, otitis media, nasopharyngeal carriage, and it is approved for all age groups. If you compare it with others, the India level, you can see the difference. So this is as per the product insert of the available vaccines, the specificity and the indications. Now, PCV30 is the first and only conjugate vaccine approved for all age groups. All the other vaccines are definitely, all vaccines are approved for infant toddler age group, only PCV13 and older PCV10. Rest are not recommended for toddler, catch-up, adolescent or adults. This is what we have as of now, the data on table. Let us not go with which will be approved, which are in the process, and which we are expecting in the next month or something like that. This is what we have as of now. So let us talk for carrier protein. Now CRM197, the process is by reductive amination, whereas the TT conjugation is by activation and derivation. These are very core of the vaccinology. We do not know much about it, but what we know that when the carrier protein, it attaches to the epitope and anchor, the proteins attach and the polysaccharides of the vaccines, so which forms the major histocompatibility complex. That is why it's T cell dependent and it activates the B cell. And there is this carrier-induced epitope suppression. Here you see, when is the CRM conjugate, when PCV is co-administered with the hexavalent vaccine, it does not compete at the epitope level, but the hexavalent vaccines contain TT, these are TT conjugated, so there is competition at the epitope level, and that results in the carrier-induced epitope suppression. So this is a concept, the pre-immunization or simultaneous immunization with a conjugate vaccine and its protein carrier in certain cases suppress the antibody induction, reducing vaccine effectiveness, and this is the science behind it. So if the CRM197 containing PCV13, if it's co-administered, then the competition will not be there. And this shows that PCV13 CRM conjugate did not interfere with immune responses when concomitantly administered with the hexavalent vaccine, and the non-inferiority was confirmed. If we see the OPA analysis comparing the two PCVs, here you can see, except serotype 14, the CRM conjugate is definitely much higher. If we take it as the 100, then the TT conjugate is around 50 or 60 only. This is the OPA GMT measured 28 days after primary immunization series, were numerically higher for most of the serotypes that we can see from this chart. And PCV13 CRM conjugate is definitely approved for 3+1 schedule as the booster in the second year of life, where the other doesn't have as of now. WHO pre-qualification is another plus point for the CRM conjugate vaccine. Next, if we look into the real world data, for the CRM conjugate PCV13, there is significant reduction in nasopharyngeal carriage, reduction in IPD and acute otitis media caused by antibiotic resistant strains. The references are there, and the real world effectiveness as the significant impact on pneumococcal disease through effectiveness has been found, which is yet to be established with the TT conjugate vaccine. Coming to the serotype 3, which is considered an atypical serotype, and none of the PCVs provide effectiveness against serotype 3. Again, it's like that naughty child in the class. If you just consider the child naughty and throw him out of the class, he will not learn anything. Rather, if you include him in the class, at least with his short attention span, he can learn some. So here you can see it is the vaccine effectiveness is 51% with the serotype 3, which you also cannot just ignore. If it's not there, then this much coverage will also be not there. 4 and 18C are often told it's clinically non-significant and non-important. This is right from the beginning. The most common serotypes causing IPD in children less than 5 years of age prior to PCV introduction globally Here you can see the presence of 18C and 4, and that was one of the constituents of PCV7 also. So it has been there, and that's why it has been included in most of the vaccines. An ideal PCV should provide against IPD only. That's what we are more concerned. But pneumococcus is always not an invasive disease. Some are invasive, causing bacteremia, meningitis, and sometimes bacteremic pneumonia, but mostly it's by mucosal spread, where it causes upper respiratory infection, otitis media, and non-bacteremic pneumonia. So IPD is not the only concern. See, the IPD, the mortality is more, the disease severity is more, but it's at the peak of the pyramid, the base and the middle part, which is larger than the top, is the pneumococcal pneumococcal disease. So that also we have to take care. And PCV13 definitely offers protection against pneumonia, otitis media, and nasopharyngeal carriage that we have already discussed. And nasopharyngeal carriage, if we think is not a priority of PCD, then that's again a myth, because nasopharyngeal carriage precedes invasive disease. It's a major reservoir and it gets easily transmitted. It helps in transmission. And to prevent the nasopharyngeal carriage, it requires a higher level of antibodies, because it's the mucosal secretion that's more important. The 3 levels of protection against PCV13 is demonstrated here. 1 is the circulating antibodies, 2 is the circulating or submucosal antibodies, then it comes to the exposure level where it causes less disease. So it's the 3-level protection, and that's why the vaccination schedule for private practice, as we know, the primary is 6, 10, 14 with a booster at 12 to 15 months, and as the age progresses, the number of doses decrease, and that's what we are well versed with. So the key takeaways, we have discussed serotype 6A responsible for 1/6, serotypes 22F and 33F, well, we have already discussed the myth. Serotype 3 we cannot ignore. 4 and 18C are outbreak serotypes. Pediatric pneumococcal infections vary in incidence and severity, and PCV13 is found to be effective in preventing nasopharyngeal carriage, thus imparts a herd effect. So, when you choose PCV, choose wisely. Thank you.
Oh, thank you, Joydeep. So now after all the vaccines, we will come to another topic, gut microbiome imbalance due to antibiotic exposure, Dr. Renal Bhattacharya. And I request the winners of the morning to go to the memento corner and collect their prize. Memento corner, please. নামটা বলে দিও আরেকবার। Dr. Shagota, Dr. Ujan, Dr. Shreyas, Dr. Ritodip and Dr. Saita. Please go to the memento corner and collect your prizes.
Good afternoon. I'm thankful to Sanofi Opella for this talk. Today's talk is gut microbiome imbalance due to antibiotic exposure, mechanisms and solutions. Can we go without any antibiotic today? The answer is simply no. So let's start with a real case scenario. A 4-year-old boy presented to a pediatric clinic with diarrhea. The chief complaints being 3 to 4 soft or liquid stools, nausea, bloating, loss of appetite, fatigue and difficulty in concentrating. That boy had a significant history of acute rhinosinusitis, and he received 10 days ago a course of cephalosporin at pediatric OPD. So this is a significant history. Now before going into this case, let's discuss what are the consequences of this antibiotic, you may say, use or abuse. The short-term consequences being antibiotic associated diarrhea, the Clostridium difficile associated diarrhea and Helicobacter pylori infection. And the long-term consequences are decreased efficacy of promising anti-cancer immunotherapies, exposure to antibiotics in childhood, they have been found to result in obesity, allergy and asthma in the later age group. So the first 1000 days, the golden days, the newborn is immunologically naive, immunologically incompetent, so they are more prone to get infected and they are more prone to get antibiotic, whether indicated or not indicated. So those antibiotic exposure can cause negative effects on microbiota and immune system of infants, and that alters the microbial composition and decreases the diversity and the metabolic activities, leading to exacerbation of the dysbiosis of the gut. Now, all of us will agree that repeated exposure to antibiotics in infancy increases maximum risk of almost all of the following, that is asthma, obesity and allergy. Now, to enumerate that what are the long-term and short-term impact due to the antibiotic overuse or misuse, we can enlist a number of conditions, be it recurrent infections, allergy, diarrhea, colitis, asthma, cognitive weakening, cardiovascular diseases, inflammatory bowel disease, liver disease, type 2 diabetes, obesity, whatnot. So there are array of disorders that has been created by this antibiotic use and abuse, or rather misuse. Now the organisms which are responsible for this antibiotic associated diarrhea, the topping the list is Clostridium difficile, the Clostridium perfringens, Staphylococcus aureus and Klebsiella oxytosa. And 25% of this antibiotic associated diarrhea is caused by Clostridium difficile. All of you must know that. But the pseudomembranous colitis caused by this Clostridium difficile is common cause of acute this antibiotic associated diarrhea, and you know that is a dreaded complication of this antibiotic abuse. Now this is a meta-analysis which shows the prevalence of antibiotic associated diarrhea. If we go for the children, it is 11% in the OPD basis and 21% for the inpatients. In adults it varies widely from 5 to 70%, and for hospitalized patients it is almost 10%. And the organisms we have already discussed. Now, recognizing the signs and symptoms of gut dysbiosis, it is not only restricted to the gastrointestinal symptoms, there are certain extra gastrointestinal symptoms also. So the gastrointestinal symptoms are on your left hand side, that is diarrhea, bloating, bad breath, fatigue, constipation and nausea. And the extra-intestinal manifestations can be in the form of chest pain, vaginal or rectal itching, cognitive weakening such as depression, anxiety and having difficulty in thinking or concentrating, and of course weakened immune system. You name any antibiotic, they can cause gut dysbiosis. The mechanism being may be the different, but the different groups of antibiotics starting from penicillin, cephalosporin, macrolide, this quinolones, carbapenems, lincomycin, all the antibiotics, they cause gut dysbiosis through different mechanisms. Now, how they cause this gut dysbiosis? There are three natural protective mechanisms of the gut that protects the antibiotic to be, or any other foreign body to be invaded into the gastrointestinal system. These are physical barrier, that is the intestinal epithelial cells and their cellular bondage with the tight junctions. The secretory barrier, the mucus and the antimicrobial peptides, and of course the immunological barriers, that is the different types of immune cells and the biomolecules that protect the gut. So these three mechanisms, they get altered with the antibiotic in different ways by different antibiotics. Now, if we go by this first 1000 golden days, whenever mother is taking antibiotic, that is also causing harm. Don't go into the detail of this, but the bottom line is that the good bacteria of the newborn gut is being replaced by a relatively pathological bacteria in the form of this Clostridia enterobacteriaceae instead of this Bacteroides and Bifidobacterium. So this is a basic mechanism by which the gut dysbiosis occurs in a newborn. And if we give antibiotic to an infant, the same things happens in different age group. The good bacteria being replaced by the bad bacteria in a short term, so that the gut environment or there is gut dysbiosis. So how to prevent that? We really cannot think of a day in our practice without any antibiotic, be it ourselves or be it for the patients. I will show a study later. The only solution may be the rational use of antibiotics. So what is the rational use? The confirmed microbial diagnosis, and usually based on the culture with antibiotic sensitivity. So if one is suspecting bacterial infection, appropriate sample should be sent for culture and sensitivity, and according to that the antibiotic has to be altered or changed to narrow down the spectrum of antibiotic. You can escalate or de-escalate. You know the meaning of escalation, that is selecting the appropriate antibiotic and going for that. And the de-escalation is that the taking off the antibiotic which is not required according to the antibiotic sensitivity. So that is de-escalation. And it has been found that benefits of de-escalation decreases the antibiotic related adverse effects that I have mentioned, cost savings, and the multi-drug organisms in the hospital environment are reduced. It has been proved. So the treatment outcomes are known inferior than the continuing on the previous therapy. So how does this reintroducing friendly microbial species probiotics help in the gut? It modulates the mucosal immune system, benefits the well-being. It competes with the existing pathogenic bacteria in the gut. A balanced microbia senses and overtakes the occurrence and opportunist and pathogenic strains, provides protection from onset of dysbiosis and several health issues, manipulates functioning of the gut-brain axis. You know that gut-brain axis is an important hypothesis which reduces the inflammation of the gut and improves health, is useful in infection control, disease treatment and management. So coming back to our case, the patient was advised following treatment, he was having gastroenteritis. ORS, zinc probiotic in the form of Bacillus clausii was given. Mother was advised to give normal semi-solid diet, and patient's mother was advised to follow up after 5 days. Again coming into the discussion. So if you go to right side, the probiotics are dietary supplements with live microorganisms that have health benefits. So how they act? They regulate the immune response by stimulating immune cells. They compete with the pathogens for nutrients, prevent their proliferation. They stimulate release of antimicrobial substance such as mucin, that is the chemicals that has been secreted by the gut, and prevent adherence of pathogens to the epithelial barrier, and alleviate gut dysbiosis and antibiotic associated side effects such as diarrhea. So basically there are 4 mechanisms, that is the regulation of immune, compete with the that is the competitive inhibition of the pathogenic bacteria, and stimulation of the antimicrobial substance, and alleviating the gut dysbiosis. So use of probiotics in children scenario to treat diarrhea in children. On your right hand side there is a startling fact that almost in majority of children 85.6% antimicrobial therapy is empirical. Probably we cannot help that because we are practicing in such a situation that it might not be possible for sending culture and sensitivity every now and then. So we have to give antibiotic empirically, and there are certain unknown pressure, unseen pressure for which we have to start antibiotic. But it is almost 85.6% of the antimicrobial that has been started empirically, and that can cause havoc. acute diarrhea is a leading cause of infant and child mortality. So there are different studies that has been done in the eastern India. Coming back to the case, on the 5th day there is reduction in loose stools from 3 to 4 episodes to 1 episode per day. Vomiting stopped, reduction of abdominal pain and improvement in appetite. On 2nd following up, no episodes of loose stools, no abdominal pain on day 10 and appetite improved. The patient showed improvement. So we can agree that probably the probiotic in the form of Bacillus clausii has some effect or a profound effect in managing the dysbiosis in pediatric diarrhea that has been induced by antibiotics. So let's quickly go through some studies. So the recommendation is co-administration of probiotics may be considered for the prevention of antibiotic associated diarrhea along with antibiotics. Yes, there are studies that if we administer the antibiotics plus Bacillus subtilis, there is lesser number of diarrhea and aphthous ulcer and abdominal pain, definitely. Another study that shows that Bacillus clausii can be used as co-adjuvant treatment for the eradication of Helicobacter pylori. You know that multiple antibiotics are needed to treat the Helicobacter pylori infection, and that can cause severe gastrointestinal problem. So probably this probiotic in the form of Bacillus clausii can be used to prevent the gut dysbiosis and diarrhea. Another study shows that the dose should be adequate. It should be, probiotic dose should be more than equal to 5 billion colony forming units of probiotics per day. Lesser amount of this probiotic won't work. So Bacillus clausii shows better tolerability to multiple antibiotic treatment when compared with placebo, and treatment with Bacillus clausii reduces the incidence of most common side effects related to anti-H. pylori antibiotic therapy. So the Bacillus clausii is a spore-forming gram-positive probiotic bacterium, may be considered for prevention of antibiotic-associated diarrhea. As it is spore-forming, it has some advantage in the form of it is heat stability, can be transported and stored at room temperature, resistant to acidic conditions, and it's able to colonize in the gut. And one interesting thing that Bacillus clausii shows intrinsic resistance to the commonly used antibiotic. It shows acquired resistance to tetracycline and chloramphenicol, and it is resistant to chromosomal mutation to rifampicin. So in a way, we are using antibiotic along with this probiotic, and this probiotic is resistant to those antibiotics so that they will be able to act better. So to summarize, antibiotics can alter the composition and diversity of gut microbes in neonates, children, adults, and may result in antibiotic-associated diarrhea. Disruption of gut microbiota and host immunity in early life can lead to the development of immune-mediated and metabolic diseases. Neonates, obese children with allergic rhinitis and recurrent infections comprise the vulnerable populations for antibiotic-associated diarrhea. Short-term effects of antibiotic use lasting few weeks to months include antibiotic-associated diarrhea, H. pylori, and Clostridium difficile-associated diarrhea. And the long-term consequences I have already mentioned. Probiotics are promising in preventing and restoring the equilibrium, and Bacillus clausii is the most popular probiotic species that can modify gut microflora and is quite effective in antibiotic-associated dysbiosis. So thank you, and please avoid antibiotic abuse. Thank you.
Thank you, Oranalok. So now I call upon Dr. Debulina Dasgupta. He will be talking on CCRT in nephrology. Oh, Julia. Oranalok, your memento.
Okay, so a very good afternoon to everybody. I'll be speaking about continuous renal replacement therapy, or what is better called nowadays as continuous kidney replacement therapy. So right at the onset, I would like to speak why exactly is CKRT at all necessary. So for that we need to understand that the AKI burden in critically ill children is quite significant. It has been found in various studies that nearly 25% of children admitted in the PICU and 30% of neonates admitted in the NICU, they can develop AKI. And it has been found that nearly 6% of these children will require some form of kidney replacement therapy. So what are the various indications? In a child with AKI, you may need to go for a KRT if the child is having life-threatening refractory electrolyte disturbance, metabolic acidosis, any significant fluid overload or some uremic complication. Even in the absence of AKI, you may have to go for KRT for removal of cytokines in case of children with sepsis with MODS, for removal of toxic metabolites in various inborn errors of metabolism, for removal of liver toxins in acute liver failure, and also in conditions like intoxications, tumor lysis syndrome, etc. So how exactly does CKRT prove to be advantageous over other types of kidney replacement therapy? It is a modality which is done very gently over an extended period of time of at least 24 hours in a day. It has got the most accurate control over fluid removal, and it also removes the solutes in a very gentle manner. So because of this, it is the, and that's why because of this it proves to be the modality which is the most hemodynamically well tolerated, and that's why it's the modality of choice in children who have hemodynamic instability and raised intracranial pressure. Also in case of neonates, it may be the only other modality available, especially in cases where peritoneal dialysis is contraindicated. But continuous kidney replacement therapy has its own disadvantages. It has many technical challenges because it needs specialized machine-trained manpower, and also since it's an extracorporeal therapy that runs over an extended period of time, you will have to anticoagulate. So now let's see how exactly does CKRT work. So continuous kidney replacement therapy combines various mechanisms, one of which is diffusion, which is nothing but movement of solutes from a region of higher to lower concentration. So coming to the, in case of CKRT, what happens, this membrane is actually provided by the dialyzer membrane, and small solutes like urea, sodium, potassium, creatinine, etc., they make their way from the blood into the dialysate across the dialyzer membrane along the concentration gradient. Another mechanism is ultrafiltration. Ultrafiltration is nothing but the removal of fluid along the pressure gradient. So in case of CKRT, excess water from the patient's blood gets removed across the dialyzer membrane into the dialysate compartment, driven by the hydrostatic pressure difference between the two compartments. And another mechanism is convection. So what happens whenever the fluid is getting removed by ultrafiltration, it will drag along with it the solutes which are dissolved in it, and the removal of solute in this manner is known as convection. There is another mechanism called adsorption, which can help in removal of cytokines. So cytokines are actually positively charged, and if we use dialyzer membranes like AN69 membranes which are negatively charged, they will help to electrostatically bind to these cytokines and thereby remove them. So it's important to remember that small molecules like urea, potassium, sodium, phosphorus, etc., they are removed equally well by both diffusion and convection. Whereas middle molecules like uric acid, they are removed better by convection than by diffusion, and large molecules like cytokines, they are predominantly removed by adsorption and to a lesser extent by convection. Now by combining one or more of these mechanisms, we derive the various modalities of CKRT. So what exactly does the CVV stand for? It stands for continuous veno-venous. So initially it used to be arteriovenous, where the flow through the circuit used to be mediated by the patient's own mean arterial pressure, but that can be disadvantageous in children who have hemodynamic instability. So instead people came up with this innovation where they have fitted a blood pump into the circuit, and that helps in creating the flow across the circuit. So that's why it is continuous veno-venous, because you can just do with one catheter put inside the in a large vein, and you can derive the blood from a vein, purify it and give it back to the vein. So that's why it's CVV, continuous veno-venous. Now it's continuous veno-venous hemodialysis if it works predominantly by diffusion. So that is helpful in removal of small molecules like ammonia in case of inborn errors of metabolism. It can be CVV-HTF, which is hemodiafiltration. So that combines diffusion and convection and is helpful in conditions where you need to remove both small and middle molecules like acute kidney injury and acute liver failure. The other one is CVV-H. So this is continuous veno-venous hemofiltration, where this will also help to remove middle molecules and small molecules, but the middle molecule removal will be better than in CVV-HTF. So this is helpful in acute liver failure and sepsis. And the other modality is cuff. It is slow continuous ultrafiltration. So here you remove only fluid. So it is helpful in conditions where you need to remove extra water accumulated inside the patient's body. For example, a child with nephrotic syndrome with refractory edema, or a child with CCF who is proving to be diuretic refractory. So what are the things that you need? You need a good machine, you need the filter, you need the solutions with which the exchange will occur between the fluid and the blood. You also need an anticoagulation. As I already told, it's an extracorporeal therapy where the blood has to come out of the body, go through those tubing, so it has every chance to coagulate, so you need to give an anticoagulation. Now it can either be systemic, like unfractionated heparin, where the patient also gets anticoagulated, or it can be regional, where only the blood present in the circuit remains anticoagulated without affecting the patient. So that can be done with regional citrate anticoagulation, where once the blood comes out of the patient's body, you inject citrate, the citrate chelates the calcium, thereby deranging the coagulation cascade. The blood runs through the circuit. Now before going back into the patient, we infuse back calcium, thereby restoring the calcium content and also restoring the coagulation cascade. You need a very good vascular access. It has to be large enough so that it offers the least resistance, thereby providing optimum blood flow, but at the same time not that large enough that more than 50% of the vein gets occupied, because that can predispose to thrombosis. And you also need a blood warmer, because otherwise the patient will end up in hypothermia. Most of the current generation machines have an integrated blood warmer in them. So what are the various complications which can happen? There can be fluid electrolyte imbalances, very frequently encountered. There can be hypothermia if the blood warmer is not working. There can be anticoagulation related complications. If you end up giving less anticoagulation, it will cause circuit clot, blood loss, thromboembolism. If you end up giving more anticoagulation, it can result in bleeding manifestations of the child. And there are some complications which are specific to the type of anticoagulation that you are using. For example, heparin-induced thrombocytopenia in heparin. In case of regional citrate anticoagulation, various kinds of metabolic complications like hypocalcemia, metabolic alkalosis, etc. can happen. Another one is vascular access related complication. Very common is catheter associated bloodstream infection. Membrane reactions can happen, especially if it's an AN69 membrane. It comes in contact with the blood, especially acidotic blood, that triggers the breakdown of mast cells and releases bradykinin, thereby giving rise to bradykinin release syndrome. It's a frequently encountered cause if hypotension occurs soon after starting CKRT. And also it can result in removal of excess of nutrients and drugs. So you may have to give extra protein, you may have to account for the CKRT removal of the drugs and thereby dose the drugs accordingly. So now let's come to a case. We encountered this child, 8-year-old female child, a few months back. The child had presented with overlap syndrome with systemic capillary leak, rhabdomyolysis, myoglobinuria, multi-organ dysfunction syndrome and AKI. The child developed hemodynamic instability requiring high inotropic support and also developed significant fluid overload, 20% fluid overload with pulmonary edema. So we decided to go on for CKRT because the child is having fluid overload along with hemodynamic instability. So this was this unfortunate child. So we secured a left femoral vascular access. We initially started CKRT with unfractionated heparin for the first 5 days. Within the first 48 hours, unfortunately, one circuit already underwent clotting and we had to change and restart with a new circuit. But after 5 days, the child started having thrombocytopenia. We considered heparin-induced thrombocytopenia to be a possibility. Also then the child started having hemodynamic worsening due to cytokine storm. That's why we decided to switch the filters from conventional CKRT filter to odysseys. So odysseys are actually filters which can absorb large amount of cytokines, and that's why they have been proven to be helpful in children with cytokine storm. They can also absorb myoglobin, helping in cases with rhabdomyolysis also. So at this point of time, there was a lot of financial problem because odysseys is 3 times as costly as a normal CKRT filter. And we arranged funds from somewhere and we started this odysseys with regional citrate anticoagulation, and we could run it for 6 days. During this span of 6 days, we found that the child gradually improved. Excess fluid was removed, hemodynamics improved, cytokine storm improved, obviously because of the odysseys and also because of the aggressive immunosuppression. So the only complications that we faced during this time was the initial hemodynamic worsening and also significant hypophosphatemia, hypokalemia, which we could correct by giving IV potassium phosphate. So finally, the child was weaned off from CKRT after 11 days, but she continues to be dialysis dependent for another 1 month. So this was the first child in whom we did RCA, probably the first RCA in Eastern India. And this is two technician, dialysis technician, Dada from our team who formed the backbone of the CKRT program. So I will not go into the outcomes because of the lack of time. Significant hospital mortality rates are there. That is predominantly because of the underlying illness and also the degree of fluid overload. High degree of fluid overload at CKRT initiation is associated with higher mortality. And in the long term, many of these children can develop CKD. So we need to follow them up also. I'll just skip these slides because of lack of time. CKRT in neonates is actually very challenging and you need specialized machines. The machines which are available worldwide, only the Carpe Diem is US FDA approved and it's not yet available in India. So till it is available, we can still go ahead with the normal CKRT machines that we have, the smallest available circuit that can be proved to be fairly safe. The main challenges in low resource settings is mainly the cost, so which is even higher for RCA, and also the need for special infrastructure. So we can overcome this with the help of funding sources and also by periodic training of our medical personnel and with proper clinical and financial policies which can help in better resource allocation. So the take home message, CKRT is the modality of choice and sometimes maybe the only choice in critically ill children who have hemodynamic instability and raised ICP, and that's why it has become a modality which has become indispensable, especially in case of tertiary care referral PICUs. Availability of neonatal machines will widen its applicability in difficult neonates, especially when PD is contraindicated. And although it's labor intensive and costly, it can be sustained even in resource poor settings with proper financial support, with training of manpower and infrastructural strengthening. It is very important to remember that teamwork is the key. So I end my talk here and a very happy Independence Day to everybody.
Thank you, Devalina. Now I call upon Ognimita Girisharkar. We will be giving a short lecture on breastfeeding updates. Devalina, please take your memento from the director.
Good afternoon. Breastfeeding update from ICH. According to WHO, all newborns should receive exclusive breastfeeding till 6 months of age, but only 44% of the mother can achieve this. The causes of delayed and difficult lactation, what are the causes? It can be divided into 3 factors: the environmental, the anatomical and the physiological, or the hormonal, and there is a paradigm shift. Coming to the environmental, we all know that the rooming in is the best. So we recommend to be in the same bed, and now we say to be in skin to skin contact with the support of the medical staffs and the family members. The second problem is the anatomical problem of the baby or that of the mother with nipple abnormalities or skin disease of the nipple. Our series of publication on impact of lactational training and nipple evaluation during pregnancy and in reducing lactational mastitis and breast abscess, and from this it is evident the antenatal training is so important to prevent the hindrances in lactation. The third factor is the hormonal one. Stage 1 lactogenesis, as we all know, occurs under the influence of estrogen and progesterone. And stage 2 lactogenesis occurs following the withdrawal of the placenta with fall in estrogen and progesterone, but with rise in not only prolactin along with insulin and cortisol that stimulates the synthesis of the basic components of milk. Stage 3 lactogenesis occurs under the influence of milk let down reflex. There are several researches for last 2 decades about the role of insulin, and it's controversial whether it can be or it cannot be. I'm not going into the hormonal interplay due to lack of time. So this is a very important reference for our work. Does insulin explain the relationship between maternal obesity and poor lactation outcomes? So what is the pathway of insulin? The insulin has 2 receptors, INSRA, which is active during pregnancy, and INSRB, which is active during lactation. So insulin binds with the INSRA during pregnancy, activates the GTP protein, and through the MAP kinase signaling pathway, it stimulates the cell proliferation. And in case of during lactation, it combines with INSRB receptors, then activates phosphoinositol 3 pathway through AKT pathway, and then through mTOR pathway It helps in milk protein synthesis. So how does the insulin does this? It induces the transcription factors that 5A, EIF5K, 5A, JAK2. So initially there is induction by the insulin, and with the ribosomal subunits it forms a translation initiation complex which helps in milk protein synthesis, and this is followed by action of prolactin, activates the transcription factor by phosphorylating, and then helps in milk synthesis. Even insulin can also follow the other pathways like mTOR or get stimulated by amino acid leucine. So this work is diabetes mellitus and insulin resistance lead to lactation failure was published in European Journal. Another work is obesity and factors of insulin resistance associated with delayed or non-lactation. From this study, we concluded non-lactation or delayed lactation is strongly associated with increased BMI, increased waistline, raised systolic diastolic blood pressure, raised FBS, PPBS, raised glycosylated hemoglobin, and raised serum triglyceride. And all the p-values are significant. So the study confirms the role of insulin on lactogenesis function of mammary glands, and mothers with insulin resistance are more prone to lactational failure. Our further work in metabolic syndrome, insulin resistance, luminal cell function, and its impact on lactogenesis, is obesity and factors of insulin resistance associated with delayed or non-lactation. So to take home, skin-to-skin contact is essential to establish exclusive breastfeeding. Antenatal checkup is a must so that the complications due to anatomical problems can be prevented and lactational hindrance can be also be prevented. The third and the most neglected factor is the insulin resistance. There are several factors of insulin resistance which are responsible for delayed and lactational failure, and these factors are evident from our different studies which are published. If we can detect this during pregnancy or before, we can establish exclusive breastfeeding more successfully. Our work since 2018, and then we are being tweeted at NHS by the largest milk bank of UK, and then our grand round and our presentation of work at Limerick University Hospital, Ireland. Thank you for your patient hearing.
Now I call upon Dr. Somit Ghosh. He will be talking about medical ethics. Ognivita, please collect your memento.
Good afternoon and very happy Independence Day to everyone. Thankful to the Institute of Child Health for this wonderful opportunity and for this annual ritual. So we will be going through some key messages to help us be safe as far as our practice of pediatrics is concerned. So we'll start with the NICU. And the obvious thing that all of us should be aware that whatever we are doing with our neonates or with our children, it has to be with an informed consent. What we must understand is that we must explain things to the parents who are going to be the consent givers in a language that they understand. We are going to face challenges regarding language barriers, lack of understanding, so there may have to be repeated sessions. So please make sure that whatever consent you are taking should be in a language they understand, and if there are barriers in language, speak in the vernacular and make sure that the understanding is clear. This is going to be one of the commonest difficulties faced in the NICU and the PICU, that is end-of-life decisions and withdrawal of care. We all know that sometimes our treatments are going to involve reaching a dead end. And when you are reaching a dead end, it is important to share the decision making with the parents. Mind you, we are not here to dictate anything to the parents. We are here to discuss the options and involve them as equal partners in continuing treatment or putting a stop to the treatment. So there has to be discussions with the families, there has to be involvement of the ethics committees, and whatever are the legal frameworks, we need to be compliant with them. And whatever you talk, please make sure that it is documented so that you are held in good stead should a misunderstanding occur. None of us do this intentionally, but especially in the newborn care, we do know of microdoses, we do know of decimals which shift, and hence we can grossly miscalculate doses. So we have to be very careful of medication errors. Good practices, if you have a team, please get them to cross-check. Don't let your ego dictate dosages. Let there be double, triple checks so that you minimize the chance of errors. You have to be alert, and infection control. This is something which will be completely unpardonable if you do not send your regular cultures, if you do not have antibiotic policies in place, you will not be defensible in a court of law. Please, please do not underplay the importance of documentation and record keeping. Poor documentation is going to lead to implied negligence in the court size. And if you are going to be maintaining electronic records, please make sure that they are secure and they are authentic. So when we are talking about neonates, ensuring the privacy is of paramount importance, because later on when these neonates are going to grow up, they're a very vulnerable population. So we are taking decisions on their behalf, which they can question later when they grow up and they become competent. So make sure whatever decisions are being taken is based on evidence and is based on science. You are going to face parental refusal of treatment. Mind you, there should not be a conflict. The parents are the custodians here, and if there is a conflict, the wish of the parent is going to be paramount and override what you are wanting to do. But if it is being overridden, it has to be documented. We have to be very, very clear when we begin our treatment about the resources and the limitations of the setup which we are working in. And please make sure that that is clarified to the receiver of the care. You shouldn't be caught midstream trying to explain that I cannot manage beyond this and you have to shift the baby to somewhere else. You may be justified in doing so, but if you have not primed your patient right from the beginning, you are going to land up in a difficult situation. Updation of skills, continuing professional education, it is something which is an integral part of our practice. It's very, very important that as pediatricians, we keep our eyes and ears completely open to cases of parental abuse, neglect, or inability to take care. And please remember one thing, it is mandatory to report this. You cannot get away by not reporting anything that you suspect. So from neonates, let's move on now to the general pediatric practice. There will be lots of similarities, but the most important things are the ones which I'll be highlighting today. And the most important is, while the parents or the legal guardians, they will continue to be the primary consent givers, older children and adolescents, that is the 10 to 19-year age group, they may give what we call assent depending on maturity. So, as a pediatrician, you have the ability to determine whether the child can give an assent. And it is always better that assent and consent are married together. The child is taken into confidence about what is being done so that the conviction is higher and the family as a whole can agree to undergo treatment. In general pediatric practice, confidentiality and privacy are generally private, but they have to be shared with parents. Here, let me point out that adolescents may have legal rights to confidentiality in areas like sexual health, substance abuse, or mental health. Now, this is a slightly gray area where you have to be careful that while you protect the child's right to privacy, if there is an episode which is pointing to self-harm, you can break that privacy and bring the appropriate authorities into play. In medical negligence and malpractice in general pediatric practice, I would not elaborate on them because they are roughly the same, but I will re-emphasize the point that medication errors are the commonest. So however confident you are of the doses, please get your team to cross-check the medical errors. Mandatory reporting obligations in cases of child abuse, neglect and exploitation is to be re-emphasized because with the POCSO Act in play, it can invite a penalty if you have overlooked it. So end of life and life-sustaining treatment decisions, there can be disagreements between the medical team and parents. Your communication skills are going to come into play. So you need to bridge these differences with your communication skills. Not everyone will be understanding the medical jargon that you might be talking in. So make sure you speak to them in a language they understand, preferably in the vernacular. Involve the ethics committee if so required, and please document everything that you are discussing. Vaccines, bread and butter. You don't have to have a written consent, but please make sure that you are discussing with them what is the purpose of a vaccination. You must discuss with them that you are not giving them 100% protection, but you are trying to enhance the protection and you are trying to give them a public health immunity along with an individual immunity. There can be parental refusal of vaccines. Once again, however convincing you might sound, the parental consent or disagreement will override if the parent refuses to take a vaccine. Where are the situations where you might have to invoke the law? If there is an outbreak, if it is mandatory for school entry without any exemptions, please refer to the appropriate authorities. Vaccine injuries and compensation, we all know that the adverse events following vaccinations have to be reported. We all have got into the practice of sticking the stickers and signing along with the date. Please maintain that practice because you need to keep a document that you have given a proper vaccination to the child. And do not entertain requests for duplicate vaccination cards which do not have these evidence. Those are the two key messages over here. Off-label or unapproved use will have to be with a mutual discussion. Please make sure that you don't get into a soup because if it is not yet recommended, for example, the HPV vaccine beyond 26 years. So if somebody wants it, insists on it, gives it to you in writing, and you have medical evidence from global literature, you may administer, but make sure you write over there that it is an off-label use. Communication, communication, communication. That is the most important method to overcome vaccine hesitancy. There will be legal requirements for school admission and for travel, so you should be aware of these legal tools and make sure you communicate well with the patients regarding this. In outbreaks, you have to try and convince the patient. If they still don't agree, you can't force it on the patient, but please make sure you are informing the relevant public health authority. Storage, please be very, very sure the population is getting increasingly educated and they will be keeping a very close eye on whether you are maintaining the cold chain. So no compromises there. Reporting adverse events, like I said, AEFI is very, very important. A very, very important question for all pediatricians. Can we vaccinate adults? The short answer is yes. And why can we? Because we are handling adolescents who are turning 18. We are vaccinating parents or caregivers in cocooning strategies. We are handling outbreaks and public health emergencies and in rural and underserved areas also. Adolescent health issues, I have already mentioned that there is a provision for an assent which is not legally binding, but if you can, like I said, marry it with the consent and get both on board, it makes your treatment more convincing. Confidentiality and privacy in adolescence, like I said, sexual health issues, mental health issues, you can maintain the privacy to a certain extent, but if there is self-harm, you have to inform the relative caregivers. Mandatory reporting and safeguarding in suspected abuse, neglect or exploitation. The gray area is going to be consensual sexual activity, but it is still under debate. Reproductive and sexual health care, like I said, there is going to be confidentiality, but you can break the confidentiality in some areas. So I'm just going to skip some of these. In special needs children, there are individualized educational programs. There has to be advocacy by the pediatricians and laws like individual, educational plans or individual treatment plans for the children, and Section 504, which allows for the child to participate in a normal school activity, has to be invoked where feasible. Finally, I'll come to the PICU. Most of the things have been discussed. The only thing over here is that there could be brain death and organ donation. Legal and ethical issues must follow very strict protocols. We must adhere to the brain death criterion and involve trained organ donation coordinators. Thank you so much for your patient hearing. We have a moral duty, an ethical duty to follow the practices and the standards of care. Thank you so much.
Thank you, Shomik. Please collect your memento from Dr. J. Roy. Now we have the best of ICH case presentation by Ladli Singh, Shreya Mishra, Tandrani and Arshia. And Dr. Aniruddha Ghosh. Dr. Aniruddha Ghosh. Come. Come, you sit down here, four of you. আমি আগে এটা দিয়ে দিই আমি ওই এত Come, please come. Sir, only to wait a minute. Let me first give you the Hey, cameraman, আসো। राशिया लाडली का कहाँ है लाडली उधर राशिया श्रेया graduate
So this is the last session of the day. Good afternoon everyone. Today we have a few cases from our last year's diary. So the presenters are our residents who work very hard in this institute. So 4 of them has been selected. Speakers are Dr. Ladli Singh from the Department of Pediatric Surgery, and Dr. Arshia, Dr. Tandrani and Dr. Shreya will be presenting single case each from Pediatric Medicine Department. Thank you.
Constant.
Good evening all. Today I, Dr. Ladli Singh from Surgery Department is here to present the work we do at ICH in surgery. For my first presentation, we have 2 patients, both below 6 months of age. Both came with a complaint of mass coming out per rectum. USG confirmed intussusception, which was long segment, and we had tried hydroreduction, which we failed at. Post which patient was subjected to laparotomy, and we found malrotation along with intussusception, which is a rare entity known as Wu syndrome. For the second one, we have 2 neonates, one admitted with respiratory distress, the second with tracheoesophageal fistula along with tetralogy of Fallot. Both were put on ventilatory support and eventually developed abdominal distension. The X-ray 1 and 3 confirms the pneumoperitoneum, post which patients were put abdominal drain. And we can see in X-ray 2 and 4 how pneumoperitoneum has resolved on its own without any further surgical intervention. Here I would like to say that there are few literatures which suggest that 1 to 3% of pediatric patients who are put on ventilation do develop pneumoperitoneum without any association with viscous perforation. For the third one, we are unmasking the abdomen secret. Case 1, 4-month-old baby boy presenting with diarrhea, left inguinal hernia and umbilical hernia. X-ray on presentation was showing air fluid level, but child was tolerating feed and passing stool. Sepsis screening came out to be negative. X-ray 3 before OT, where we can see how there is a separate jejunal loop which is appreciated. As there was a diagnostic dilemma, a board meeting was put forward and a decision to open the patient and have a look was taken. Intraoperatively, to our surprise, the gut appeared all normal. So we performed an ileostomy, took a biopsy and we came out. But ileostomy remained non-functioning till day 10 post-op. In X-ray 4, we can see how we did a dye study to see if there was any further obstruction, because of which our ileostomy remained unfunctional. But dye was comfortably passing through the ileostomy. Biopsy came out to be suggestive of severe inflammation and no surgical pathology per se. We lost the child sadly, but there was multiple immunodeficiency tests that were done, diagnosing the patient as severe combined immunodeficiency syndrome. In the same series, we have a 2-year, 5-month-old patient which had a complaint of distension of abdomen since 6 months of life. Child was initially treated conservatively and was diagnosed with central hypothyroidism and autoinflammatory syndrome. Child presented to us at the age of 2 years, 5 months with the first X-ray which shows multiple air fluid level. Initially we did conservative management, did a dye study. In barium enema, we can see how the whole of large gut is dilated. There is hold up of dye beyond 24 hours, but there is no such pathology which we can appreciate. Patient was subjected to laparotomy, and we found a transition zone as marked in image 3 with red arrow, which confirmed that there is highly chance of Hirschsprung disease, and it was further confirmed on biopsy by absence of ganglion cell. My purpose of presenting both these cases are to say that no abdominal case can purely be surgical or purely be medical. Both the teams should come forward and discuss these cases, especially the complex ones. For my fifth case, we have a 7-year-old boy that presented to us with increased phallus length since last 2 months, bilateral impalpable testes. We did an hormonal study which showed raised testosterone and beta HCG. MRI whole abdomen was done, which is shown in image 2. The first image shows a right side huge mass, and the second image shows a prosthetic utricle. So the imaging reported to have a right-sided huge mass near the deep ring. My third image is a laparoscopic view of the same mass showing a huge bossulated testis-like structure having vas and vessels. We somehow, giving the look of the image, we knew it was more likely malignant. So we did an orchidectomy on the left side, right side, and left side showed vas and vessels exiting the deep ring. So inguinal exploration was done where we found a nubbin. Nubbin is a atrophied testes. We did not do anything with that. Instead, we left it and we came out, and the biopsy was sent, which was suggestive of gonadoblastoma. My purpose of presenting this case is, again, UDT should not be left untreated beyond 6 months. All the undescended testes do need a surgical treatment. And for my last case, this is an orthopedic case operated by our orthopedic surgeon, Dr. Niloy Kanti Das. 3.5-year-old female presented with preaxial type polydactyly of both feet, congenital holovarus of right side, associated syndactyly of both hands. This is preoperative image 1 and 3, and in postoperative image 2 and 4, we can clearly see the aesthetic and functional correction for the same. With this, I would like to conclude, and thank you all for listening.
Good afternoon everyone. Myself Dr. Shreya Misro, JR1 from ICH. Today I am going to present a case decoding a rare malabsorption syndrome. So 4 years old male child presented to us with chief complaints of easy fatigability, intolerance to spicy food due to burning sensation in the mouth. So we took the dietary history and came to know that he is a non-vegetarian, consumes animal products. Past history at 2.5 years age, he was admitted in ICH with similar complaints of generalized weakness. Family history, now the child has an elder brother who was also diagnosed with, megaloblastic anemia at 4 years of age. Genetic study was not done. He received vitamin B12 injection and oral B12 and was well on follow-up. So on examination of this child, there was pallor, glossitis, angular cheilitis with hyperpigmented knuckles, but there was no evidence of any organomegaly or icterus. So on admission, we did all the relevant investigations, and hemoglobin was low with increased mean corpuscular volume and increased LDH. Ferritin was slightly increased, and iron, TIBC and TSAT were not suggestive of iron deficiency anemia. Peripheral blood smear was done, which revealed normochromic normocytes, few elliptocytes, teardrop cells with myeloid precursors, few nucleated RBCs. There were no evidence of hemolysis from history or clinical examination. Urine routine examination was done and protein was 1+, stool for occult blood test was negative. So serum vitamin B12 assay was done, and the level was excessively high, greater than 2000 picogram per ml, and serum folic acid was greater than 40 nanogram per ml. So thalassemia screening was normal. So detailed past history, because he was also admitted 2.5 years back with the same complaints. So we took the detailed past history and came to realize that then also hemoglobin was decreased, MCV was increased, retic count normal, G6PD and DCT screening was negative. Now serum vitamin B12 was less than 100 picogram per ml, folate was normal. Peripheral blood smear examination was done in the past also, which revealed erythrocytes normochromic with macrocytes and marked anisopoikilocytosis with target cells, teardrop cells and rouleau formation. Bone marrow biopsy was also done, which revealed hypercellular marrow with segmented neutrophils, normochromic macrocytic cells revealing megaloblastic changes. So the differentials that we were considering at this point were pernicious anemia, transcobalamin defect type 2, inflammatory bowel disease to rule the etiological cause of vitamin B12 deficiency, congenital dyserythropoietic anemia. We did a further workup. Autoimmune panel for pernicious anemia was negative as anti-intrinsic factor antibody was normal, celiac screening was negative, serum homocysteine level was normal. So ideally when a child presents to us with features of megaloblastic anemia, vitamin B12 should be low and homocysteine level should be high. But in this case we realized that the serum homocysteine level is normal and vitamin B12 is increased. So when we digged more into the history, we realized that the child has received one dose of injection methylcobalamin before admission, and then because there was positive family history also of vitamin B12 deficiency, we did a clinical exome sequencing which revealed Imerslund-Grasbeck syndrome. It is a very rare malabsorption syndrome with an incidence of 6 in 10 lakh children, and it's an autosomal recessive type of disorder with zygosity is homozygous. So this is the pathway of vitamin B12 absorption, where the pathophysiology is here. The vitamin B12 combines with intrinsic factor, and when before absorption into the intestinal cell, there is a receptor, the cubum receptor. The cubum receptor is composed of cubulin and amnionless 2 subunits. So the defect in the cubum receptor prevents the vitamin B12 and the intrinsic factor complex to get absorbed into the intestinal cell and then subsequently into the bloodstream. This cubulin receptor is also present in the renal tubules, so because there are other receptors of protein absorption in the renal tubules, so it just causes asymptomatic proteinuria. So these are some of the features of vitamin B12 deficiency, where we can see there is cheilitis, there is hyperpigmented knuckles, hypersegmented neutrophils, and also this is the bone marrow aspiration showing the macrocytes. So the treatment if we needed is IV methylcobalamin injection. Oral, it is generally ineffective, but studies have shown that clinical response might be present with very high dose of oral vitamin B12. So lifelong supplementation with vitamin. So the take home message from our case is that if there is positive family history, we should not only symptomatically treat the vitamin B12 deficiency, but definitely dig in more and do a genetic study, because in this we went on to do a genetic study and we realized that the child had IGS, Imerslund-Grasbeck syndrome. So it needs lifelong supplementation with vitamin B12 to prevent the irreversible neurological complications, and if intervened early, these patients show a very good clinical response. Thank you.
Good afternoon, everyone. Today I'm going to present a case of skeletal dysplasia. A 12-year, 2-month-old girl presented with short stature, bilateral elbow swelling and no menarche, had no features suggestive of any chronic systemic disorder. There was no history suggestive of IUGR polyhydramnios antenatally. Birth weight was normal. There was no history of birth asphyxia, and she is developmentally normal. On clinical examination, the height was 132 centimeter, which was well below the mid-parental height range. Weight was 24.2, that was less than 1 percentile. Arm span was 104 centimeter, and upper segment to lower segment ratio was 1:2:1. Vitals were stable. On head to toe examination, there was no microcephaly. There was hypertelorism present. There were prominent eyes and triangular mouth with downturned angles. On plotting the growth charts, we could see that height was less than 3rd percentile, that was indicating stunting. Weight was less than 3rd percentile, which shows wasting. However, the BMI appears to be normal, that was just above the 10th percentile. The other features that were noted were that the short forearms, that is the predominantly upper limb was affected, and the girl attained a puberty Tanner stage 3. Echo and USG whole abdomen was done, which was within normal limits. We did a pedigree chart which showed that the child was born out of a non-consanguineous marriage and the elder brother was not affected. So a full skeletal survey of the patient was done, which showed features like maid-lung anomaly of the forearm. There were broad and short fingers. There was mesomelic shortening of the upper limbs, and clinodactyly was seen in the 5th finger of both hands. Along with that, there was hypoplastic interphalangeal creases. Hemivertebra was noted in the thoracic region. There was also mid-facial hypoplasia and mandibular microagnathism seen. However, the lower limbs were normal. There were no dislocation of hip, and pelvis also appeared normal. So a whole exome sequencing was done, which showed a loss of function of ROR2 gene, and the final diagnosis was Robinow syndrome, autosomal recessive pattern. So currently the child is on oral calcium and vitamin supplements. The girl is leading a completely normal life, but she has menstrual irregularities and faces difficulty while lifting heavy objects. In short, Robinow syndrome, specifically the autosomal recessive form, is caused by loss of function mutation of ROR2 gene. ROR2 is necessary for proper proliferation and function of chondrocytes, which gives rise to the overall skeletal size. The children who are affected by Robinow syndrome are prone to infection. There can be cardiac abnormalities present in them, however they are quite uncommon. There can be endocrinal abnormalities along with genital abnormalities. However, in majority, the intelligence is normal with adequate sexual functioning and reproduction. Thank you.
Good afternoon, everyone. I'm Arshia Islam and I'm going to present a case of refractory infantile seizures. Case scenario: 2-month-old baby girl presented with recurrent unprovoked seizures lasting for about 2 to 4 seconds from first month of life, which was aggravated after she developed fever post vaccination. In the 2nd month, she was brought to ICH, was drowsy on admission. She was born out of consanguineous marriage. Birth history was uneventful. Family history: there was febrile convulsions in maternal grandfather. Her 8-year-old elder brother was healthy. Anthropometry was normal. On investigations, lactate was elevated and there was metabolic acidosis. CSF study and EEG were normal. MRI brain was suggestive of metabolic brain disorder or leukodystrophy. Management: levetiracetam was started but convulsions persisted even after maximizing the dosage. Child was shifted to PICU but convulsions persisted even after adding multiple anti-epileptic drugs, which were phenobarbital, phenytoin and ultimately midazolam infusion. Mitochondrial cocktail was added and panel for inborn errors of metabolism and whole exome sequencing was sent. Convulsions were controlled. Child was started on oral anti-epileptic drugs and shifted to ward. Discharged on pyridoxine, biotin, folinic acid, coenzyme Q, carnitine, levetiracetam and phenobarbital with genetics reports pending. Genetics analysis revealed homozygous mutation in the BTD gene located on exon 2 with autosomal recessive inheritance, pathogenic for biotinidase deficiency. Thereafter, biotinidase enzyme levels were done which were deficient in the baby. Coming to biotinidase deficiency, biotinidase is an enzyme which recycles biotin from diet and endogenous metabolism. It is crucial for activating carboxylases, pyruvate carboxylase, acetyl-CoA carboxylase, etc. for crucial pathways, namely fatty acid synthesis, amino acid metabolism and gluconeogenesis. Therefore, biotinidase deficiency manifests as multiple carboxylase deficiency. And the clinical presentation is seizures, hypotonia, developmental delay or ataxia. Cutaneous manifestations involve skin rash and alopecia. There may be vision and hearing loss as well. The neurological symptoms resolve within hours to days with oral biotin therapy, and the cutaneous manifestations take about a week. Treatment is by lifelong oral biotin supplementation at 5 to 20 mg per day. Raw eggs are to be avoided as the avidin in raw egg binds to biotin. Thoroughly cooked eggs can be eaten as heat inactivates avidin. Prenatal screening and genetic testing for siblings is crucial as there is autosomal recessive inheritance. In this image, we can see there are seborrheic dermatitis like eruptions in a newborn with biotinidase deficiency, which were absent in our case. Discussion. Early identification and treatment of refractory seizures with underlying metabolic cause such as biotinidase deficiency can prevent lifelong complications and major disabilities. Genetics, this case highlights the role of genetics as it plays a pivotal role in diagnosing the underlying causes early on. Vitamin responsive epilepsies, if detected early, can be effectively treated with targeted precision therapy. For example, by pyridoxine in pyridoxine dependent epilepsy, by biotin in biotinidase deficiency, by folate in cerebral folate deficiency, and biotin plus thiamine in biotin and thiamine responsive basal ganglia disease. Now, child is 2 years old on biotin, seizure free, and has achieved age appropriate milestones and is doing well. I'd like to conclude by sharing this video of the child, which is a testament to her recovery and the work that we do. The image and video has been added with consent. Thank you.
August. Yeah. You can have a good photograph for ICH and ex-ICH now, and that's what we do every year, that a group photograph here from ICH and ex-ICH. On the, yeah? ICH and ex-ICH, you can come, and thanks to doesn't matter. ICH patient pathaleo hobe. Suppliers, part of the extended family. Aye, tu aye.
Kurai, Kondrani. Aye, Kurai.
Aye, sabai aye, sabai. না না বসতে হবে না দাঁড়া
Hey, Dr. Anil. Hey, Dr. Singhi. Come.
অনিল কোথায় গেল? আরে দাঁড়া না, দাঁড়িয়ে হবে। অনিল সিংহি কোথায় গেল? অনিল, আরে ইউ আর পার্ট অফ ICH। জিগ্না, আরে না না এটা হোটেল।
এই আরে কোথায় চলে যাচ্ছে অনিলবাবু? হ্যাঁ এখানে এসো, এখানে। জয়দীপ, এই সোমনাথ আয়, পাগড়িটা কোথায়? পাগড়িটা লাগিয়েছো? সোমনাথ এসো। এখন তুই তুলতে আরম্ভ করো, আরো অনেক পড়ে গেল। জয়দীপের একটা পড়বেই, যেখানে যে কোনো কনফারেন্সে চাল খুলে পড়বে, ও সব জায়গায় মাথায় চাল খুলে পড়লো। এদিকে এদিকে চলে আসো, এই সোমনাথ এদিকে এসো, এদিকে এসো, ওই বলছে ওরা আর হাঁটু করে বসতে পারছে না। পারছে না, চলো
ঠিক আছে,
রেডি
হবে হবে। কালকে দেখা যাবে এটা ডিলিট হয়ে গেছে।
এখনই ডাউনলোড হয়। মোবাইলে তোল, মোবাইলে তোল, সবাই গ্রুপে পাঠিয়ে দিবি। এই দাঁড়াও না, কোথায় যাচ্ছ?
সোমনাথ,
তোমার
সামনের বার একটা